on TYK2 inhibitors in immune-mediated inflammatory rheumatic diseases. To chair this session, I've got two distinguished guests. First is Professor Narasimlu, who is past Dean of Indian College of Physicians, former Professor and HOD of Nizam's Institute, Hyderabad, Professor and HOD of ESI Medical College, Hyderabad, past President of IRA, former Editor of JAPI, former President of IACM, a legendary figure in Indian rheumatology. I welcome you, sir. Please take your seat on the dais. Along with Professor Narasimlu, I'll have another distinguished guest, Professor C. Punjab Kes Rajendran, former Professor and HOD, Department of Rheumatology, Madras Medical College, former head SRM Medical College, recipient of the MN Pasi Award in 2011, and currently consultant rheumatologist at Kaveri Hospital, Chennai. I welcome you, sir. I request the chairpersons to introduce the speaker of this plenary session, Dr. Chandrasekhara.
Yeah, thank you, sir. My friends, at the outset, I congratulate Dr. Nagaprabhu, who got trained in the University of Medical Sciences at DNB, one excellent and hardworking student of mine in those days. Still have very sweet memories of him, and highly successful. Fortunately for me, all my students are more successful than me. I am thankful for Almighty for this. Such a wonderful conference. Just I called him on the phone, immediately agreed, and you can see the results, how he had done this, taking whole Tamilnadu with him. And to brief over this session, Dr. Chandrasekhara, I don't think anybody in the hall don't know about him. He's the first citizen of IRA, means president of Indian Rheumatology Association. He's done a DM in Sanjay Gandhi Institute of Medical Sciences way back, and came to Bangalore in 97, 98. And for a brief period, he was in Ramaya Medical College. Then he started Chandray Medical Institute. Often I keep talking to him on various academic organizational issues, and very affectionately takes things. He was multiple positions he has occupied as a Karnataka Rheumatology Association President. Now, President of Indian Rheumatology Association is the highest post. Below that, many posts he occupied. And is old faculty of IRA. He's going to speak on tyrosine type 2 inhibitors in application of rheumatology and new drugs. Dr. Chandrasekhar, my compliments to you for blessing Dr. Nagaprabhu. He is my student and a wonderful man. Thank you for accepting this plenary session. I ask Dr. Rajendran, CP Rajendran, to have few words about you and our topic.
Nothing to talk about the IRA president. He is very good, he is excellent, and everybody will know about him. Today he is going to talk about the tyrosine kinase 2 inhibitor in immune-mediated rheumatic diseases. It's one of the JAK kinases, and it's an intramolecular signaling molecule, and it has had a unique action when you compare with the other JAK kinases, and the drug trials are very encouraging. For example, number of side effects are much less when you compare to the other JAK kinases. Anyhow, he is going to talk in detail about that. Now I request Dr. Chandrasekhara to give this lecture.
Good morning, everyone. Thank you, Chairman, for nice introduction. I think I will move on to today's lecture on type 2 inhibitor. Just before getting into that, let's just refresh the fundamentals of our immune modulators. We have three broad classes of immune modulator. One is what we have used from years, the conventional disease-modifying anti-rheumatic drugs. Then we have biologics. Then we have what we now call as target-specific DMRs. How do they really differ? I mean, it's basically all of them are handling the immune system functioning, and what is the advantage or disadvantage of each of them. See, if you see the conventional disease-modifying antirheumatic drugs, they are little non-specific. They alter the metabolic process of the cells. By altering the metabolic process of the cells, they interfere in the cell functioning. Because of some enzyme specificity of the immune competent cells, they are little more specific and effect more on the immune competent cells. Thereby, they modulate the immune system. So this is what we classically call conventional disease-modifying antirheumatic drugs. Next rationale came from on the biologics. What biologics do is they use a biologic pathway which is other than the signaling pathway. Signaling pathway is also a biologic pathway, but it's intracellular, whereas the biologics use the extracellular signal pathways. Extracellular pathways, either the receptors or the cells, and they use the naturally occurring molecules, either immunoglobulins, receptors, or any of those protein molecules, interfere in a defined biologic pathways. And when it comes to the next one, the today's topic of type 2, the first one is the JAK inhibitors. These are called target-specific antibodies. These, if you see, interfere in the secondary signal pathway from the receptors to the nuclear cells. The transition of the secondary signal pathways is something what these molecules targets. So one of them, what we really learned about is the JAK-STAT pathways. In the JAK-STAT pathways, we have JAK. There are 3 of the JAK, followed by type 2. These are all tyrosine kinases. What they really do is, once the molecule interact with the surface receptors, interact with its ligands, there is a steric change which occurs in the molecule receptors, as a consequence of which these tyrosine kinases become activated, and once they get activated, they activate the subsequent pathways, what we call STAT pathways. So among them, we have JAKs as well as type 2. And initially, we learned in blocking the JAK's pathways, JAK molecules, and of late, we have now started targeting about the type 2, the tyrosine kinase 2 molecule, which will also be a part and parcel of the JAK-STAT pathways. I don't dwell in this, but I think just to be on, there are different domains within these tyrosine kinase 2 molecules. We have FRM, SH2, pseudokinases, and kinases, and we need to know little about it. Of course, when we start applying mind and how and when we can use different molecules, and we have different type 2 molecules in type 2 inhibitors, which are specific to different domains of this particular molecule. So overall, what really these type 2 works with? Once, as I said, the ligand and receptor interact. When the tyrosine kinase 2 gets activated, it triggers a transcriptional factor and transduce the activator STAT pathways. Through this, it promotes the expression of cytokines, regulate various cellular pathways, and induces division, differentiations, and as a result of which, they work with different pathways. When it comes to type 2 usually includes the specific cytokines like IL-12, IL-23, type 1 interferons, so which leads into the Th1 and Th17 cells. So that being little more specific and narrows down into few of the cellular pathways compared to the JAK inhibitors. So how really it works and what exactly happens, if you can see in the figure A, there it is through the interferon gamma pathways, type 2 with JAK2 in combinations, it's going to work with the Th1 related cytokines. Similarly, with IL-23, that is type 2 with JAK2. So it's not that type 2 alone works. Type with JAK is always a necessity. Type and JAK combinations gives a different signals. And similarly, in the cells where the type is absent, type 2 is absent, there you can see that IL-10 production is in excess. That is, a down-regulator of inflammation is excessively secreted. That gives us a adequate theoretical base to say that if you block type 2, possibly that you can block both Th1 and Th17 pathways, simultaneously increasing the anti-inflammatory cytokine proportions. So thereby you can definitely achieve the what we are looking for with reference to the immune-mediated inflammatory rheumatic diseases. I want the inflammation to be down, anti-inflammatory pathway to be in excess or adequate. That balances out these immune inflammatory disease in favor of getting a good control on the disease process. So just to make things clear, see actually how these signals, this JAK1, JAK2, JAK3, TYK2 interacts is depending on the combination of these molecules on the subreceptor domains. Based on that and with their interaction on the cytokines, they have different pathways that are triggered. See, if you can just see the TYK2, JAK1, JAK2 combination stimulates, proactivates STAT1, STAT3. And similarly, if you see IL-10, TYK2, JAK1, and IL-12, JAK2, TYK2, and similarly IL-23, TYK2, JAK2, and TYK2, JAK1 with the interferon alpha beta. So these subsequently, if you go down the pathways, if these combinations interact, you can see that we have the anti-tumor, if it is IFN, if it is IL-12, TH1, if it is IL-23, TH17, and IL-10, the same combination with TYK2 also have anti-inflammatory properties. So that's how the pathways of a receptor ligand is translated into the transcriptional factor and finally becoming an effective immune responses. So that's how we can see now the TYK2 be having a definitive role in multiple sites. One, through the TH1, TH2, it produces TH17, psoriasis, rheumatoid arthritis, same TH1, TH17 are more active, and so also on the various cutaneous conditions, encephalitis, and B-cell lymphopoiesis. So TYK2 has multiple role, and as we know that the TYK2 have increased expression of TYK2 or altered TYK2 responses can result in many of these diseases. Interfering or blocking the TYK2 is definitely going to be theoretically helpful in all these conditions. There is an explosion on the number of TYK2 inhibitor molecule. We have 5, which is some are in phase 3, some are already approved, some are still in the phase 1 studies. We have brepocitinib, ropsacitinib, deucravacitinib. This is the one which is almost approved and is being tried for newer indication. We have BMS, still with the number 986202, and SAR 20347. So these are the TYK2 inhibitors that has been developed either in phase 1, phase 2, or phase 3, and few of them in the approval state. So if you see the brepocitinib, it is basically interferes with TYK2 JAK1 combination because it specifically binds to the catalytic domain JH1. I think if you recollect my third slide where I have given the molecular structure, these are the different domain areas within the TYK2 molecule which are targeted by different compounds. Ropsacitinib is on TYK2 JAK2. It's almost in the catalytic domain of JH1. And you have deucravacitinib, which is in the regulatory domain of JH2, and BMS and SAR, they are on the binds catalytic as well as binds regulatory domain. So based on these, in addition to their affinity to other JAK blockers, so it's not that they are absolutely affiliated only to TYK2, some amount of inhibition of JAK molecules are also there, but they are less affinity than the TYK2. That's how they become TYK2 dominant inhibitor. Based on these combinations, the pathways that they are going to block are going to be different. I think it's quite clear because it's a combination of TYK2 and JAK, 1, 2, 3. That is going to determine whether it goes to TH1, TH17, or it's going to be TNF dominant, or is it going to be varieties of other responses going to be done. Based on that, we are likely to get their advantages and disadvantages with reference to different indications. So of this, the deucravacitinib is something which has been already approved with reference to the indication of moderate to severe plaque psoriasis. It's been approved by FDA in US and Japan. And it's also approved for generalized pustular psoriasis. It's only in Japan, still FDA is under its radar. And of course, it's been now tried in alopecia areata, ulcerative colitis, Crohn's disease, systemic lupus erythematosus. I think we are fortunate to be one of the center where we are going through the deucravacitinib trial with reference to lupus. And we have seen in quite a few of the patients, I'm not sure who is on placebo and who is on the drug, but quite a few of these patients are doing good with reference to lupus, especially with reference to skin manifestations. So the deucravacitinib seems to be one of the possible type 2 inhibitor, which may be an alternative drug which we are likely to have with reference to lupus and lupus management, so also with psoriasis. Somehow, with the way they block, more so focused on Th1 and Th17, our failure of anti-IL-17 blockers with reference to rheumatoid arthritis still keep most of the scientists little skeptical about these type 2 inhibitor being useful with reference to rheumatoid arthritis. If you could see, there are no trials with reference to rheumatoid arthritis in any of these. Though theoretically we could think that possibly blocking the Th17 and Th1, the rheumatoid arthritis could also be overcome, because if you see that they are all one of the pathways which are active with reference to rheumatoid arthritis, but the failure of anti-IL-17 still keep most of us, little more guarding about using type 2 inhibitor with reference to rheumatoid arthritis, because the main pathways which they block are the Th17 and Th1. So we are really not sure whether it can work, but probably it may be one of the off-label indication. Over a period of time, we may start using it with reference to the rheumatoid arthritis. But we are a little skeptical about type 2 being a very useful molecule with reference to the rheumatoid arthritis. So just to quickly go through, because brepocitinib, the mechanism of action is type 2 JAK1. It has selectively have a lower affinity to JAK2 and a very high affinity towards the type 2. And there are clinical trials which are going on with a titrating dose from 1 milligram to 200 milligram. This is still in phase 1 trials. So far, the safety signals are quite good. And so also, if you come to the various other studies, it's being trialed in alopecia areata, atopic dermatitis, and other new potential therapeutic indications, including systemic lupus erythematosus. The studies are proposed and planned. Similarly is also rapsutinib. This is also in phase 1 and phase 2b studies. Both are completed. Adverse events are fairly less, and even the clinical laboratory abnormalities were very less. There is no reported red signals in continuation of the study drug development. So more likely, we may have few more trials and few more studies with reference to these indications. The deucravacitinib is something which may come to us next couple of years to the market, especially even in the Indian market, because trials are being done with reference to this drug in India. The other drugs are still not in clinical phase trials with reference to the in the Indian continent. So, and also they being in phase 1 and phase 2b studies, the chance of them getting into our use may be 4 to 5 years. I mean, that's a timeline that any of these drugs has when are still in phase 1. Most of these are the deucravacitinib is already in, some of approval has happened, as I said, with reference to psoriasis. Psoriatic arthritis trials are going on. Most likely, the approval for the psoriatic arthritis do come with reference to this drug. One of the major advantage of them is type 2. And as we know, the type 2 doesn't play a major role in hematopoiesis and other housekeeping operations of the JAK-STAT pathways. So that being the case, the possibility of adverse event, what I see or what I expect with the JAK inhibitors are not normally or less likely to be seen with type 2. That's what most of the study report says. And one of the major advantage what we look with type 2 inhibitor in comparison to the JAK inhibitor is its possible safety profile, because the type 2's role in housekeeping being on the lesser side. Hematopoiesis and in other housekeeping activities, it's of less use. So there are several clinical trials just to be listed, but anyway, the drug has got a final approval. Current studies are happening with reference to its use in systemic lupus erythematosus, and the way things are going as per the reviews that we had in the interim reviews, there are no major safety signals, and probably may, over a period of time, may get an approval for even the utilization of SLE. This were just an overview of what's happening with reference to deucravacitinib in systemic lupus erythematosus. Around 363 patients have been recruited with a significant improvement in the patients on the drugs. So the drug being used in 3, 6, and 12 milligram, and the best things you could see is around 3 milligrams, and probably the dose that may be fixed may be around 3 to 6 milligram. That's a dose that's going to be there with reference to this drug being once it comes into its approval. So what do we expect with reference to this drug? It's being one of the oral medication, type 2 specific, with a good safety profile. Hopefully this drug should slowly come into the armamentarium of using this particular drug with reference to systemic lupus erythematosus. Of course, its use in psoriasis is already approved. Psoriatic arthritis, down in few days, it should be able to, it should get its approval with reference to psoriatic arthritis. This is another compound still under preclinical study and phase 1 clinical trials. And the other drug which is in lookout is the SAR 2347. It's also under the preclinical evaluation. So overall, to put it, how does type 2 differ from JAK inhibitors? So as I said, because of its selectivity and low affinity to the JAK inhibitor, it would be potentially safe. The only thing is, unlike JAK, since if the JAK inhibitor has a pan-inhibition of multiple cytokines, and with a little variation in their affinity between JAK1, JAK2, JAK3, the variation in immune suppression of cytokines and different pathways are different. But unfortunately, if you look back into the JAK studies, comparison of different JAK preparations, we have tofacitinib, baricitinib, and different JAK inhibitors, we didn't find much advantage of one JAK inhibitor over the another JAK inhibitor, both in meta-analysis as well as in network analysis. And there are very few head-on studies between the different JAK inhibitors to see what is superior to the one JAK over the other JAK inhibitor. None of those JAK inhibitors are superior to each other. However, I think if someone gets hand to the recent review which has been published from my center about the pharmacokinetics and JAK inhibitor in expert review, they have presented the data very clearly that where we could very much see that the head-to-head JAK comparison doesn't show advantage of one over the other. But the advantage and how one can use this JAK in a different location, as I put it, is based on pharmacokinetic, pharmacodynamic, and adverse event profiles. If you look at the adverse event profile, some have hepatotoxicity, some don't have hepatotoxicity, some need to be modified in the renal impairment, and some need to be modified in the hepatic impairments. So based on that, one can choose and pick the JAK inhibitor, whether to go to tofacitinib, whether to go to udapasitinib, which probably likely to come in India over next 1 or 2 years. And these pick and choices are going to be based on that. When it comes to type 2, we have yet to understand these 5 different type 2 inhibitors which are likely to come. Advantage and disadvantage of each of these inhibitors also need to be learned about. Hopefully, it has a good treatment potentials with reference to many of the immune-mediated inflammatory rheumatic diseases. likely to take up the role in psoriasis, spondyloarthropathies, as well as in systemic lupus erythematosus, where Th1, Th17 pathways are the dominant drive. So hopefully, in years to come, we may see a reasonable alternative of type 2 inhibitors with reference to the treatment of psoriasis, SLE. Lot more has to be done with a lot more comparative studies vis-a-vis between the different type 2s, different JAK and type 2, JAK, type 2, and biologics. We are now in a world of confusion because now we have lots of choices. And as the choice increases, confusion increases. With the increase in confusions, error increases. I mean, that's the word that is always there. So if you have more choices to choose, the chance of going error increases. 10, chance of error is 1 out of 10. So if it is higher, the chance of error goes on increasing. Hopefully, it's a time for us to learn in depth about possible pharmacokinetics, dynamics, and as well as the approximation of the pathways of each of these diseases. That's where you can pick and choose and also can, to the best extent, personalize the treatment with reference to these various inhibitors which are going to come. So with this brief note, I thank the organizers for inviting me to deliver this lecture. And also I, as a chairman of ZIRACON 2024, I expect all of you to be part of this mega event, ZIRACON 2024. Welcome to Bangalore, and hope to see you in Bangalore. Thank you.
Thank you, Dr. Chandrasekhar, for inviting us to Bangalore. Definitely all of us going to come, and we'll be a guest there. And thank you once again for excellent talk on tyrosine inhibitors. Still, these drugs are not available in the Indian market. And hope when they come again, our patient care will improve significantly. Our session is open for any questions. Any questions? I think a new topic, they should have many dilemmas, doubts to clarify. Chandrasekhar here to clarify.
US has approved, US, Japan has approved the deucravacitinib with reference to psoriasis. It's available in the market.
Some of them have been approved by FDA,
Yes.
but they are under patency, very costly. So
They're pretty expensive. It's still not available in majority of the market. Even Indian and European market also is still to approve it. It's not still approved by European group. It is still not, of course, India is still, the trials are going, it's not yet approved. And they have not even applied for the approval in India. So
in phase 2, phase 3, the incidence of malignancy infections, that information?
they are same. They are as good as of a placebo. They have not found any red signals. Only thing is there was a little marginal increase in herpes zoster, but even the herpes zoster flare is not as much as you see in JAK inhibitors.
If there are no questions, I request Dr. Rajendran to give concluding remarks. Meanwhile, I call Krishnamurthy to come on the stage.
Thank you very much. But only one thing, but once it comes to India, it will be very useful because most of the patients, they are not accepting to take the vaccination for shingles and also the other problem. They say the trial that they were done, the excellent report about the side effects. No lipid abnormalities, no herpes, and also the other infections also are much less. Even thrombosis is very much less. So in all aspects, this drug will be definitely a good drug. Thank you very much for your wonderful talk. Thank you, sir.
Thank you.
My friends, I request Krishnamurthy to join me. We started this South Zone conference in the year 2014 when I was the president of IRA, with the concept to that young people from South Zone who are not getting opportunity get this opportunity. It has given a good results. This is a 9th conference we conducted. 2 years we didn't do because of COVID. And next 10th conference going to be in Hyderabad. And we agreed, Krishnamurthy and me agreed. And Tamilnadu chapter of Indian Rheumatologists are thankful for accommodating difficult situation because higher in national conference was Hyderabad last year, this year in Bangalore. Actually, it was our turn, but already this is the third conference Tamilnadu. Two conferences were done in Kerala, two in Andhra, one in Telangana, one in Karnataka. Next conference is going to be in Hyderabad because Telangana, apart from Hyderabad, we don't have other city logistics. So after Telangana, it will be given to Karnataka in advance only I'm telling. So we welcome all of you to Telangana conference. The chairman of conference will be, as we already decided, Dr. Rajkiran, Organized Secretary Varaprasad, and Chairman Scientific Committee Dr. Kirti Talari, and Treasurer is Vijay Prasanna. And this will get approval in the next meeting. And we invite you shortly about venue, dates, and various logistics. Thank you. Dr. Krishnamurthy, your comments, please.
No, I think normally we decide this in the AGM, isn't it? Okay, it's okay. Anyway, we'll take it as a formal announcement, and here afterwards we'll make it as a proper procedures. Today evening. Yeah, because Narasimhala is leaving today, he's cut short and is announcing this. We'll make it as a procedure here afterwards to be announced in AGM.
5 o'clock in AGM, Krishnamurthy will address once again.
6:30 or 7. It's anyway announced.
Dr. Krishnamurthy will address in AGM. My flight is 8 o'clock. I may have to leave at 5:30, 6 o'clock. So Krishnamurthy will address on this. Okay. Oh, thank you, my friends.
Moving on to the next session, which will be a debate on targeted therapies in immune-mediated inflammatory rheumatic diseases, for and against the motion. For the motion, it will be Dr. Rachel Uman who will be speaking for the motion for targeted therapies, and Vishad Vishwanath sir will be speaking against the motion. To chair this session, I invite Dr. B.G. Dharmanand, a very eminent rheumatologist, former president of the IRA, who has held multiple positions in the IRA, secretary, past vice president, and he was the past vice president of IRA. Along with him will be Dr. Rajamani, senior consultant rheumatologist from Coimbatore. He's a pioneer of rheumatology in Coimbatore. So he was one of the first rheumatologists to start practice in Coimbatore. He's currently senior rheumatologist at KMCH Hospital in Coimbatore. He's trained in the UK. I welcome you, sir. I request the chairpersons to introduce the speakers.
I'm happy to introduce Dr. Rachel Uman. She is from, I don't know, she did her MBBS from Christian Medical College and MD General Medicine from Sullia, Karnataka, and postdoctoral fellowship from Dr. Shannai Center in Cochin. And at this moment, she is working in a medical college in near Trivandrum. And she is going to talk for the motion, and Dr. Vishad will be for against the motion. Should we vote? See that the topic is for debate is targeted therapies in immune-mediated rheumatic diseases are the future. She's going to argue for, and Vishad is going to argue for against. So can I ask for a pre-debate voting? So how many of you would think that targeted therapies in immune-mediated rheumatic diseases is the future? So now I think Vishad has a big task to convince us against it, and I'll hand over the mic to my co-chairman.
First of all, I should congratulate Naga Prabhu and team under the guidance of Professor Rajeshwari, Arul, and John Matthew for conducting this excellent session. I've been a sleeping patron all throughout. Despite the major advances in rheumatology, still there is no ideal treatment. And the future of targeted therapy in rheumatology is one of the most exciting questions in current rheumatology. This debate is about comparing the advantages and disadvantages of the two different approaches and aim to shed light on the possible future of targeted therapies. Dr. Chandrasekhara has given us an excellent insight into the molecules and gone into the type 2s. So we have quite a lot to expect in future.
Over to you, Dr. Rachel.
A very good morning to one and all. So I'll be speaking for the topic, targeted therapies in immune-mediated inflammatory rheumatic diseases as the future. So what does this picture tell you? This is basically Hiroshima after the nuclear bomb explosion. This is what the conventional treatment for autoimmune rheumatic diseases have been doing. They have caused a general immune suppression to basically modulate the uncontrolled inflammation. These approaches have not been very successful in a heterogeneous patient population. And they have caused more side effects in the form of increased risk of infections, mainly because of their non-selective immunosuppression. So now we move on to the future, that is targeted therapies. As we are here for precision, for the use, we are in the pursuit of precision. So basically in precision medicine, we go in for a targeted approach based on the individual's genetic and the immunological variation. This will help us during the course of the disease and for the various drug responses. So this timeline will clearly tell you how we from 1975, where broad spectrum immunomodulators like sulfasalazine and gold were discovered, followed by methotrexate in 1985, where in 1998, the first the TNF inhibitor was approved. In 2000, where we realized that early intervention improves outcomes. 2005, where treating of therapeutic state improves the outcomes. And in 2015, where the jack of all trades, the small molecule drugs, JAK inhibitors, have been discovered. So this timeline clearly tells us how we are going out from a generalized approach to a more targeted approach towards the autoimmune diseases. So the targeted therapies that are involved in are cytokine targeted therapy, cell targeted therapy, kinase targeted therapy, and emerging immunotherapies. So the whole talk, it's about future of rheumatology. SZIRACON has been all about future of rheumatology, and all the talks have been concentrating on that. So I'll be just telling you about which are the molecules that we are targeting when we're speaking about the targeted therapies. The cell targets would be the BAF, TACI, the BCMI, CD19, CD20, the core stimulation molecules. And the cytokine targets would be the interleukin 1, 2, 17, 23, interferons. And then we'd come to the kinase targets, which would be JAK1, JAK2, JAK3, and the tyrosine kinase. So these are the targeted molecules that we are talking about. And the conditions where the targeted therapies are established beyond doubt would be rheumatoid arthritis, axial spondyloarthritis, psoriatic arthritis, IBD-associated arthritis, ANCA vasculitis, giant cell arthritis, Takayasu's arthritis. So just moving forward and telling you about a few targeted therapies. First, we speak about RA-ILD. This has been published in 2023, where they speak about the targeted therapy in RA-ILD. So this slide, I don't know how clear it is to all of you, but yes, what it tells us, once RA-ILD has been diagnosed, the first line of approach would be optimizing methotrexate to stop anti-TNF and to start on abatacept or rituximab and give a proper dose of glucocorticoids. And in wherever indicated, to also start the patient on cotrimoxazole. So abatacept and rituximab have been approved as advised as the first line treatment. And if the patient fails to improve on that, we can go on with tocilizumab or JAK inhibitors. So again, this slide tells you clearly how first line therapy in ILD has been shifted on to rituximab. The points from the paper would be ACR has been criticized for making mycophenolate mofetil and azathioprine as first-line treatment for RA-ILD without much evidence. Targeted therapies like abatacept and rituximab have the strongest evidence for RA-ILD, and they have recommended that these should be combined with methotrexate or given as monotherapy in case of RA-ILD. While methotrexate may be continued, it cannot really work for progressive ILD. So methotrexate has a protective effect in RA-ILD patients and should be continued. TNF inhibitors should be avoided. Abatacept and rituximab have the strongest evidence. Tocilizumab, JAK inhibitors can be as used as second-line agents. MMF may be combined with rituximab in refractory cases, and short role of GCs in glucocorticoids in NSIP or OP pattern, but not UIP. Now next being ocular inflammation, RA scleritis. So this is a paper published in 2021 where they just give us a guideline. Episcleritis, we mainly go in for DMARDs, whereas in scleritis, that is what we are more concerned about is the necrotizing scleritis. If IV pulse steroids, oral steroids, the patient is resistant or becomes dependent on it, after a complete infectious workup, the first line of treatment would be anti-TNF or cyclophosphamide. If the patient has already received it or is not responding to it, we should consider rituximab, givokizumab, abatacept, or tocilizumab. So moving on from RA, we go on to SLE. This is a paper published in 2024 where novel target therapies revolutionizing SLE care. So as we all know, SLE is basically an interplay of various genetic factors, environmental factors which lead to certain epigenetic changes and can lead to dysregulated immune responses. And the plan is to target all these therapies. So the ones circled in green are the ones which have been approved for treatment. The BAF and the APRIL molecule has been targeted, and we've got belimumab, Benlysta, which is approved for active, antibody-positive, non-renal SLE. There are a lot of molecules which are under trial and which have failed trials. The other one which has been approved is the calcineurin inhibitor, voclosporin, and it is approved for FDA for lupus nephritis. Interferon alpha, anifrolumab, has been approved for moderate and severe SLE and SLE nephritis. Interleukin-2 is under investigation. CAR-T therapy is under investigation under trials for various autoimmune diseases, including lupus. So the treatment, so the EULAR 2019 guidelines tells us that treatment for non-renal lupus erythematosus, where belimumab and rituximab were not given much importance, and they were placed later. But now, according to 2023 EULAR recommendation, belimumab and anifrolumab have been given importance in the treatment and have been included in the guidelines. Even for lupus nephritis, belimumab, voclosporin, rituximab have been included in the guidelines. So in the lupus nephritis, rituximab was typically considered in case of failure of first-line therapies or in a relapsing disease. But a post-hoc analysis of the LUNA trial showed that complete B-cell depletion following rituximab therapy in lupus nephritis was associated with higher odds for complete response at 78 weeks. Now moving on to the systemic sclerosis. So this is the FASCINATE trial where tocilizumab was compared with a placebo, and tocilizumab was found, there was clinical relevant difference in reduction of FVC at week 48 as an exploratory endpoint. So tocilizumab was found to be effective. Now an Indian trial which was published in 2018 where intravenous cyclophosphamide was compared with rituximab for the treatment of early scleroderma lung disease. And the conclusion was that rituximab is a safe and effective alternative to cyclophosphamide in the primary therapy of skin and lung manifestations. Now moving on to the inflammatory myositis. Rituximab used in myositis, 83% of the refractory myositis patients achieved an improvement, definition of improvement with rituximab. This slide is basically showing you various trials conducted over a period of 2005 to 2020, which definitely tells us that rituximab has been helpful in myositis. Moving on to the other ANCA vasculitis, 2010, we had the Rituximab, which is an induction, where rituximab was used as an inducer. Rituximab was not found superior to cyclophosphamide, but in the RAVE, it was non-inferior to cyclophosphamide. But the main Ritsan trial, which is a maintenance trial, maintenance 1, main Ritsan 1, 2, and 3, all clearly tell us that rituximab had fewer relapses for ANCA vasculitis. Now, our next dreaded steroid, we have got avacopan for steroid avoidance in ANCA-associated vasculitis, and the results have been quite promising. Can it replace a steroid taper in the treatment of ANCA-associated vasculitis? So this study definitely tells us that avacopan was non-inferior to prednisolone taper for inducing remission at week 26 and was superior to prednisolone taper for inducing sustained remission at week 52. Coming to our kinase targets, the JAK inhibitors, JAK1, 2, 3, all of them have been used in the various profile of patients, be it rheumatoid, psoriatic, angst-pon, lupus, plaque psoriasis, IBD, or atopic dermatitis. And they have been found statistically superior to placebo. So this would be a wide range of success story of JAK inhibitors in the various, be it spinal involvement, dactylitis, enthesitis, psoriasis, or uveitis. Our next concern always has been the side effect profile of tofacitinib, but the oral surveillance trial, a post-hoc analysis done, said that among patients without history of any atherosclerotic cardiovascular disease, all with some prevalent cardiovascular risk factors, the MACE risk did not appear different with tofacitinib 500 milligram BD versus tofacitinib versus anti-TNF. And the MACE risk for tofacitinib versus TNF cannot be excluded, but there is a very less risk, but we can't completely say if we choose the patient profile properly, we can use it without any side effects. So to conclude, targeted therapies are indeed the future treatment modalities for immune-mediated inflammatory rheumatic diseases. Much of the evidence-based guidelines are shifting their stance in favor of targeted therapies. Many of the older non-specific immunosuppressants currently in use were borrowed from oncology without much data to support their efficacy. It was a story of having something at least versus having nothing. And targeted therapies in rheumatic diseases has opened up a way for precision medicine. Thank you.
Thank you, Dr. Rachel. That was very interesting. Shall we proceed to the next? So we invite the next speaker.
Dr. Vishwanath is well known to us, and he is trained in SGPGI Lucknow, and he has worked as an assistant professor in CMC Vellore, and he has his own center called IRIS, interestingly called IRIS in Thiruvananthapuram. And he has an enormous task of countering Rachel's argument that targeted therapy is the future. Over to you, Vishad.
Thank you, sir. First of all, let me thank Dr. Nagaprabhu and organizers SZIRACON 24 for giving me this opportunity. I would like to begin by paying my tribute to this gentleman who's so well known to us, who's very endearing to us. Sir was actually a great academician. He's a great clinician, a wonderful organizer. But to me, sir was a great mentor. He had been a constant source of support and encouragement. And last year, I was conducting conducting SZIRACON 23 on behalf of Kerala Chapter IRA, was the organizing secretary. And I still remember sir giving me so much inputs and giving us so much support. He came over and actually he said, Vishad, I'm not feeling well, but I'm coming because of you. You tell me what you want to do and I'll do whatever you want. And he actually inaugurated a picture exhibition. This is a fond memory. Yesterday, as I was sitting and watching the inaugural ceremony, this vacuum, I felt that this vacuum could never be filled. Now, going to the actual topic, targeted therapies in immune-mediated inflammatory diseases as the future of rheumatology, I'm given an arduous task. Dr. Rachel has taken you to a Disneyland, a land of wonders. And it is my duty to bring you in touch, not an honorable duty, but to bring you in touch with the reality in science. So first of all, I would like to define targeted therapy. A drug that targets a particular molecule or pathway involved in the pathogenesis of the disease, in the pathogenesis of that disease, and not in the pathogenesis of other diseases, or pathogenesis of other physiological pathways. So that would be an ideal targeted therapy. So a target therapy would be one drug that would be a particular molecule or pathway, a drug that would target a particular molecule or pathway which is involved in the pathogenesis of that particular disease, or maybe in a group of diseases similar, but not in other, not having much role physiologically or functionally. And future is difficult for us to predict future. I think 10 to 20 years is maximum that I can think about. Beyond that, I think it's not up to me to speak on. So some of us believe in God and some of us believe in the theory of evolution. I believe in both. Of more than 1,000 named body parts, there are hardly, you can count here, 18 body parts which are so-called vestigial. That is, they do not have any other function. So there is nothing in the body, either anatomically, physiologically, or biochemically, that one can call as vestigial and can just be taken away without causing adequate side effects. And we know that the numerous biochemical pathways in the body, our body has been tuned or has evolved in such a way that it is most efficiently carried out. So there is no biological pathway which is exclusive to itself. So the same molecular pathways that mediate inflammation, it also mediates the coagulation pathway, it mediates growth and survival. So there is nothing that we can say is exclusive to a particular pathway. And most of the biochemical pathways, the transcription factors and cytokines are shared between multiple pathways. So risk of blocking one is very likely to risk blocking many of the other physiological entities in the body. And the classical example is the pleiotropism of the JAK-STAT pathways, which is involved in inflammation, it is involved in angiogenesis, aging, it is involved in cell survival, and antimicrobial properties. So let us see what is the current status of target therapy in rheumatoid arthritis, a disease that we consider is one of the most researched out one and where the data is quite robust. So few of these drugs, anti-TNF inhibitors, anti-cytokines, anti-B cell therapies, T cell co-stimulation molecules and small molecules have been approved for use in RA. These are actually the targeted therapy, but as you know, they target the cytokines and not really the disease per se that we deal about. And if you compare the efficacy of these pathways, I couldn't find an article that actually looked into comparing the efficacy of different molecules which are used in treatment of rheumatoid arthritis, hence I used a ChatGPT search. And what came up was that methotrexate is ACR20 response about 50 to 60% in 6 months. Upadacitinib, the latest kid in the block, which is supposed to have the best effect, has a response of about 70% at 12 weeks. So that means that we are going from 50 to 55% to 70% with the addition of this so-called targeted therapy. So if you look at the efficacy of current therapy with upadacitinib has the best data in comparison with other biologics, especially it is supposed to be superior to adalimumab as well as superior to abatacept. And what we see is that most of the ACR20 responses have been in the range of 50 to 70%. The best response, which is seen in this select early trial and select compare trial, is when it is used in combination with methotrexate. So the best response of 70% that we see here, or the ACR50 response of 52% that we see here, these are both seen in patients who used upadacitinib in comparison along with other molecules such as adalimumab or used along with methotrexate in comparison to adalimumab. And so what we understand is that 30 to 40% of patients on upadacitinib do not show adequate response, and this works best in combination when used with the conventional disease-modifying agents. And what about in SLE? Rachel was very prolific about speaking about the role of target therapy in so-called target therapy in SLE. SLE, of course, there are so many attractive targets. Rituximab had failed. Belimumab and anifrolumab have come up. Several other molecules have gone into failure. And what about the results of this? The best result is with belimumab and anifrolumab, which have about 45% response as against 31% the placebo. So there is hardly another 15% improvement with these medications. And all these are, mind you, all these are used in the background of conventional therapy. So when we talk about the efficacy of target therapy, which is the most hyped out aspect of so-called target therapy, first of all, target therapy is not adequately targeted enough. It cannot really be, there is an added improvement in the efficacy when we use it along with conventional medications. However, there are still a good number of people who do not respond to it. And hence, we know that it leaves much to be desired. So why is this so? Because of the pure multifactorial nature of the pathogenesis of immune-mediated inflammatory diseases, genetic factors, host factors, environmental factors, all lead to pathogenesis of rheumatoid arthritis. And if you look at the genetics of rheumatoid arthritis, there is no single gene abnormality. It is a multitude of genes which are expressed, which ultimately lead to a rheumatoid phenotype. So what target are we going to block here? Similarly is the story with SLE. SLE also has about 30% of SLE is supposed to be heritable. And even with SLE, the genetics is so heterogeneous. There are so many molecules which have been implicated in SLE, as well as in ankylosing spondylitis, which is considered to be very closely linked with genetics, and which has a single gene which supposedly has the highest penetrance when it comes to disease pathogenesis. So when we compare the expectations versus reality with respect to efficacies, the multifactorial nature of the immune-mediated inflammatory diseases means that there is no single etiological pathway or no single target is possible. And no targeted DMRs can capture all the critical elements in the pathogenesis of a particular disease. And we also know that very well now that there is emergence of resistance not only with the antibodies, but also even with the use of small molecular inhibitors. And hence, target therapy is not at all a panacea for all ills. And we also have to remember that it works best in combination with conventional DMRs because of the pleiotropic effects of the conventional DMRs. Now, what about the safety of the targeted therapy? The safety of target therapy was always in question right from the beginning. This was the infamous TGN 1412 trial, which was the trial of CD28 superagonist antibody, this antibody was tried in inflammatory diseases. And this was an antibody that was supposed to have a lot of promise in inflammatory diseases. And this was tried in 6 healthy volunteers. It was used at a dose of 1/500 that is used in primates. And all 6 of the patients who received this antibody developed cytokine release syndrome within hours of infusion. 4 of them went on to develop multi-organ dysfunction. So the beginning of target therapy was not at all promising. The safety data with respect to the oral small molecules have been coming up. Multiple safety issues have been recorded, serious adverse effects, death, infections. And what is more significant is the late reporting of the cardiovascular and cancer risk with tafasitamab in rheumatoid arthritis. This is very alarming as far as I think, and justifiably so, because these molecules have been used for a very short period of time, and we do not have adequate long-term knowledge about what they can do to the body. And even with 5.5 years of median follow-up, of course, in patients with slightly higher risk of developing cardiovascular disease, what this clearly showed was that there is an increased risk of malignancy as well as in cardiovascular diseases when you use these medications for a longer period of time. And these side effects can very well be, many of these side effects can very well be explained by the extrapolation of their multiple roles in the immune and growth pathways. But some of these side effects, such as increased serum creatinine and elevation of CPK, are not still very well explainable. And true to its nature, some of these molecules which have been used, so-called target molecules in use, have had to undergo the ignominy of withdrawal after regulatory approval. The well-known story of efalisumab and nitazoxanide, anti-human CD11 in psoriasis and anti-alpha-4 beta-1 integrin in multiple sclerosis, which was withdrawn a few years after launch because of late occurrence of PML, is another sign for concern. And this was another, I think this is a very important aspect which, I'm sorry, but my slide is not, okay. One of my slides is not moving. One slide is not projecting. Okay, this slide basically deals with JAK2 phosphorylation and its role in epigenetics. What has been reported is that JAK2 is an important signal transduction pathway for regulating the epigenetics of cells. Epigenetics, as you know, is something that is closely linked with the heritability, even linked with the expression of multiple genes, and this is a trait which can be handed over across generations. That is, a father having an epigenetic alteration can be handed over to a child having, can be handed over to his child. So what has been shown is that JAK-STAT pathway, in fact, coordinates more than 5,000 genes which are involved in epigenetic pathways. So we are, in fact, inducing heritable alterations in the genetic mechanisms, which we do not know still what would be the long-term outcome. And this is what I said. The JAK-STAT pathway coordinates expression of around 5,000 genes which are involved in, by its epigenetic regulation. So when we come to the safety concern side effects, short and long-term safety concerns are there, unpredictable side effects are there, and there is even a potential to influence epigenetics and cause heritable variations in expression of genes. And if you look at the cost effectiveness and accessibility, newer drugs have been associated with significant cost implications, and major advantage of conventional DMRs have been their cost potential, and there is a potential of widening of gaps in the care, which shift the focus to care of the privileged. This is another point of concern from a social point of view. And what about conventional DMRs? They have a proven track record, they have predictable side effects, cheaper and accessible, can reduce the need for targeted treatment, and no, Dr. Rachel, I don't think that they are like an atom bomb. They are like a soft bomb which distorts, which helps us evade the disease without causing much of damage. It's like a tear gas bomb, maybe. And despite more than 25 years of its existence,
we may have to
last two slides.
Yeah.
Despite more than 25 years of existence, etanercept was launched on November 1998, and more than 25 years of existence, the so-called target therapy has not still found its position as the first-line treatment for rheumatoid arthritis in any of the leading guidelines. So to sum up, target therapy was expected to be the holy grail in immune-mediated rheumatic diseases. However, they have not met the promise. The multifactorial pathogenesis of most of the immune-mediated inflammatory diseases is likely to not give us one single target which is going to cure all, which is going to be a panacea for all rheumatic diseases. The efficacy of existing so-called targeted DMRs is not that robust enough yet, and the safety, long-term and short-term safety, and increased disparity of care are concerns that we need to look into. Conventional DMRs, I feel, are here to stay, and combination of conventional DMRs with target therapy, which I am not sure which can really be called a particularly target therapy, would be the future. I feel that would be the future of rheumatology. Thank you.
Good. I think Vishad tried to give a very good argument against what Rachel has been arguing. Rachel, you have a minute, 1.5 minutes to have a rebuttal for lack of time.
Congratulations to Dr. Vishad for the beautiful rebuttal. But, sir, you said that I can't think about 20 to 30 years down the line. But if somebody else had not done it, you wouldn't be right here talking about even methotrexate or even about rituximab. So if we think today, tomorrow we will come out with a better future. So yes, we can predict the future. I'm not predict, at least we can bring about a change in the future. That would be one. Then the next, you said that in RA, none of the recommendations have given any of these biologicals as first line. So that's why I clearly put up a slide where in RA-ILD, rituximab and abatacept has been given as first line treatment. Then you spoke about the cost. Yes, the cost is definitely a factor. But we do remember that rituximab was out of reach for most of the patients, but now even a middle class or even a lower middle class can definitely afford rituximab. This would be with the help of Indian Rheumatology Association and our government, which we can make it affordable to all. Then next, side effect profile. Yes, there are a few side effect profiles, but studies further will definitely prove that they are equivalent to the conventional other conventional treatment for rheumatic diseases.
Thank you, Rachel. You have 1 minute to say a few words.
Yeah,
last few
thank you,
words.
Rachel. First of all, I didn't say that I couldn't predict the future. I said I couldn't predict the future beyond another 10 to 20 years. That I think I'm very well justified. I think 20 years quite a timeline which I can discuss this comfortably. Second thing is that yes, there are certain indications which are very, let us say they are niche indications where the lack of data also could be a reason why Of course, we won't be having thousands of people who are developing necrotizing scleritis and people are going to try methotrexate in that. People will be alarmed or pushed to, given the hype around the so-called target therapy, people would naturally be pushed to use these medications, and hence they are likely to have a slightly more data as compared to the others. And I think I stand by what I say, the multifactorial pathogenesis of these diseases. We do not have a single genetic abnormality or a single pathway which is going to be implicated in any of these diseases. These are purely multifactorial, multi-mechanical diseases, and I don't think that there's going to be a single target which is ever going to be effective to get rid of these diseases. I feel that multi-pronged treatment is going to stay in immune-mediated rheumatic disease at least for another foreseeable future, let me say.
Thank you. And I think both of them have their arguments. And I think I will get this for voting, post-debate voting again. So the topic is the targeted therapies in immune-mediated rheumatic diseases are the future. So most of you voted for in the pre-debate, and how many of you vote for this movement, for this motion? I think Vishad has done his duty, and those who are against, though the people still believe that targeted therapy is going to be the future, and Vishad, congratulations for converting a significant
I'm satisfied.
people towards your motion. And I think this is a wonderful debate which stimulated. See, autoimmune diseases are very complex diseases where there is no single target, and target is even not known many times. And more closer we go to the target, they seem to go farther and farther away. So this is the state of affairs at this moment. And with that background, you have done a fantastic job. Thank you very much. Wonderful. Congratulations.
Over the years, over the last few decades, we have changed our treatments based on what we know. Now there has been quite extensive research into the molecules, and as a result of that, we've been changing our treatments. And I think the role of biologics are here still to stay. And as we need to tailor our treatment to our patients' needs, you know, and these targeted therapies are there. But still, as Vishal mentioned, DMARDs are still here to stay, particularly in our country. Thank you.
Thanks to Dr. Rachel and Dr. Vishad for that compelling discussion for and against targeted therapies in rheumatic diseases. Next, we'll have the first Professor Danda Memorial Lecture. Professor Danda, as you know, sadly passed away last year. So we'll have one of his illustrious students to deliver the first Professor Danda Memorial Lecture this year. To chair this session, we'll have Dr. P.S. Arul Rajmurugan, who is the Head Institute of Rheumatology, Madras Medical College, and the Scientific Chairperson of SZIRACON 2024. He's also the Secretary of Association of Rheumatologists of Tamilnadu. Welcome you, sir, to take your position on the stage. Along with him will be Dr. Anup, who is trained in CMC Vellore and the UK, and who is the director of one of the largest rheumatology centers in North Kerala. Welcome you, sir, to chair this session. I request the chairpersons to introduce the speaker.
Before we move on to that session, we have a small display of details about Professor Danda's endowment, which has been created by Madam Danda. So for that, we have few slides that will be introduced by our Dr. Anup.
First of all, I would like to thank organizers and the senior members of the ART for this particular new session, Professor Danda Memorial Lecture, Oration in SZIRACON. As this, on behalf of all alumni of CMC, I would like to extend my and everyone's thanks and gratitude towards the organizers for such a wonderful gesture. And this is a message from Sumita Madam, and she has requested me to introduce the Danda Memorial, the Debashis Danda Foundation. So this one, let us remind ourselves in serving humanity by following blazing trail left by my husband, late Professor Debashis Danda. And it is appropriate to his name. The blessings will shower continually, and wishing great success for SZIRACON 2024. And welcoming you to be a part of Dr. Debashis Danda Foundation. And Dr. Debashis Danda's foundation, it's actually registered, this one. And the president is Dr. Sumita Danda. And the first secretary is Dr. Ashish Jacob Matthew. And the treasurer is Professor Satish Kumar. And senior advisors are Dr. Ramnath Mishra and Professor John Matthew. Coming to the major contributions and achievements of Professor Danda, coming to the research, he was actually the torchbearer and the path-breaking research in Takayama arthritis and Sjogren's syndrome. And he was phenomenal in introducing DC-VAS ACR EULAR database for classification of vasculitides and ITA scoring system. And he was the founder, state-of-the-art immunology and rheumatology department in CMC Vellore, and supported establishment of ACR Applar exchange program and fellows retreat at Indian Rheumatology Association and establishment of Indian Rheumatology Disease Registry. And he was, as everyone knows, he was the past president of Indian Rheumatology Association from 2017 to 2019, and he was the Applar president from 2021 to 2023. And he was the chair of ILR 2022. And he was the awarded ACR Distinguished International Rheumatology Professional in 2023. And posthumously, he was awarded Applar Master a few weeks back, 2024. And he was, during his last days of us, he was actually working as a course director along with Dr. Khairan Walsh for postgraduate certificate course in primary care rheumatic and musculoskeletal medicine at BMJ. What is actually the mission of this foundation? It is actually to foster excellence in clinical care, advancing academic education, research among medical students, and postgraduate trainees and junior level faculty members in medicine for enhancement of social welfare. How can you help this particular foundation? Join us in honoring Dr. Danda's legacy by supporting the foundation, and your contributions will help us in following ways. Fund research projects that have the potential to change the lives and provide educational opportunities for future leaders in rheumatology, and expand the community programs that offer support and resources to those in need. And the ways to contributions are volunteering and offer your this one great time and expertise to help us achieve our mission, and partnerships and collaborations with us to create impactful programs and research opportunities, and donations, make one-time or recurring donations to support our initiatives. And if you got anything details to want to understand, you can always write to us at ddanda2024@gmail.com. Thank you very much.
Thank you, Anu. Now we will move on to the scientific session. This time, we feel privileged to have Professor Danda Memorial lecture in this South Zone conference. The one person who was sincere, honest, hardworking, and devoted most of his life for training his students in rheumatology. I knew him since he was an assistant professor in Department of Medicine. Even I used to send my postgraduates to work under him. And slowly he has established, and now the CMC Vellore, the Department of Rheumatology, has grown in heaps and bounds. So we owe a lot to him. So we felt it is an honor to have the memorial lecture in his name. The fitting disciple is Dr. Sandhya, who has done MBBS at Kozhikode Medical College, MD at JIPMER, and fellowship at CMC Vellore. And she is now the senior consultant rheumatologist of Narayana Health City, Bangalore. Her field of interest is Sjogren's syndrome. She has done a lot of works in Sjogren's syndrome. So she has received many awards. Next. Any other slides?
I want to just add a few more things regarding Sandhya. Sandhya was actually my junior in Calicut Medical College and also in CMC Vellore. And she was one of the most favorite student of Danda sir. And I remember once sir has told, sir has never seen such a brainy lady like Sandhya. So she was actually one of the most prominent face and figure in the field of rheumatology, in the field of primary Sjogren's disease. But she doesn't know that. Actually, she is one of the most prominent figure from India to the global rheumatology, to the global Sjogren's group. Okay, over to you, Sandhya.
Thank you for the kind introduction. So I would be talking about Sjogren's syndrome myths and pearls. So let us start off with the first statement. Sjogren's syndrome is a rare disease. This is, of course, a myth. With a prevalence of 0.01 to 0.72%, this is the second most common rheumatic disease after rheumatoid arthritis, if not the most common. It is underdiagnosed and misdiagnosed. But is it a rare disease in India? This is again a myth. So let me show you how we started off. These are the earliest publications of Sjogren's syndrome from India. And you can see that there is one publication from Madras Medical College where there were 36 patients over a period of 4 years. And the publication from SGPGI, they had 26 patients over a period of 10 years. So this paper had this heading that primary Sjogren's is a rarity in India. Mishra sir, along with Dr. Sapan Pandya and Danda sir, went on to write this textbook chapter in 2011. So what they wrote is, a decade ago, primary Sjogren's has been rarely reported from India. Contrary to Western data, the reported occurrence of disease has been low. Even in dedicated clinics for rheumatic disease, only about 0.5% of all patients are diagnosed to have Sjogren's. They also, this was their introduction, but they put together cohorts of Indian patients from different timelines and different parts of the country. So you can see that Mishra sir's group had 26 patients over a period of 10 years. From West India, over a period of 5 years, 68 patients. And from South India, 231 patients over a period of 8 years. So what they concluded was, it's not that it's a rare disease, but it is an underdiagnosed entity in India. Sjogren's syndrome is a disease of postmenopausal women. This may not be true for Indian patients. You can look at the table of comparison here. You have CMC Vellore data represented here. You look at the Chinese data and compare with the Caucasian population. So what can be concluded is that we have a younger age at onset as compared, younger age at diagnosis, onset may be even younger age at diagnosis as compared to the Caucasian population. This is also supported from data from PGI. PGI had 64 patients and they said the median age was 37.5. Data from Madras Medical College, 82 patients. Sikha group, the mean age is 45. And if you look at the patients who had systemic presentation, age is even younger at 34. The most common presenting complaint in Sjogren's is Sikha. Is this true? Again, this is also false. If you look at it, this is the retrospective study from Vellore. Only 10% volunteered Sikka. And if you look at the data from a prospective study from Madras Medical College, 82 patients were there. Objective signs of dryness was found in more than 90%. Telltale features such as dental caries in 60%. 40% patients did not complain of Sikka symptoms. Okay, so if Sjogren's syndrome is suspected, we need to do objective test irrespective of Sikka. This is because subjective and objective Sikka are not always concordant. Is this a true statement or false? So this is a pearl. So discordance has been observed in 80% for ocular, 73% for oral dryness. This is from the UK Sjogren's syndrome registry data. So patients generally underestimated both oral and ocular Sikka symptoms, but more for oral. And objective and subjective strongly correlated for oral more than ocular dryness. Is Sjogren's syndrome the most common cause of Sikka symptoms? Next statement. Is this true or false? So this is also false. So if you look at the data, 106 patients with keratoconjunctivitis Sikka were followed up for 12 years. Of this, only 29% developed primary Sjogren's. And in a cross-sectional study of people with Sikka, only 5 to 15% were diagnosed to have Sjogren's. The drugs are the most common cause of dry mouth. This includes antihypertensive, diuretic, antihistaminics, anticholinergics, antidepressants, and sedatives. And other conditions which causes Sikka, we should not forget diabetes, radiation, chronic viral infections. Can Sjogren's syndrome be ruled out if both Sikka's symptoms and signs are absent? What do you think? This is again a myth, because we know that renal and neuro Sjogren's can precede Sikka features by decades, and children may not have Sikka symptoms and signs. So let us talk a little bit more about neurological and renal disease. So there are a string of pearls here. So in Sjogren's syndrome, peripheral neurological involvement is more common as compared to central, and among the peripheral, autonomic small fiber neuropathy and sensory neuropathy are the most common. Immunosuppression is not required in all cases. It is important to immunosuppress upfront in neuronopathy and those with motor deficits and those patients who have worsening or rapidly progressive sensory. Central nervous system is uncommon, and if you are diagnosing central nervous system, you need to rule out other etiologies before you attribute it to Sjogren's. So there should be a high degree of suspicion for Sjogren's syndrome in the following so-called idiopathic neurologic diseases. These are sensory neuronopathy, ganglion or otherwise called ganglionopathy, small fiber neuropathy, autonomic dysfunction, optic neuritis, myelitis, NMOSD, and aseptic meningitis. I would just like to elaborate a little touch upon ganglionopathy. So this is otherwise called neuronopathy, and it can evolve for years before accurate diagnostic detection and often without a proper evaluation for Sjogren's. This condition affects the large fiber dorsal root and causes inflammation, and this is challenging to treat because years are spent before a diagnosis can be made. And there is only a tiny therapeutic window for total reversibility. And so we should remember that upfront this condition needs to be detected early. Even if it is idiopathic, we need to evaluate for Sjogren's, and upfront immunosuppression is required. Okay, prevalence of fibromyalgia in Sjogren's syndrome is overestimated. Is this true or false? So this is a pearl. It is overestimated. And why is it overestimated? What is the condition that is mistook for fibromyalgia in Sjogren's syndrome? Okay, so can you identify what is this condition? Very good. So this is small fiber neuropathy. And what is this on the right? What is this condition? So both these conditions are small fiber neuropathy. But we recognize the length-dependent small fiber neuropathy. What you see on the right side is non-length dependent small fiber neuropathy. So if a lady comes and says that they have symptom in all these areas, what would you diagnose? most of the time the patient would be diagnosed to have psychiatric condition, and otherwise patient would be diagnosed to have fibromyalgia. And it should be remembered that in Sjogren's, non-lung dependent small fiber neuropathy is more common than lung dependent. So that is why most of the conditions, if you have diagnosed fibromyalgia in many of your Sjogren's syndrome, it is time to relook. All patients with renal tubular restenosis should be evaluated for Sjogren's syndrome. True or false? This is Pearl, and all patients should be evaluated irrespective of whether they have Zika or not, and renal tubular restenosis can present as hypokalemic paralysis, osteomalacia, renal calculus, and nephrocalcinosis. And this is the systemic review of all case reports. There are 440 case reports of Sjogren's syndrome RTA. Majority are from Asia. The median age is from 37, ranging from 6 to 78. So you can be very young or you can be very old, but still you can, when there is renal tubular restenosis, we need to evaluate for Sjogren's. Renal tubular restenosis, when it happens, is one of the earliest manifestation of Sjogren's syndrome. The Zika features are subclinical, so they are not going to be presenting with dry eyes, dry mouth, but if you evaluate objectively, there would be high positivity. Now let me show you some other scenarios where Sjogren's syndrome must be suspected. These are the systemic manifestations: parotitis, purpura, lymphocytic interstitial pneumonitis, where you see the characteristic cyst, and in between the cyst there is ground glassing. Non-erosive arthritis, which you may think, and patient may have RF positivity, and you may think that this is mild RA. Go back and relook whether this is Sjogren's or RA. And patients who have cytopenia, hyperglobulinemia, high ESR, and normal CRP, we should sensitize our hematology colleagues to look for Sjogren's in these patients, because this combination is called the biological footprint for Sjogren's syndrome. So scenarios, these are the Zika surrogate features where we must suspect Sjogren's syndrome. So when there is lack of pooling, so patient may not volunteer dry eyes, dry mouth, but what we need to look for is whether there is lack of pooling of saliva, whether there are features of recurrent oral candidiasis, lobulated or fissured tongue, presence of root caries, incisor caries, and premature caries. So if these are there, then there should be a very high suspicion for Sjogren's. The other possibility is if somebody has undergone multiple dental procedure, which is inappropriate for age and other comorbidities, again we must consider the possibility of Sjogren's. Is ANA a useful screening test for Sjogren's? False, because only 20% of patients fulfilling ACR-EULA criteria are ANA negative, and 10 to 20% of patients with ANA negative are anti-SSA positive. And again, 20% of patients with anti-Rho52 are anti-SSA negative. So going on, Sjogren's syndrome can be ruled out if all antibodies are negative. Is this true or false? This is false, because seronegative Sjogren's syndrome is a very distinct entity, and this is characterized by negative antibodies for SSA and SSB. And current definition for seronegative Sjogren's depends on biopsy, but people feel that the true prevalence we may not know, and it is underestimated. It is believed to be 8 to 37% of Sjogren's syndrome may be seronegative. And you also have triple seronegative. So people have found that SSA, SSB, RF negative, but ANA positive is seen in 8.6%, and all these antibodies negative are seen in 4.5%. So what are the characteristic features of seronegative Sjogren's as compared to seropositive? They have a lesser proportion of females, higher age at diagnosis, poor quality of life, low ESSDI, lower risk for lymphoproliferation and lymphoma, and higher risk for ILD. RF is relevant to pathogens of Sjogren's syndrome and should raise suspicion of Sjogren's in patients with mild non-erosive RA. So this is a true statement, and RF positivity is found in 50 to 60% of Sjogren's syndrome, and this positivity is associated with glomerulonephritis and cutaneous vasculitis, type 2 mixed cryoglobulinemia, and lymphoma. ACR-EULA criteria is required for the diagnosis of Sjogren's syndrome. Is this true or false? This is false, because as we know in rheumatology, classification criteria should not be used for diagnosis. This is used for recruitment in studies and clinical trials, and fission diagnosis is still the gold standard. Sjogren's syndrome has the highest risk for B-cell lymphoma among all autoimmune disease. Is this true or false? So this is a pearl, and B-cell lymphomas are seen in 5 to 10% of Sjogren's syndrome. That means the risk of B-cell lymphoma is 7 to 15 times that of general population. And the most common lymphoma is extranodal non-Hodgkin's B-cell lymphoma, and this originates in the mucosa-associated lymphoid tissue, and most commonly the salivary glands. And persistent parotidomegaly should be evaluated for lymphoma in patients with Sjogren's. Now, let us briefly talk about pathogenesis of lymphoma. So, this is the salivary gland, and you know that in Sjogren's syndrome, in very severe cases, the salivary gland can mimic a lymph node. So here you have the germinal, central, and marginal zone. So which is the site for production of anti-SSA, anti-SSB antibodies? That is the germinal center. But which is the site for occurrence of lymphoma? Which is the site? Any guesses? I have already mentioned, so it is the marginal zone. But why should you have this discrepancy? So what happens is, in germinal center, you have production of anti-SSA, anti-SSB antibody. These binds to the self-antigens. So this immune complex will migrate to the marginal zone here. And in marginal zone, you can see that these are the B cells which I have marked in red. And there you can see that B cells are producing antibodies against immune complex. So tell me, which are these antibodies? The antibodies against immune complex, what are they? Sorry? Very good. So this is the rheumatoid factor. And so you can see that as B cell proliferate, they accumulate mutations, and in the presence of B cell cytokines, they go on to develop lymphoma, from polyclonal to oligoclonal and lymphoma. So Sjogren's is just one step away from lymphoma. So site of lymphoma is the marginal zone and not germinal center, and neoplastic B cells arise mostly from RF-producing B cells. And this is the last statement. Sjogren's syndrome, RTA, is always benign and immunosuppression is not required. Is this true or false? False. Yeah. So this statement stands true for all the different manifestations of Sjogren's syndrome. This is a myth, of course. And we should understand that whether it is RTA or any other manifestation of Sjogren's syndrome, there is a wide spectrum of disease. All RTA are not the same, and all tubulointerstitial nephritis, that is the pathology which underlines RTA, they are not benign. So at one end, you have patients with mild electrolyte imbalance, but normal and stable renal function without proteinuria and low ESSI. These patients should receive only alkali and potassium. On the other hand, if you have patients with low EGFR, hyperglobulinemia, and high ESSI, they should be treated with immunosuppression. And what sort of immunosuppression? There is a difference between treating lupus and Sjogren's. So lupus patients, you see a dramatic effect. In Sjogren's, you may not see the dramatic effect. Still, you need to persist and give longer duration of treatment, and B-cell depletion therapy is required. With that, I conclude my talk, and thank you for patient listening. And I wanted to talk about Sir at the end because I did not know if I spoke in the beginning whether I would be able to continue speaking. So working with Sir, working under Sir has been inspiring, and he has been a great mentor. And not only because of his knowledge, his expertise, his enthusiasm, but he also encouraged non-conventional approach and tangential thinking. And he was always ready to question norms. And we realized that Sir was so much ahead of his time. And many of the things which Sir told about Sjogren's syndrome, we can see the international community accepting now. But he knew those things, and he was very emphatic in getting the message across even a decade earlier. So we want to continue the work what Sir has started. So we have set up the Indian Sjogren's Syndrome Registry. because we think that the existing criteria may be good enough for Western patients, but would not do justice to Indian patients with Sjogren's syndrome. And I request help of each and everyone here to get this. We have already recruited 400 patients from 16 centers, but I would request the help of each and everyone here to get larger numbers. Thank you so much.
Thank you, Dr. Sandhya. The talk is open for discussion.
So, sir, when I joined NH and when I was at CMC also, I had initiated this conversation with hematologist. So, so he said that this is new information for them, and they have not looked for Sjogren's in those with maltoma. So, I have requested, sir, whether we could call back those patients and look for underlying Sjogren's. So what he suggested was that the number of maltoma may not be huge, but he said we can get all of Karnataka, he said we can collaborate with others and get all those maltoma and look whether there is underlying Sjogren's. One more important point is, sir, in the previous, so the international community also recognizes this fact. So previously, if you see before the ACR-EULAR criteria, the criteria that ACG 2002, lymphoma was considered an exclusion. So if you have lymphoma, that is an exclusion criteria for Sjogren's. They have removed it because the EULAR big data, they found that in 10% patients, lymphoma is the first manifestation. So I think we should look, and I think we should be able to do that. Yes, yes. Thank you, sir. Thank you so much. Yeah, so CMC, sir, there are a lot of differences. There is paucity of randomized control trial. So if you look at the literature evidence, it is quite patchy. So I think the nephrology perspective is that they do not offer biopsy to all patients with renal tubular acidosis. They do evaluate for Sjogren's, but they do not offer renal biopsy. So one indication for immunosuppression, apart from what I've mentioned, is if on renal biopsy, there are significant lymphoid infiltrates on the renal biopsy, that is an additional indication for immunosuppression. So for other criteria, I see if there is creatinine is elevated, they do consider immunosuppression, but otherwise not.
What you recommend is that if you find the AGFR is going down, and as you mentioned, you have raised IgG levels, you would ask them to do a renal biopsy and then decide on immunosuppression, and that would be anti-B cell.
Yes.
Thanks.
So there are different type of B cell lymphoma. So maltoma is a lymphoma that is mature B cell lymphoma.
But the small cell, the typical small B cell lymphoma is supposed to be more common. That is, am I correct?
No,
The incidence of maltomas are much more elevated in Sjogren's syndrome as compared to 40 times, some 40 times more elevated in Sjogren's as compared. But the general lymphoma prevalence is higher in Sjogren's. That is the B cell lymphomas. The small B cell lymphomas are higher. That is the correct.
Yeah. So overall, when you're looking at prevalence of B cell lymphomas, maltoma is included under that. So maltoma comes under extranodal B cell lymphoma. So how it is different from others is this is called a mature B cell lymphoma, which is because it's happening in the marginal zone. So these can, so you in Sjogren's, this is the most common, and this is considered in the classification of lymphoma, this is a B cell lymphoma. And you can get diffuse large B cell lymphoma de novo in Sjogren's, or maltoma can transform to B cell lymphoma. So, but the most common in Sjogren's is, I think it's maybe 80%, 80 to 90% of all lymphoma in Sjogren's are maltoma.
Yes, thank you. We will close the session. As
Now we
time-
request the
We are
chairpersons
running
on.
late, so we'll close the session. We can have a discussion during the tea time. We'll go for tea time and I will assemble again for the oration.
Now we request the chairpersons on stage to present a memento to our speaker, Dr. Sandhya ma'am. So we request everyone to give a very good applause for our speaker. So now I request our chairperson, Anup sir, to present a memento to Dr. Arul Rajamurugan sir. So very good applause for our chairpersons. And also I request Dr. Arul Raj Murugan sir to present a memento to Dr. Anup sir. Now I request before speakers and chairpersons, now I request our chairpersons, Dr. G. Narasimhalu sir and Dr. Panchapakesa Rajendran sir, to come on stage to present a memento to our speaker, Dr. Chandrasekhara sir. Once again, a very good applause for our speaker. And now I request Dr. Panchapakesa Rajendran sir to present a memento to Dr. G. Narasimhalu sir. Also, I request Narasimhalu sir to present a memento to Dr. Panchapakesa Rajendran sir. Thank you so much, sir. And now I request our next chairpersons, Dr. Dharmanand sir and Dr. Rajamani sir, to come and join us on stage to present a memento to our speakers, Dr. Rachel Oman Joseph and to Dr. Vishad Vishwanath. Now I request Dr. Rajamani sir to present a memento to Dharmanand sir. I request our chairpersons to present a memento to our speaker, Dr. Vishat Vishwanath. I request Dharmanand sir to present a memento to Dr. Rajamani sir.
Thanks to all the dignitaries and delegates. Now we'll have a short break. Please finish it fast and so that we'll be in time for the Professor ANC oration.
I have received innumerable awards during the last 77 years. I will be 78 in few days of my life. But when you get an award from your dear friends, colleagues, and your organization, you feel happy. Rajyotsava, Padma Shri, lot of them are political awards. You see. There are other considerations there. But when your friends give you the award, 2006, my birthplace, Chitradurga, they awarded me publicly. There were 15,000 people. Mallikarjun Kharge, Jafar Sharif were also awardees for some other reasons. But I felt very happy. I was born there, I received. Second time, my colleagues Dharmananda and Ramesh Jois honored me in 2011 when I got the Rajyotsava award. I felt immensely happy because Bangalore Rheumatology Association honored me. Paul Bacon gave the award. In 2011, my alumni, Bangalore Medical College, honored me. I was very happy. 3 institutions, apart from Bangalore Medical College, are very dear to me. Madras Medical College, Chennai, are now the Institute of Rheumatology. Christian Medical College, Vellore. St. John's Medical College, Bangalore. These 3 are very dear to me. You will know the reason when I talk why. Chandrasekharan is not just a legend. He is the father of Indian rheumatology. There were claimants earlier. There were people claimed that we did this, we did that, we did this and all. Chandrasekharan never claimed. Chandrasekharan never claimed. He silently worked, silently achieved everything. I wouldn't have been here today but for Chandrasekharan. In 1988, I received a postcard. I couldn't retrace the postcard. He said, Dr. Mahendranath, I believe you are practicing rheumatology in Bangalore. Please join Indian Rheumatology Association. And I joined the Rheumatology Association. In 1993, he inducted me to the EC in Delhi meeting. He told Malaviya, Mahendranath is a young man, he works hard, he has ideas, we should take him. Then in 1999, one day he called me. He said, Dr. Pispati spoke to me today, and I believe Sukumar Mukherjee's term is over, and he wants to make U.R.K. Rao the next president of the IRA. What do you want to do? I said, sir, Pispati is not Congress High Commander Sonia Gandhi, and IRA is not Congress High Command. Right? I said, I will not allow this to happen. That's all he said, nothing else. Then I contested the election. My good friend U.R.K. Rao is still there, and he was the opponent. And I had a long chat with Rao, and Rao's wife, who is a younger sister to me, very dear to me. And Rao agreed to withdraw at one stage and to make the election unanimous. But Pispati persisted and changed. And the election happened. But Manjushree Mitra was the chairman of the IRA at that time, and there were some ballot papers open. They cancelled election, and there was re-election again. Again I won. I had told U.R.K. Rao, you should not be contesting against me. I am senior to you in every respect. Your wife wants to support me. And at this stage of life, Rao, you should make your own decisions, not listen to his party. Rao didn't listen. And I told Rao, come what may, Rao, I will defeat you. All right. And I defeated him. Next time he won. Nothing. Rao is one of the closest friend of mine in my family affairs and his family affairs. And Deepthi is another daughter to me. So I'm just telling you. So, but for Chandrasekharan, the history of rheumatology changed. Why, you will see. I have chosen the topic as evolution of rheumatology in India and also southern India, past, present, and future. And I have no disclosure to make. And during the talk of my layout, I'll talk about the history, the past, the present, the growth and consolidation of the IRA. There are unspoken truths and facts which younger generation should know about it. The future and message to the youngster, and Guru Vandana to Professor ANC. 1959 rheumatology outpatient clinic started in TN Medical College and BYL Nair Hospital by late Dr. M.M. Desai, who was a giant of Indian medicine, great physician, and a rheumatologist. In 1963, APLAR, earlier CPAL, was formed with India as a founder member. 1963, Indian Rheumatism Association, now Rheumatology Association, IRA, formed with headquarters in Mumbai. In 1968, the first CPAL Congress held, organized by late M.M. Desai in Mumbai. In the early 60s and 70s, physicians were managing rheumatic diseases. Early 60s and 70s, physicians were managing rheumatic diseases in major cities like Mumbai, Kolkata, and Chennai. Most of the physicians were trained in UK and had some exposure to rheumatology. In 1971, Professor S.D. Devdar in PGH Chandigarh started a rheumatology outpatient clinic. In 1972, Dr. Chandrasekharan started a Department of Rheumatology full-fledged in Madras Medical College and General Hospital in Chennai. In 1972, Dr. Malviya started rheumatology outpatient clinic in All India Institute of Medical Sciences. 1974, Dr. Manjushree Mitra late started rheumatology OPD in Neil Ratan Sarkar Medical College or NAS Medical College as it's known in Kolkata. Brigadier N.D. Menon started rheumatology in Army Hospital in Chennai. Dr. Hari Vaishnava late started rheumatology in Safdarjung Hospital in Delhi. In 1978, late Dr. Tilwe started rheumatology at KEM Hospital. These centers trained young internal medicine postgraduates and initiated research. Most of the leading rheumatologists of India were the products of these centers. Unlike their teachers, they become full-time rheumatologists. That was an important metamorphosis as rheumatology centers were established and in turn trained young postgraduates evolved with a force multiplier effect, and it is an ongoing phenomenon. In 1980, private rheumatology clinics were established. I started my clinic in 1983 in Bangalore, Samarpan Health Center, I'll show you. And in Mumbai, Dr. Sanjeev Amin started in 1988, and Dr. Pispati started his clinic in 1980, and Hyderabad, U.R.K. Rao in 1994, and Lakshmikant started their rheumatology clinics. And Samarpan, you can see, the right is Sanjeev Amin's clinic, Sridipti of these things, S.J. Gupta in New Delhi. S.J. Gupta's clinic and home served as the headquarters of the IRA for almost 2 decades. The history of the IRA can be divided into pre-2000 and post-2000 eras. It has grown from strength to strength. It has played an important and central role to stimulate, foster, and sustain growth and development. Rheumatology has been accepted as an essential and important super specialty. Today, most major public and private sector hospitals have rheumatology consultants. IRA started having annual conferences from 1984. It has orations to recognize and honor young and senior rheumatologists. The main IRA oration is given to a senior rheumatologist. Earlier it was known as Aventis oration, and later we made it as IRA oration. We had a Boots oration for youngsters. We had also a Nall oration. Now we have many more awards and orations to promote youngsters. In 1983, Padma Shri M.N. Passy, who was a rheumatologist in Delhi, he was the honorary physician to the President of India, and nascent rheumatology in Delhi developed. The Delhi Rheumatology Association started an award because Passy died just few months before our 2004 SZIRACON conference in Delhi. In his memory, they started Padma Shri M.N. Passy Award to recognize and honor the outstanding contribution over a lifetime. This is currently the highest award in Rheumatology Association. Dr. Sachdeva Late from Delhi, who was practicing rheumatology, and me were the first recipients of this honor in 2004 in Chennai, in SZIRACON. Dr. Krishnamurthy was the organizing secretary. Panchapakesh and Rajan was involved in the scientific committee. And Raghupati, who was the central home minister, who awarded. And I am very happy that I received the highest award of the IRA in Chennai. Kalkan oration started to honor persons who have contributed to spread rheumatology and promote the organization. In the beginning, the IRA used to bring a monthly newsletter which was started by Professor Devdar. Professor Chandrasekharan started bringing out Indian Journal of Rheumatology in the 1990s, in 1993 to be specifically. In Lucknow, in DM Rheumatology started in 1976. Dr. Agarwal, Dr. Sita Nayak, Dr. Ramnath Mishra, Amita Agarwal strived hard to develop into a world-class center. Professor Ramnath Mishra has trained nearly 60 rheumatologists over the years who are now working around the globe. Now Dr. Amita, Dr. Abel Lawrence, Dr. Vivek Agarwal, Vikas Agarwal, and many other more are maintaining the premier status. King George Medical University, KGMU, is another center of excellence in Lucknow, started by Dr. Siddhartha Das. All India Institute of Medical Sciences in New Delhi did not have a department of rheumatology for a very long time. Rheumatologists were working under the Department of Medicine for a very long time, in spite of the presence of giants in rheumatology there. In August 2015, an independent department of rheumatology was started by Uma Kumar at AIIMS. Credit must be given to Uma Kumar for her efforts to start rheumatology in the premier institute of the country. And you can see Uma and her department there. Salutations to Uma. PGI Chandigarh is another premier institute which has rheumatology under medicine department. Dr. Aman Sharma is guiding the department. We still don't have an independent department of rheumatology in PGI Chandigarh. The pediatrics department, immunology department headed by Surjit Singh, who is rightly called as the father of the pediatric rheumatology in India, made it into excellent center of excellence the word. He started DM pediatric rheumatology courses in the center. Rajasthan, Gujarat, Madhya Pradesh have developed rheumatology significantly in the last decade. Jaipur, Ahmedabad, Baroda, Indore, and Bhopal have excellent rheumatology setups. Tamilnadu, Madras Medical College, Chennai, has been in the forefront of rheumatology training in the country. The DM program at Chennai has produced world-class rheumatologists who are serving across the world. Professor ANC's Herculean efforts in starting this course is known to all. Maybe the younger people do not know. Rajendran took me one day to MMC and showed there were 2 full rooms, 40 by 40 feet, filled with files, correspondence with the Tamil Nadu government. I don't think anyone would have the patience or the tolerance to do that with the government. ANC did that. He made tremendous efforts and sacrifices to build this department later. It became the first institute of rheumatology in the country and remains the only institute of rheumatology for exclusively. We must appreciate that. Dr. Rajeshwari, a student of ANC, played a crucial role in bringing up the institute. I regret that due recognition has not yet been given to her for her great efforts. Dr. Krishnamurthy, Dr. Parkodi, Dr. Rajendran, and in the private sector, Dr. Rajamani, and many others have made tremendous contribution to the growth of Rheumatology in Tamilnadu. Dr. Arul Rajamurugan, who currently heads the Institute of Rheumatology, has been working hard to maintain its premier status. CMC Vellore, Department of Rheumatology was started in 2004. Debashish Janda joined in 1996. Fellowship started in 2007. DM courses started in 2011. And the department was approved for PhD in 2015. Debashish Janda made a monumental contribution to the growth of Indian rheumatology and CMC Vellore. Under his leadership, the Department of Rheumatology in Vellore attained international status. Dr. John Matthews is now heading the department, assisted by Dr. Ruchika Goyal, Dr. Ashish Matthews, and others. And this is when we pay tributes to Debashish Danda in Institute of Rheumatology. You can see Arul Rajamurugan, Ramnath Mishra, myself, and Ruchika with Rajeshwari there. In Hyderabad, the Nizam's Institute of Medical Sciences, NIMS, started rheumatology OPD in 1995. A full-fledged department of rheumatology was started in 2000. Professor G. Narasimhulu started fellowship courses in 2000, DNB in 2005, and DM in 2007. Dr. U.R. K. Rao started OPD under the guidance of V. Shantaram much earlier in 1995. Dr. Lisa Rajshekhar currently heads the department, and it's also an institute of excellence. This is the NIMS department, frontage of NIMS, and me and Lisa. Dr. Sharat Chandra Mouli at KIMS has built a world-class department of rheumatology with training programs. His CME programs attract national attention. He has contributed significantly to the growth of rheumatology in Andhra Pradesh. Dr. Raj Kiran Duddam, Dr. Varaprasad Rao, Dr. Lakshmi Kant, and the new generation of young rheumatologists, pardon me, I can't name everybody, and it is not intentional, I am saying from the heart, made Hyderabad a major rheumatology center. Dr. U.R. K. Rao, who runs his Sridipti Rheumatology Center, has contributed tremendously to the growth of rheumatology in Andhra and Telangana. In Kerala, rheumatology services are excellent. Dr. Binay Paul, Dr. Ramesh Basi, Dr. Padma Kumar, Dr. Jayachandran, Dr. Anthony Jacob, Dr. Padmanabh Shanai, Dr. Ved Marva, Dr. Suma Balan, Dr. Vinod Ravindran, Dr. Anup, and many others have contributed to the growth of rheumatology. Dr. Shanai Center is the first private institute to be allowed to run a DNB training program. Late Joy Philip has made significant contribution to the growth of rheumatology in the state. And you can see Shanai Center and Vinod Ravindran's Rheumatology Care Center there. In Pondicherry, JIPMAR is a world-class rheumatology department DM program. Thanks to efforts of a very silent worker, not many people even notice him. Veer Singh Negi, a disciple of Ramnath Mishra, built up a beautiful department with the French collaboration. Currently, Molly Tauba is guiding the department very efficiently. That was Molly in 2008 in BSR. In one of the meetings, she had a poster presentation. In Karnataka, Bangalore St. John Medical College has a full-fledged department of rheumatology since 2011. Rheumatology services started much earlier in 2001. Vinita Shobha, who heads the department, also runs a fellowship program, patient awareness and education program, helps her patients financially. Shobha has developed into a world-class department. Her dedication and passion for teaching and training are very impressive, and she is probably the inspiration behind all our cohort studies. It's a pity that none of the 71 medical colleges in the state, only St. John's in Bangalore and JSS Medical College in Mysore, have departments of rheumatology. We have recently started a rheumatology outpatient services in Victoria Hospital attached to Bangalore Medical College, and my young colleagues, Shivraj and Prakurti in Mangalore, also run a department OPD services in Venlock Hospital in Mangalore. I think we should have more and more rheumatology services in the public sector, which is more useful to the people, because institutions, corporate hospital institutions, provide only about 20% of the rheumatology services. A significant number is provided people like me or U.R. K. Rao or Vinod Ravindran or Rajamani in private sector. But people need to, like GH in Chennai, we do not have. I hope very soon we would like to make Victoria Hospital and Bangalore Medical College a hub in rheumatology. Manipal Hospital in Bangalore, Dr. Dharmanand, Dr. Ramesh Jois, Dr. Abhishek Patil, Dr. Benjita Pinto, Uma Karjagi, Satish Kalanje run a rheumatology fellowship training program. Chandrasekhara's Chandra Center has been training program for last 20 years, and its fellows are working across the country. It also runs educational programs, Rheuma TV, and regular webinars. Sharat Kumar and Vikram Raj Jain run Optima Rheumatology Care Center, which is a complete rheumatologist hospital. Dr. Subramaniam at JSS Hospital in Mysore runs a Department of Rheumatology, assisted by Shiva Prakash and Mahabaleshwar. We have very good rheumatology services in Mangalore, Belgaum, Hubli, Dharwad, and Gulbarga today. In Bangalore, we have nearly 50 rheumatologists and 8 pediatric rheumatologists. Unspoken truths and facts. While IRA's history can be divided into pre and post-2000 era, there is really not much to speak about pre-2000 era. Dr. A.N. Malaviya, Dr. V.R. Joshi, Dr. Chandrasekharan are the triumvirate of the IRA. In addition, Dr. Devdar and Pispati did play an important role. My journey in the IRA started in 1998 when I received a postcard from him. In 1993, I became a member of the EC, again due to ANC. I was elected as the president of the IRA in 2000 and served till 2003. I was the EC member for 12 years. From 1997 to 2006, I breathed, talked, walked, and dreamed IRA. There was nothing but IRA on my mind and my heart. My family, my children, my practice become secondary. I tried to make IRA organization strong organizationally, financially, and academically. I neglected my own health, traveled across the country to conduct CME programs and enlisting members into the organization, brought best of the people across the world to India, and made them to talk to our students, whether it's Chennai Medical College or All India Institute of Medical Sciences. Dr. Ashok Kumar, Dr. Ramnath Mishra, Dr. Rohini Handa, Dr. Amita Agarwal, Dr. Alakendu Ghosh, Dr. Krishnamurthy, Dr. Ravind Chopra, Dr. U.R.K. Rao, Dr. Sanjeev Amin, Dr. Ved Chaturvedi, and Dr. Danda, who is no more, have been my fellow travelers in this very long and challenging journey. I have already talked about my first meeting was in 1984 with Pispati. I had come to India, started practice. I traveled to Mumbai, went to Jaslok Hospital, sent my visiting card in. I waited for 30 minutes, and he came out, and he said, oh, you are Mahendranath. Yeah, where did you do your training? Actually, Dr. Pispati did 1 month of training, non-touching the patients in Bath Hospital with Peter Madison. And I had worked for 5 years. He said, you have excellent credentials and all these things. Have a meeting in Bangalore, have it in West End or in a 5-star hotel, and send me a ticket, I'll come and talk. That's the end of it. My relationship was over. In 1990, my first APLAR with Bali, again with U.R.K. Rao, V.R. Joshi, Arvind Chopra, we were all there. I had a presentation, platform presentation. Rao had a platform presentation. There, the registration fee for all these conferences was phenomenally high. Even in 1990, it was $400. Johnny Dharmawan from Indonesia was the president of the APLAR. I wrote a letter to him. We are from developing countries. $400 is my whole year earning. I cannot come and attend this meeting. You must reduce the registration fee for the developing countries people and waive the registration fee. Johnny Dharmawan probably mentioned to Pispati, because he was the vice president of APLAR, a young chap has returned from your country. And in the corridor there, Pispati was complaining to V.R. Joshi. These people are in India, high-headed people, write to president of the APLAR over my head and all these things, as though APLAR president was a god and he was a demigod. So this is how things ran in the country. I still remember, I introduced one of the greatest colleagues from Britain to U.R.K. Rao. He called me aside, Pispati, and said, you should never do this to anybody. People will know that there are other rheumatologists in the country. All right. So this was how this was done. No, I have all respect. People who are gone. I have no animosities, no malices. But people should know the history. IRA's first EC meeting was held in Bhatia Hospital in Mumbai, in Pispati's chamber. I went by morning flight to meet there. There were 4 people. Dr. Pispati, Dr. V.R. Joshi, these are all printed pictures in my brain. I don't need a slide, actually. Nimish Nanavati, Atul Modi was an orthopedic surgeon who was the treasurer of the IRA. They were there. They looked at my feet, looked at my face and said, why are you here? I looked at them and said, why? I'm an elected member of the executive committee of the IRA. Can't I come? Yeah, come. They put cut an extra stool and made me to sit. Then they asked, how did you come? I came by flight. You came by flight all the way from Bangalore for this meeting? I took IRA very seriously. I said, yes. Then the deliberation started in Marathi. Everybody knew Marathi. So I told, excuse me, gentlemen, I don't know your language. Let us talk in English. That day, they marked me. This boy needs to be hit, and hit hard. And they hit me hard. All right. And 1997, SZIRACON in Bangalore, struggle for funds. No pharmaceutical company will come and give and all these things. I had to sell my shares of 1 lakh rupees to keep the money. Then there was one company called Blue Cross Pharma. They said, we'll give you, Peace Party came and said, Blue Cross will give you 40,000 rupees, provided I organize the symposium, I choose the speakers, and I am the chairman. You have nothing to do with that. I was in very difficult situation. One of my patients, who was the chairman, general manager, director of Canara Bank, organized IRA meeting. Young ladies, you there, listen to me. This is important. You will never listen in your lifetime. Let me tell you. All right. Yeah. So then we organized a great meeting. Paul Bacon came. Ralph Schumacher came. A lot of them came. It was the first meeting. Debashish Danda got the Boots Best Oration Award, and Vaidehi Chaudhary. These two people went very long way. Debashish Danda took Indian rheumatology to new heights. Vaidehi Chaudhary is a very big name in America. She's a very bright girl. I had told, you will go a long way, Vaidehi. EC meetings were conducted in a very casual manner, mostly in Mumbai. Members who were not rheumatologists were selected as the president of the IRA, violating all constitutional norms. Except E.N. Chandrasekharan, everybody kept quiet. Nobody said anything. The seniors, Dr. Malaviya, Dr. V.R. Joshi, Dr. Devdar, Tilve, nobody said anything. They kept quiet. My aim was to shift the IRA office from Mumbai to Delhi. And Peace Party said, Mumbai has done everything to the IRA. Nobody has done anything. You can't do this. If you want to shift, it is on my dead body. I said, Dr. Peace Party, even if it's a dead body, your dead body, I will shift the office. And I did shift the office, but he didn't die. I generated substantial resources to the IRA. By that time, I think my prescription power was more, and we were well known. I had reached a level of where I can pay highest income tax, this thing. Without my notice, I must mention this, in 2002, NDTV was the channel. At that time, it has still not become Narendra Damodar Das TV, it was NDTV. They published an article there. They named 4 best rheumatologists in the country. Dr. A.N. Chandrasekharan from Chennai, A.N. Malaviya from Delhi, Sanjeev Amin from Mumbai, and my name was fortunately was there in the last from Bangalore. I don't know how did it happen. They have their own resources and all. I mooted the idea of IRA Bhavan in 2002. It was not this thing. And I contributed personally 25,000 rupees. And till today, I'm the only personal contributor to IRA. We are also given 3 lakh rupees to IRA Bhavan. Later, we withdrew that because they were not thinking of having IRA Bhavan. I was one of the founders of and I also formed the committees to have IRA guidelines. Lupus guidelines was framed by Ashok Kumar, and RA guidelines was framed by V.R. Joshi, later by Ramnath Mishra. And in fact, lupus guideline was so good, Caroline Garden was asked by ACR to form new guideline for the lupus. And Caroline asked, I believe, Mahendranath, you have a guideline for lupus, can you give me? I gave that copy to her. I was one of the founders of the Indo-UK Forum. We organized a joint BSR IRA meeting in Bengaluru. I co-opted Alakendu Ghosh, Dr. Arvind Chopra, and Sujata Hasani to the EC to give a wider representation. There was tremendous opposition from Peace Party. In fact, he wanted Arvind Chopra to be suspended from the IRA because Arvind started BJD India program. And again, Sanjeev Amin helped us a lot. Sanjeev Amin was the secretary of the IRA Bombay. And Sanjeev Amin, in the history of the IRA, only one member has been suspended from the primary membership of the IRA, it was Sanjeev Amin. It was due to Dr. Pispati because he didn't agree with them. Later, I brought back Sanjeev Amin to the organization. I became the chairman of the BJD in 2004, continued until 2008. We did great work in increasing awareness of musculoskeletal diseases and did the largest COPCA study in the world. We involved young orthopedicians and helped them to understand rheumatology better. We worked as umbrella organization along with the IRA. I spent decades in publishing patient education materials across the media in English as well as in local languages. IRA booklet, Aches and Pains, was published in 2000 in Kannada. It was the first book to go to IRA website in Kannada. Later, Chandrasekharan translated into Tamil and published. V.R. Joshi translated into Marathi, and then somebody translated to Bengali. SZIRACON 2002 in Bangalore. Professor Carol Black, President of the Royal College of Physicians, Professor Ralph Schumacher, Professor David Scott, President of BSR, and many others were in attendance. Globalization of Indian Rheumatology Association started. Europe and America started noticing us. Professor Paul Bacon started IRAWA, which contributed significantly for the growth of our knowledge of vasculitis. It is the first special interest group of IRA which has put India's name on the world vasculitis map. Other SIGs like OA and pediatrics were taking shape. These were some of the publications. I wrote and wrote. Lupus, more common than time, awareness, this thing, playing unfit children, pregnancy and rheumatism. You won't believe it, the amount of writings I wrote and published in Times of India, and across India it reached. Not only that, I asked Hext and Aventis to publish some of these things in local languages, in newspapers. I told them, instead of giving me money, buy the advertisement space there. And across northern India, Gujarat, Rajasthan, Madhya Pradesh, Assam, Punjab, Haryana, Northeast, you name the newspaper, I have brought some of them actually show to you. I didn't know there were so many newspapers. And according to the Newspaper Association of India, 50 million people the message reached. Many of my North Indian colleagues are not even aware of that. Why did rheumatology become so famous there? Sudden stroke, blame it on antibodies. Rheumatic pregnancy should exercise restraint and caution. I mean, kept on writing that. See. I also worked towards developing pediatric rheumatology. We had big pediatric rheumatology conferences that were held in Mangaluru, Nagpur, New Delhi, and Chandigarh. I personally contributed financially to every meeting. Patient education awareness program increased across the country. Professor Devashish Danda promoted major activities. These activities have become national movements. All these activities helped the growth of Indian rheumatology by leaps and bounds. All the presidents have contributed to the growth of rheumatology in the country. Some have done a lot, some could have done much more. In 2006, advanced rheumatology courses was initiated. Robert Lahita, Adam Young, Peter Madison, Joe Adu, and Paul Emery came and talked. I made a rule, whoever comes to the talks, at that time, we were not paying anybody to come to IRA meeting. They financed themselves and they came. I remember Carol Block saying 3,000 pounds for a business class ticket from London to Mumbai and Bangalore. They came. Only advanced rheumatology courses, we started paying them economy class tickets. Now the history is different. And they all came and made them to take them to our institution, whether it was Bangalore or Chennai or All India Institute of Medical College. I made them to do teaching rounds there. Teaching rounds at MMC and AIMS. More and more state CMEs, journal CMEs, and interspecialty crosstalks have started. Our presence in APLAR, ULAR, BSR, and ACR has increased. There were posters, plenary talks by our members. I recommended 6 senior rheumatologists for FRCP. They all got. I'm not very techno-savvy, so I can't use the computer. My children help me. If I knew very well, I would have made probably 100 FRCPs of London, because one day I want to see an Indian can become the Prime Minister of Britain, but not the Royal College of Physicians. Vinod knows how difficult it is. He has infiltrated to some extent, but one day I want to see an Indian becoming the Harvard Institute, Royal College of Physicians in England. Probably Vinod can do that, I think. Our presence increased, I recommended, and I also recommended Arvind and Ramnath for ACR Master. Arvind Chopra, I call him the father of the rheumatological epidemiology in India, I not only recommend, when I do, I do it wholeheartedly. I called late Philip Q, who was the credential committee of the ACR, and told, Philip, this person needs, and you must give it, you see. And they obliged. And Ramnath was very reluctant. I proposed his name. I called the credential committee again and told, Sharad, can you please do this? And even before Ramnath was informed, Sharad called me and said, Mahendranath, we have fulfilled your design. I have reputation, my credibility and response, because I don't do wrong things. Because you can't recommend a wrong name. If you recommend a wrong name, they will ask you, the local embassy people, to find out about them, and they will not accept it. So many people are not aware how these things work. I nominated almost all MN Passy awards, and they were all deserving. So I can show this MN Passy Award in 2004, first recipient, and 2006 I became a distinguished fellow of the Royal College of Physicians. Again, Carol Block nominated. I didn't apply, I didn't ask. I also became a BSR fellowship, which is very important. There are only 12 fellows on the earth, BSR fellows, in last 70 years. I am the first non-British, non-American, non-European Indian, and it mentioned for your services to rheumatology. And Karnataka Rajyotsava Award in 2010, Distinguished Alumni Award, Mission Arthritis India Patients Group there, and double masters in 2019, ACR Master, APLAR Master, 2019, Bangalore Municipality Award, and Kempegowda Award, and 2008 South Zone Award. And now I consider this one of the greatest awards because ANC was very close to me. He was very fond of me. And in fact, I remember Dharmanand once told that Dharmanand decided to come to Bangalore. He is there. Why you want to go? Go to Salem or Madurai. Dharmanand himself has told. I've gone to Lady Madhavan Road, had food in his house. He was a vegetarian, and every Monday, wherever on the earth, he used to go to Shiva temple. We have stayed together. Malavia, myself, V.R. Joshi, ANC. And I used to carry ready-cooked vegetarian food. I have cooked upma and poha in my room, and all of us, we have eaten together. I have been fortunate enough in that. So I have tremendous respect for him, tremendous respect for him. I was very happy a few weeks back. I received a landline phone call. It rang. Mahendranath, I immediately was, I am back. I am well now here. I am going to here. I have not yet started seeing patients and all. So this ANC oration, I am ever indebted to Tamilnadu Rheumatology Association for conferring me as the first recipient. Chandrasekharan also, there are people who have done a lot. People who have done a lot. I don't deny that. I have told this to Malavia, V.R. Joshi also, that nobody has done like Chandrasekharan. Many people climbed Mount Everest, but it was Edmund Hillary and Tenzing Norgay. So that premium situation belonged to A.N. Chandrasekharan. I contributed to the best of my ability to the IRA over the last 3 decades and will continue to do so. Because last 20 years of my life have not been separate from IRA's life. This is a fact, actually. I have received tremendous love and affection and respect from my colleagues in the IRA. I can't believe, I must tell you this, my family has contributed. My wife has long-standing interstitial lung disease for 31 years. And Chandrasekhara, Dharmanand, Ramesh Joyce look after her when I am not well there and all. Chandrasekhara's wife, Renuka, a few months back when she was ill, I was ill, everybody, sir, we are a phone calls away. Another young girl, Chandrika Bhatt, a pediatric rheumatologist who had come, who came to the clinic and said, sir, you are very elderly, COVID time, don't go anywhere. If you want to need, buy something, groceries, medicines, I am there. I am really moved, you see, the amount of love and affection. What I have given is very little to IRA, but IRA has given much more. I have perhaps the most globally honored, professionally honored Indian rheumatologist. I dedicate it to the IRA. You can see the ACR award. The president of ACR came and told, Mahendranath, the award was given in the Art Museum of Chicago where Vivekananda delivered talk. She came and hugged me and she said, we should have given you 10 years back. We are aware your work. What I did for patient awareness and education program for 2 decades paid. That was the one. There were very elderly rheumatologists who came to see, how do you have such a large patient base? They came to see me. And Dinesh Khanna, Kevin Pyle, and Chris Edwards there. He's the son-in-law of Graham Hughes, a good friend. Ariane Hendrick, And this is the Appler Award. And Paul Bacon and his family. Jean, I went to see her a few bags. That is Paul Bacon's garden. And the Ganesha and Lakshmi statue, he took it from Bangalore, but they are from Tamilnadu museum there. Rohini Handa and myself, and Ian McInnes, Surjit and me, award ceremony, Lakan Pal and incoming president of this thing, and my family, my dear wife, my daughters, I think they will come after this, and Chandrasekhara, me, and Dharmanand, Rheumatology Awareness Day in Bangalore. We have been doing this, you see. Rohini Handa, congratulations on the singular honor, which is a testimony to your unmatched promotion of Indian rheumatology and Indian rheumatologists. You championed the cause when rheumatology had few takers and industry support was non-existent. SZIRACONs were attended by few dozen, not several hundreds. The sapling you nurtured has grown into a banyan tree. You walked all among your peers and are a role model for the younger colleagues. Salute to the quintessential organization man. Your organization applauds you and your achievements. I believe this is George Nuki. I believe there is no one that has contributed more to the growth and development of IRA as a professional, clinical, and scientific society. In particular, his work in initiating advanced rheumatology courses, IRA Karnataka Traveling Fellowship, and Indo-UK Rheumatology Forum had an important impact on postgraduate rheumatology training in India. Dharmanand stood by me in all these, my endeavors actually. I give complete credit to Mahendranath not only to KRA's success, but a concept of national flavor of the IRA. Otherwise, IRA was only confined to Mumbai. He promoted people who could work for the organization of IRA. Dr. URK, Ramnath, Amita, Ashok, Rohini, me, Danda, Alakendu, Dharmanand, and many others are recognized. This is Ved Chaturvedi. Ashok Kumar says, I always liked your dynamic approach to all challenges. Very few people possess the ability to express boldly in public that they are convinced about the goal they achieved. I do not have to tell what all you did for IRA. I must say that all the honors conferred you are richly deserved. Personally, you have been a great friend, philosopher, and motivator. I recall the Bali, Arvind Chopra says, I recall the Bali Appler days we met. You have steered Indian rheumatology to unprecedented growth and development like no one. You are the icon of rheumatologists. Your loud and honest voice continues to be the conscious keeper of the association. You have never hesitated to call a spade a spade. Sir, you have been a great source of inspiration. Ramesh Joyce, support not only for me, but for many youngsters. It's not only the professional side, but also personal care and comfort you give me and others. Your involvement with us like a friend, guide, and philosopher makes you extra special to all of us. Inclusiveness and nurturing generation next to one thing that all of us should learn from you. Karnataka Rheumatology, your brainchild has today seen a phenomenal growth and is a testimonial to your efforts. Sanjeev Amin says, our highest respect to you are for successful course correction and endeavors of the Indian rheumatology that with your clear vision has challenged the nexus of multinational pharma companies. In those days, we had only physicians with interest in clinical rheumatology, and formal training of rheumatology as a super specialty was taking baby steps in Lucknow and Madras and now Chennai. Political skill, you have single-handedly, with your political skills, lifted the clinical rheumatology in India from the scrapyard to its very prosperous, elegant status of today. Your establishment of Karnataka Rheumatology chapter that made valuable contribution to the past decade. All your awards are immensely distinct. U.R.K. Rao, he is one of the early rheumatologists to propagate rheumatology in India. He is the first person to obtain masters by all prestigious rheumatology associations in the world. Kaushik Chaudhary, you have become a national icon in the field of rheumatology, winning awards and accolades at home and abroad, including prestigious Masters of American Rheumatology. You have been one of the key catalysts for the transformation of the specialty of rheumatology in India. Your vision and collegiate approach have won you friends, admirers, home and abroad. But behind this razzmatazz lies a simple and devoted to your family man. Surjit Singh says, Mahendranath, I have had the privilege and honor of a personal connect and professional association with Mahendranath for 24 years. I value his greatly. Not only has been a constant source of encouragement through his time, his wise counsel and sage advice has been very helpful. Mahendranath held our hands and guided us when we were trying to set up nascent specialty of pediatric rheumatology at the Advanced Pediatric Center, PGIMR. Thank you, sir. Arul, I took rheumatology because of you, sir. When I was a general medical postgraduate, you made a clarion call to medical PGs to take up rheumatology at CME, an organized Madurai Medical College. I owe a lot to you, sir. A friend from England, greeting to a doctor who transforms specialty, how it is perceived in the country. Dharmanand says, Mahendranath sir is an inspirational figure for rheumatologists from all over India. He welcomed me and other youngsters in Bangalore with open arms, and we all flourished blessing from him. His enthusiasm life is infectious. His ability to remember names is legendary. He is the Amitabh Bachchan of rheumatology, and he is the original angry young man and remains a superstar. I don't know, the Dharmanand, whether angry or not. Why I'm impatient? Because very little time left. That is one of the reasons. Dear Mahendranath sir, this is Manjari Agarwal. Sujata Sahani called me one day and said, I have a pediatrician who comes from a very ordinary family. She doesn't have much resources. We want to send her to a European conference, BSR. I said, all right, I send her. And she said, a decade back, you helped a young pediatric rheumatologist to buy a return ticket to travel to UK under fellowship. That was just a small fragrance. I've done probably many more. I don't want to say that. Arup Kundu says, Mahendranath is the soul of the IRA. Rheumatology is his passion. An exemplary, humbler person to be followed by young rheumatologists. You made all of us proud, sir. Present status, the manual of rheumatology was started by Dr. Pispati, followed by U.R.K. Rao, who continued the tradition effectively for many years. Now the manual is a great learning tool for all of us, and it's appreciated. And last month, I kept a manual copy in the Royal College of Physicians library. A lot of clinical subject books were published by Rohini Handa, Aman Sharma, Binay Paul, Vinod Ravindran, and many others. The journal has attained an international status. IRA E-News, keeping all of us abreast with the world of rheumatology. More and more research grants are being awarded. These are the publications. I feel very happy to see them, you see. They are no less than any world-class books, you see. They should be in every library in America and Europe, actually. People are focusing on specific diseases. Aman Sharma is an international authority on vasculitis. Danda was the foremost authority on Takayasu arthritis. Dharmanand has focused on fibromyalgia and soft tissue rheumatism. Vinita Shobha and Lisa Rajshekar are focusing on myositis and lupus. I must also tell Sandhya is focusing on Sjogren's syndrome. Binay Paul is an acclaimed authority on gout and crystal arthropathy. Ramesh Joyce is known as the Paul Bacon of Karnataka. Dr. Vinod Ravindran, Dr. Kirti Talari are focusing on reproductive rheumatology. In fact, Vinod is reaching youngsters across the country how to write articles, how to edit, how to publish. His workshops are always overcrowded. Siddhartha Das in authority on osteoarthritis. There are masters of all like Chandrasekhara, U.R.K. Rao, Padmanabh Shenoy, Sapan Pandya, Mohit Goyal, and many others. Ved Chaturvedi, the foremost authority in spondyloarthritis. And there are great many masters like Ramnath Mishra, Professor Amita Agarwal, Rohini Handa, who continue to be captivating speakers of world class. The future, IRA has a very bright future. I feel immensely happy to see the new generation of youngsters across the country who are extremely bright, innovative, and very hardworking. India is lucky to have people who can take the country to greater heights in rheumatology care. Please continue to strengthen IRA. IRA is our mother. Do not weaken it. It makes better so that the world, we should make it much more stronger. Because APLAR was started by India, but today I noticed in Singapore very strong presence of Pakistanis and Bangladeshis. I went to certain symposiums and special interest groups. Rubbish papers were presented. Rubbish paper were presented. Looking at the posters of Indian rheumatology persons was immensely happy, you see, immensely happy. So whoever it is, Chandrasekhara, next Aman Sharma, Vinod Ravindran, please take interest in APLAR. I would like to see Ved Chaturvedi as the president of APLAR, Chandrasekhara as the president of APLAR, Vinod as the president of APLAR. Make our presence felt. We have immense talent pool. Make use of them. The world should know them. World should know them. Message to youngsters, you are brighter, more intelligent and hardworking than me or my generation. You also have exponentially more opportunities. Do not be in a hurry to make money. Money and fame will come. Take care of your health and spend time with your family. I was very fortunate. 2006 had 2 stents put in, prostate cancer, gout, renal calculi, I still surviving. I used to tell Ramesh, Ramesh, don't neglect your health. I got a warning, you don't even get a warning. So young men, you are very, very important to your family. You are very precious to the family. You are precious to the community because we invested a lot on you. So take care of the health. Spend time with patients. Develop a hobby like reading, walking, music. Have some pets. Spend time with patients. They are your best mentors. You don't have to be in a big ivory tower institution or corporate hospital to achieve glory in rheumatology. I hope I serve as a living example, practicing a small independent setup, never attached to a corporate hospital, never attached to an institution, and become the most decorated rheumatologist globally. I can confidentially say I succeeded in my efforts to globalize Indian rheumatology. My first mentors were my parents, and then my teachers and my colleagues. I have learned a lot from all. And the greatest mentor is the Almighty. These are my parents. My mother went to jail at the age of 16 as a freedom fighter. My father spent 9 years. In 1947, my mother was arrested. Probably she was released very early because she was pregnant. And I was born on December 24th, post-independently. And my dear wife, Shashikala, I'm grateful Rajeshwari mentioned her name. 42 years of our married life, she has stood like a rock. My family, my eldest daughter Viplavi, my son-in-law Raghav, Anvesha, one of the finest, probably acclaimed nutritionist. IRA should listen to her one day, and Prapti. And these are some of the photographs. Our first SZIRACON in 1997. You can see Chandrasekharan there. He was the scientific committee chairman. Manjusri Mitra, Dr. Padmanabhan was the director of the Indian Institute of Science. And you can see the 4 grades of Indian rheumatology, Professor Devdar, Malviya, V.R. Joshi, Pispati, and Dr. Srinivasan, a renowned orthopedic surgeon who was the chairman of the organizing committee. And you can see M.R. Shivkumar, who was again one of the spine backbone supporter of the Iravas with David Scott. And this is APLAR 2015 in Chennai. V. Krishnamurthy solely put tremendous efforts to make the first APLAR in India very successful. He worked day and night hard. I do not think his wife Kalpana and his young kids Anjana and Bharat had seen his faces for together. I don't think we recognize Krishnamurthy correctly. I personally feel Krishnamurthy deserves MN Passy Award, and he should be given the award. I have never made a mistake. I don't want to put anyone to embrace and all these things. And I can see that Krishnamurthy deserves it. And he is always in our hearts, I can say that. And this is our APLAR stall. Vinod took a lot of efforts to put up the stall there. And I think most of the time only Vinod and me were the lone rangers there. And this is in America with my publication patient awareness program in ACR. And this is Ramesh and Dharmanand honoring me first time when I got the Rajyotsava award. And this is Victoria Hospital. Day before yesterday, we started the outpatient. I went there every Thursday, we go there. I sat with Harshini. We saw 47 patients. I saw 15 patients and 4 inpatient referrals, and then came to clinic. Harshini saw most of the patients. We need to do it in a proper way, Vinita Shobha. It should go on. Our services should reach to the poorest of the poor of the people who can't come and give 3,000 rupees in my consultation room. I have decided, as long as alive, I would like to go on every Thursday and work there. And Chandrasekharan, back to Chandrasekharan. Guru Brahma, Guru Vishnu, Guru Devo, Maheshwaraha, Guru Sakshat Parabrahma, Tasmai Sri Guruve Namaha. Chandrasekharan epitomizes every word in this. He is not only a great guru, he is a great human being, very caring and compassionate physician. We miss him here. We miss him here. I wish he will recover very soon and all, and back to us with help us. And I only request you all to give a standing ovation to the great living legend, who is the father of the Indian rheumatology, undoubtedly, and he will remain as the father of the Indian rheumatology. Thank you very much indeed. Thank you. I again thank you for giving me this greatest opportunity, and I cherish this moment. Thank you.
I request you all to continue the applause for Dr. K. Mahendranath as well, before we wind up. Thank you very much, sir. We are honored to have you on stage.
The organizing team of SZIRACON 2024 are immensely grateful to Dr. Mahendranath for this inspiring lecture. We are running short of time, so we'll quickly move on to the next session. So now we'll be dividing into Hall A and Hall B. So I request the speakers in Hall A to be ready. Let me invite the chairpersons for the next session. The next session will be chaired by Dr. Arul Rajmurugan, the HOD of Institute of Rheumatology, Madras Medical College. He's the Secretary of Association of Rheumatologists of Tamilnadu and the Scientific Chairperson of SZIRACON 2024. Along with him will be Dr. Srijita, who is trained in Nizam's Institute, Hyderabad, and is practicing at Manipal Hospital, Bangalore. I request Dr. Arul Rajmurugan to introduce the speakers.
I am very happy to chair this session, which I thought it's a highlight of this whole conference. Dr. Srijita was my medicine postgraduate. She was in my unit, so she was with me for 3 years when doing general medicine. So I am happy to chair this session along with her. We'll move on to the scientific session. So first topic, know-how in genetics. That will be by Dr. B.R. Lakshmi. She is the founder, trustee, and managing director of Molecular Diagnostic Counseling Care and Research Center, Coimbatore, and founder, member, and vice president, Board of Genetic Counseling India, board member of Asia Pacific Society of Human Genetics. She has got PhD in IIT Madras. Next slide. Next slide. Oh, yes. Her field of interest, community genetics, public health genomics, genetic counseling, rare disorders, and creation of models to handle molecular genetic diagnostics. Career highlights are spearhead the state-level project for identification and prevention of Duchenne muscular dystrophy in collaboration with the National Health Mission, Tamilnadu. Directs and leads many research projects funded by Ayush, ICMR, and SPZ. Yuva Shakti Award and Top 15 Women Scientists Award. Honored with the prestigious Community Empowerment Award in 2024 to raising public awareness of genetic disorder by UAE Genetic Diseases Association, Dubai. Welcome and over to you, madam.
Thank you. Good afternoon, and thank you so much for this opportunity. I should thank Dr. Madheswaran Mani, whom I just know for the last less than a month, when he came and spoke about this. And I'm sure I'm an odd man out because I'm not a clinician. I'm basically from IIT Madras with genetics and biochemistry as a base. And thanks for the introduction, sir. And I always strongly feel that science should reach community. And in that way, I've been with neuromuscular disorders, and it was from 2005, and it was started all in Chennai. And then I'm an alumni of Avinash Lingam, where I did my bachelor's and master's, where the founder always used to say, the science which we study should reach the community. So that was something which was strong in me. And when I started this foundation called MDCRC, which is Molecular Diagnostic Counseling Care and Research Center, and I can vibe with Dr. Mahendranath, who just spoke, because ours has also been a long journey, because researchers in India are working together is just happening, and we are working together. And I should say, I have addressed lots of conferences and things, but this is my first to a real group of wonderful rheumatologists, and I'm happy. And MDCRC is a registered charitable trust, and it's a not-for-profit foundation, and we focus on public health initiatives, mainly neglected disorders, and more for the underprivileged. And all what is happening for last more than a decade has been offered free of cost for patients. And it has been a journey in rare or orphan disorders. As Dr. Sandhya rightly said, lots of times when we say rare in India, how is it? I would say it is more orphaned or neglected, because our numbers are huge. And we have evolved a wonderful community genetics model. And this is MDCRC, and we are located inside Royal Care Super Speciality Hospital because we want wonderful clinicians to take care of our children. And we deal with muscular dystrophies. Mainly, I've been focusing on Duchenne muscular dystrophy for more than a decade. And I need not say much about it. You would be knowing. And coming to genetic disorders, any genetic disorder for that matter, where are we? And generally, how it happens is you have a disease with a genetic component, then you map the genes, you identify the genes, then comes diagnostics. Once you have the diagnostic pipeline sort of set, then you start to understand the underlying biology. Then comes prevention, drug therapy, pharmacogenomics, gene therapy. So all this comes through. And for any disorder, the age of onset, the symptoms, the inheritance pattern, all that matter a lot. And of course, all of us know Duchenne has an X-linked recessive, and this is just to give a brief of the background before I really go to share a few insights on the rheumatology. So with regard to Duchenne, as such, we all know it affects male, and it is an X-linked where women are generally carriers. And is there a cure? No, nowhere in the world till the minute, now this minute, there's no cure as such. And for a country like India, the need is to handle this lethal genetic disorder where our numbers with our, generally the statistics is 1 in 3,500 live male births, but our work in the community, it was a house-to-house survey between 2011 and 13, where we found our numbers are 2.5 times more than the global figures. And is there a cure? No. And so the MDCRC commitment has been to identify, to prevent. When I say identify, S at the grassroots level, at the clinical level, and then confirm at the molecular level, which paves way for the prevention of the disorder in the next generation. And we worked with the Vision 2020, and of course, because of the pandemic, it was 2022, where we took on, by 2022, Tamilnadu will be a state where there is no kid with Duchenne who will go unidentified. So if you identify, if you have the molecular basis, you prevent it in the next generation, and we have sort of achieved it, and I have close to 4,800 patients with confirmed Duchenne with us. And so molecular diagnosis becomes very crucial, because generally when a Duchenne kid goes to a doctor, he says, yes, they identified. Lots of times it is just 1 or 2 cases they have seen during their last year of MBBS, and generally what is said is nothing can be done, you please go back home. We strongly say no. Yes, nothing much on the treatment is available, but the molecular base has to be established to prevent, because we have mothers who have 4 and 5 children affected with Duchenne. It really shatters. Today we have the science, we have the technology, and it has to reach. So if we lose this kid, then it is very difficult to establish the carrier status and help in the prevention of the disorder further in the family. And when we say molecular diagnosis, it is very ethical to have genetic counseling along with it. Because even a normal cholesterol or a glucose report, people want somebody to tell them. And when it comes to a genetic disorder, we strongly feel they have to be counseled. And I'm very happy I have been the founder member of Board of Genetic Counseling India. We started it in 2014. It's more than a decade. And every year, we have the first weekend of July, we have a national and international conference. And we have close to around 300 certified genetic counselors in the last 10 years. And so when it comes to genetic counseling, yes, we have the proband, and we have a pre-test, post-test proband counseling. Then you have the carrier counseling, the pre-test and post-test, the reproductive counseling, the prenatal, the premarital, the preconception, all which goes with it, and the psychosocial counseling. And of course, after the corona, the telegenetics has really picked up in a big way. So MDCRC has sort of, in 2021, we completed our 10 years. And as I told you, we have close to 4,800 plus Duchenne's and into 2 carriers whom we have tested. And we have offered all the services possible. And we have sort of, with our commitment and accomplishment, we have redefined Duchenne with our services and initiatives. So it's a commitment, and we have covered the entire state of Tamilnadu. As I told you, district by district. All the 45 health unit district in the rural, we have completely trained the VHNs for the symptoms. And then they have picked, we have camps, and we have trained the PHC doctors. Then once we have 30, 35 of them, then we have a neurologist there. We bring the sample, molecular workup. We go back to the district, give them the report, do the counseling, do the pre-test carrier, bring the carrier sample back, go back with the report. If the mother is in the reproductive age, or they have girls in the reproductive age, that is the sisters, then the maternal aunt, the complete cascade is done to ensure that we do not have one more Duchenne kid in the family. So this has all been possible because of our holistic services, where we have a very strong field and outreach department, the genetic diagnosis or the molecular workup, the genetic counseling, as I told you, which is very crucial, and where the parents are able to take an informed reproductive choice. So that is what, because there's no direction given, but they are all, so lots of mothers say, if I had known, I had a brother, I had an uncle with Duchenne, if I had known. So that if I had known, that opportunity is given for the couple. And okay, all this is done for prevention for tomorrow, and must be any therapeutic strategy that is in the pipeline. But then we have our live children in front of us. They are young, wonderful boys and mentally very agile, growing, tall, nice, wonderful male kids. So we have the multidisciplinary clinical care. We have the international guidelines we follow. And I think ours is a first 10-bedded hospital for Duchenne's, where we offer all the multi-speciality. That is why we are there in Royal Care. So we have the pediatricians, we have the neurologists, we have the orthopedician, the rehab specialist, cardiologist, pulmonologist, all which is needed for our kids. And then the rehabilitation is very strong in our setup, and the family support, which is very needed. And so this has helped us really sort of achieve our vision, and molecular diagnostic becomes crucial. Like say we have been saying no to invasive technique, no muscle biopsy. We just go with blood samples, we extract the DNA. And of course, we can start with MPCR. It depends on what disorder we are going to talk about. Then the MLPA, which does both the duplication and deletion. It's a fragment analysis, copy number variation. And then we have the next-gen sequencing. So the strength of MDCRC is a documentation of every patient who comes in, and the sample numbering, extraction, the molecular workup reports, and counseling. And so when the sample inflow comes in, the diagnosis is done, and then the carrier workup is done. And the most important is the DNA sample, the storage of the DNA. And so we have sort of created genetics and public health, a framework for integration of human genetics into public health practice to serve the community in need. As many of the speakers were saying, finally it has to reach the common man. And we have evolved a community genetics model. Of course, it had its own challenges, but a very contented sort of a researcher or a scientist, where we have ensured that every child with Duchenne, till the last child, the molecular workup is done, we know the mutation, carrier status in the family is established, and we ensure that there is no kid in the family with Duchenne in the future generation which is going to come up. And now, sort of, there have been lots of requests of extending or furthering it to other genetic disorders of various specialities, and we are just talking through it. And so there was an invite from Dr. Madheshwaran Mani, who's a rheumatologist. So the title for my talk is No how in molecular genetics. So this is what was given to me. So rheumatic diseases and possibility with genetic services. So it's an overview. I know there's a short of time, so I will just run through it, and I will be very happy to discuss about it. And again, I'm not a rheumatologist. We are just initiating our work, but a broad thing of what can be sort of shared is what I'm going to discuss with you. So for any disorder as such, you have your genes, and at least with rheumatology, the environment and lifestyle plays a very, very crucial or important role. So the doctor is there, and all the molecular workups and the genetic counseling is very important. And again, with RDs, monogenic, polygenic disorders, it's a very complicated one. Even neuromuscular is complicated because apart from Duchenne's, we have 37 other muscular dystrophies which we are dealing now. But as I started reading for rheumatology and things, I feel it is quite complex. And being with it, the experience is what is going to really bring things out. And I know all of us know the importance of molecular diagnosis. I need not repeat it again as such. Importance of genetic counseling. And more when we say genetic counseling, see, you can just give a test. You want an NGS, you can give a targeted panel, or you can give a WS or a whole genome. But what becomes very important is the interaction with the patient and the genetic counseling, if you want the whole thing to be very complete. Because you talk to the patient about the disorder, you talk about the inheritance risk. What is the type of inheritance? Is it X-linked? It is autosomal recessive or dominant? And so you talk to them about that, and how do you manage the proband or the patient at risk? And how you help them make an informed decision making, and what are the available choices, the pros and cons of whatever treatment methodologies we are suggesting. So counseling becomes very important, and I feel with the gene technology is moving in a very fast pace. But unless ethically, humanely, we sort of support it with genetic counselors who can work along with the clinicians and researchers, it wouldn't be very complete, or it wouldn't really serve the purpose. And you know, the NGS market is growing, and we are sure in the next 15, 20 years, it's really going to grow in a very big way. So the most important, which I felt, is correlation, mainly the clinical context and the phenotype analysis is the base that has to be done before we get into genetics. So detailed clinical examination, the patient-specific symptoms, medical history, physical examination are the first and most crucial steps. For example, even if the same gene is involved in multiple conditions, the clinical presentation may point more strongly to one disorder than the other. So that becomes very crucial, where we have your guidelines and things which is followed, and the phenotypic patterns. I'm sure people would be knowing about HPO and other things. Now with AI, there are lots of things which are coming up, which is making things easier. So when it's phenotypic patterns, specific patterns of symptoms of signs may align more closely with one condition than the other. For example, HLA-B27 is associated with both ankylosing spondylitis and reactive arthritis, but chronic back pain with sarcoidic joint involvement might favor AS, while joint pain following an infection may suggest reactive arthritis. So more to say, the clinical evaluation and the phenotypic patterns are very crucial and has to be set well before we order for a genetic test. And I know they're all stalwarts in the field of rheumatology, but only to bring the context of genetics, I'm just giving a few examples. So the most common rheumatoid arthritis, we have the symptoms and the normal gene function, the HLA-DRB1, and the presence of this allele increases the susceptibility to autoimmune attacks on joint tissues. Now comes the differential diagnosis. Osteoarthritis typically involves non-inflammatory degeneration of the cartilage, often affecting weight-bearing joints with asymmetric involvement. The other is psoriatic arthritis, often accompanied by psoriasis, dactylitis, nail changes with a different pattern of joint movement. Gout, not much is found, but still characterized by sudden severe attacks of pain, redness, and tenderness in joints, often starting with the big toe. So coming to the mutations, we know the gene involved here, associated risk with RA, typical mutation with that. And the differential based on genetics is no specific genetic marker like those of RA. OA is more related to wear and tear, and with psoriatic arthritis, HLA, CW6, gout. So these are something which comes with experience and practice, and again to say the clinical and the phenotype form the basics before we decide on a genetic disorder. And so other than that, apart from genetics, apart from the clinical and the phenotype, the other thing is the other tests which goes with it, like the rheumatoid factor RF, the anti-citrullinated protein antibodies, and of course the HLA, DRB1 shared epitope. So the purpose is identifies the presence of specific alleles associated with increased risk and severity of RA. So how can genetics help in RA treatments is basically understanding the disease susceptibility, improving diagnosis, guiding treatment decisions, predicting disease course and complications, identifying new therapeutic targets, screening and prevention, genetic counseling, and advanced research. So understanding the disease susceptibility, again, 45-year-old woman with family history of RA develops. It's 20 minutes now? Oh, five more minutes. So more to say, I leave the PowerPoint is more to say understanding the disease susceptibility, improving diagnosis. We have umpteen examples on this, identifying new therapeutic targets, which is very interesting. And again, it's more for the clinician, the laboratory person, and the genetic counselor sitting together. I'm sure the progress is much more. Advancing research, the new therapeutic targets which are coming, and the calculation, like what is the impact? More to say, we need to understand the benefit of genetic testing. Yes, in rheumatoid arthritis, 60 to 70%. In AS, it is around 90%. So each one of it has a percentage who can benefit by. So overall calculation is, when you have an RD patient, close to 66 or 67% can sort of benefit from genetic diagnosis. And coming to panels, we have various genetic panels for differential diagnosis. We have comprehensive panels, autoimmune panels, auto-inflammatory panels, and really, if we had more time, we could discuss, but still, these are all available. And coming to NGS panel, we have the autoimmune panels, and we have the purpose and what are the genes included. And various polymorphism which we need to keep in mind, allele frequency and penetrance, and combining genetic information with additional biomarkers. This again becomes very crucial, autoantibodies and other biomarkers, and population and ethnic. This is very important because the pipelines, whatever is used, all is from the West. And I'm sure this body as such, which is growing with time, needs to have your own pipeline, our Indian pipeline, which is very crucial, and that has to be established. And functional studies, where you know lots about the VUS, lots of times you get variant of unknown significance, where functional studies help a lot, and environmental triggers, which we need to understand at the interaction with the gene, family history, and genetic counseling. So in the Indian population, rheumatoid arthritis, SLE, AS, psoriatic arthritis, GIA are the most common. And this table gives sort of a comparison of inheritance pattern and genetic testing consideration for patients with RDs. So we say whether it's germline, de novo, or mosaic, and we need to know whether it's monogenic, digenic, and many times it's polygenic. Family history. So most important is you have a genetic counselor sitting to draw the pedigree and then evaluating, and then the type of, whether it is childhood or early onset or late onset, and what is a preferred genetic testing, whether it is a targeted panel, which is good enough, which is much cheaper than WES, then the WES where it only studies the exon, the whole exome, or the WGS, which is quite expensive unless it is really needed. And what are the pre-test consideration and the importance of genetic counseling. And again, the most common is the targeted gene panels, the WES and WGS. And again, this is available, I can put in the references. And the future is, it's very important because we get into this mode because there are lots of advantage. The molecular diagnostic, genetic counseling, assessment, and important DNA banking. I'll just take a minute to tell why it's important. Research, publication, conference. So the DNA, when we started in 2005 as such, it was only MPCR. Later on, we had the MLPA. So with MPCR, if 100 children with Duchenne are there, around 40 40 to 50, we can sort of pick the hotspot region. But when MLPA came in, we went up to 65 to 70. But still, there were around 25% of the children where we couldn't give a confirmed molecular diagnosis. But the good part is we had the DNA with us. Very well documented and very good condition. We still hope from the first child who came to us. In 2016, when NGS came, we put those samples for NGS analysis, and you wouldn't believe, we rose from 75 to 85% for Duchenne, the point mutation, small insertion, and the rest were all other muscular dystrophies. And again, VUS, there are lots of exciting things which we observed, and more to say, this has to be handled very systematically, and again, to re-insist that a genetic counselor is a very crucial part in your setup when you start your genetic workup. And we are doing it under gene labs as such, and I always want to say, if you want to go fast, we go alone, but if you want to go far, we go together. Thanks, and looking forward for an enriching association. Together we make a difference, and I'm Dr. Lakshmi, and my contact, Dr. Madheshwaran Manivela. Thank you so much. Thanks for the opportunity.
Thank you, madam. Thanks for your illustrative talk. We'll move on to the next talk.
Thank you.
Before we move on to the next talk, I just want to make a small announcement. The quiz for postgraduates, DM residents, is happening in the first floor at Emerald Hall. If any of you are staying back, please go to the first floor, Emerald Hall.
It's my pleasure to introduce Dr. B.G. Dharmanand, Consultant Rheumatologist, Manipal Hospital, Millers Road, and past President of IRA for the next talk. Welcome, sir.
Thank you, Chairperson.
One more comment. So, this topic was given to him purposefully because he was going around with only fibromyalgia. So, I thought, why can't we give this talk and make him do some hard work?
Thank you.
Thank you, sir.
Thank you, Arul, for stimulating me to read. And this is my, unfortunately, this is my fifth lecture this month. And I did speak on endothelium and scleroderma, and I did speak on cancer and osteoporosis. So it's not only fibromyalgia. See, autoimmunity, in contrast to cancer, is much more complex. Probably the most complex of all the diseases we have ever encountered in pathophysiology-wise. Cancer seems to have one single gene. Sometimes that seems to mutate and cause a havoc, and easy to detect, and the gene-based, IHC-based diagnosis and specific targeted therapy is becoming more and more possible. So I would call it as a civil war within, and to my surprise, there seemed to be a movie or a video game called Horror Autotoxicus. I couldn't decipher the language, it looked like Russian. And this is a cartoon idea I gave to one of my great uncles who is a retired cartoonist. So he gave this autoimmunity cartoons for me, and 25 years ago, and it still looks good. So what are our approaches till today for autoimmune diseases? And we were carpet bombing, as somebody was telling in the earlier talks, corticosteroid. This is probably remains one of the earliest contributions of rheumatologists to medicine. So, and after that, we use broad spectrum immunomodulators. We use steroid sparing drugs to reduce the toxicity of steroids. And most drugs are stolen from oncologists and nephrologists, like azathioprine, cyclophosphamide, mycophenolate, tacrolimus, etc. And we did, to our credit, we did develop an induction and maintenance regimen, particularly lupus nephritis, ANCA vasculitis, and few other diseases. Then we moved to, here rheumatology started, probably immunology knowledge started developing little target, though the target is still not known, but the mechanism of action of the molecule is specific to a target. That target may not be very relevant in all patients with lupus. We have B-cell targeting drugs like rituximab, obinutuzumab, and B-cell function modifiers like belulimumab and interferon alpha. And also, we did try heroic attempts at resetting immune system, like autologous stem cell transplantation, and with a reasonable success in scleroderma, but still remains a procedure with significant mortality. Again, we are here learning from oncology. Why oncology research has leapfrogged compared to research in immunology or rheumatology is Nixon's declaration of war against cancer. Somewhere in 80s, Nixon declared openly that we will win the war against cancer, and enormous amount of funding has gone into cancer research. I think we are, to a certain extent, we are getting the benefit of that research, and oncologists have learned to unleash our immune system against tumors with great results in hitherto uncurable cancers like solid tumors, metastatic melanoma, etc. I was talking about immune checkpoint inhibitors, but unfortunately they have given us a new disease to read and treat, autoimmune diseases related to immune checkpoint inhibitors, which can be a problem if you are a rheumatologist or a clinical immunologist attached to a popular oncology center. And Padmanabha Shenoy mentioned about bispecific T-cell engager therapy with blinatumomab. I think we should have a tutorial to help us to pronounce these drugs properly. And that is a drug which can marry a T-cell and a B-cell quickly, and we can ensure B-cell destruction. And CAR T-cell therapy is the latest of this result. It is a marriage between immunology, gene editing, and it's a great translation from bench to bedside in a very short period. Within about 20 years, it has from bench to bedside and clinical approval. Now we have at least 5-6 CAR T-cell from different companies approved for various cancers, including ALL and other lymphomas. So what are we trying to do? We are trying to beat the autoimmunity by playing its own game. We are trying to trick the immune system and try to beat the autoimmune diseases by creating another autoimmune situation. So the chimeric, the antigen receptor T cell, that's what is called as CAR T cell. It is a patient's own T cell, which is infected by a virus, which is neutralized, but ability to carry a receptor called, that is a chimeric antigen receptor, into the T cell, and that is expressed on the T cell surface, and which can go to the target and bind to the target. In this situation, most of the time it is CD19 in the B lymphocytes. So this is a component of a chimeric antigen receptor. There should be an antibody to target the specific protein, in this case CD19, and you need some sequences to keep it on the surface. So we should be able to, we can engineer a molecule, but we should be able to get it into the surface and stay there, make it stay there. And we all know that you need 2 signals for a T cell to be activated, and they could incorporate the second signal also into the same CAR system. So in a single CAR molecule, you have these a molecule which can bind to the antigen and also deliver the second signal to initiate the killing process. The process is, it uses patient's own peripheral lymphocytes. So we have to do apheresis, and this blood sample is sent to the lab, and it is expanded. This process generally takes up to 3 weeks. And we also have a lentivirus. Sometimes retrovirus also have been used in few methods. So the pathogenic aspect of lentivirus is neutralized, and they were engineered to express the CAR receptor. And the they allow the virus to infect the T cells, and the virus enters into the cell, and the DNA gets incorporated into the DNA of the T cell, and that T cell has to expand in the human body, though it is our own cell, but it's not our own cell in true self, because it is a modified cell. It can get destroyed. Our immune system can destroy it very frequently. So you need a conditioning immunosuppression before at least 4 to 5 days before the CAR T cell transfusion, you need to have a chemotherapy regimen with fludarabine and cyclophosphamide. So it kills the T cells. The lack of T cells allows the CAR T cell to multiply and can go into the tissues. Once go into the tissues, it looks for CD19 and binds to it. Once the binds to it, second signal is automatically given because of the inbuilt mechanism. And once that is done, and T cells start the process of producing whatever chemicals to kill the CD19 cells. That goes into, this is how the entire process works. So CD19 as a target seem to be deliver much more broad spectrum results vis-a-vis CD20. There are CD20 CAR T cells were developed as well. They did not do as well as CD19. So CD19, by binding to CD19, seem to induce much more powerful apoptotic response in the B cells compared to CD20. And also the expression of CD19 and CD20 is slightly different. Both of them spare the plasma blast. And BMCA is another target, which is the target in multiple myeloma. But these are also the first patient who used this CD19 plus BCMA, B cell maturation antigen, was treated by a Chinese patient for refractory lymphoma. And that patient also happened to have lupus and lupus nephritis, and she went into a very sustained early remission of her lupus. That was the first ever case in the literature. Then second most popular case, which we all know, is for a German patient who received the cells for a lymphoma. So B cells are relatively expendable tissue. We are able to knock out B cell, and people are able to manage. Though they are at higher risk of infection, they are able to manage. So, and the ability to identify B cell as the prime driver of autoimmune disease also is an important first step before they went ahead with the CD19 and knocking out B cell as the primary goal of inducing remission in lupus. So we have borrowed this concept from B cell lymphoma. When it can do well in B cell lymphoma, let us try it in B cell dominant autoimmune diseases. And rituximab and belimumab do not deplete the tissue B cells. The CAR T cells can go into the cells. It is like a live system. It can go and look for CD19 positive cells wherever they are and knock them out. So this is a cartoon which shows the difference between a monoclonal antibody and a CAR T cell. Monoclonal antibodies, rituximab, obinutuzumab, and all the drugs we are very familiar. There is a drug called inebilizumab, which is CD19 antibodies. We don't know whether CD19 antibodies will also give a good response like CAR T cell therapy. The main difference is it's a living drug. They proliferate in our body and persist for a long time, at least for months. Sometimes up to 6 months they have been identified in at least cancer situation. But in lupus patient, they have not been identified beyond 3 months. And the pros is the deep depletion of B cell, which can be achieved, quick relief. The extent of B cell and also the abruptness of B cell depletion, that seemed to play a huge role in inducing remission in lupus and also probably have a role in resetting the immune system. Whatever B cells repopulate later seem to have a slightly different phenotype. They have a relatively naive phenotype compared to aggressive autoimmune phenotype. This is one of the first studies to come out in lupus. I don't want you to see anything. Look at the curves, how rapidly it drops. So the CD19 cells dropped within a week. So these drugs are very effective and very quick. And look at the SLEDAI and double-stranded DNA. Within 3 months, they've all touched baseline. So this quick relief, almost all patients went into whatever is called DORIS remission or SLEDAI remission within 3 months in these 5 patients. This is again a very busy slide. You will not be able to read everything, but this is a bigger study which was published in NEGM, which brought this drug to rheumatologist attention. And there were 8 patients with lupus. Almost 8 out of 8 got into a DORIS remission. Every patient had their DNAs. Every curve which is going down is antibody. Some of them which are going up are C3, C4. And the similar results were also noted in inflammatory myositis and scleroderma, where Rodnan skin score and other parameters did improve. Again, this is a slide, just whichever is going down are antibodies. But note that anti-Rho or SSA antibody did not go down. So we still, a patient who are significantly positive, maybe Sjogren's syndrome patient, whether they do well with CAR-T therapy is still not clear. CAR-T therapy, the B-cell directed therapy, even after complete depletion, Rho and La antibody don't seem to disappear. So that is one result which could be noted. It may have an implication. And side effect wise, all the rheumatology patients have done well. They had limited amount of side effects. All of them had some infective complications due to various reasons I'm going to discuss with you. And scleroderma and myositis we had discussed. There is also another technology which I will briefly touch in the next slides. They also have RNA-based CAR-T cells. So instead of using a live virus to infect the T cells, they can, messenger RNA they can insert into the T cell, which can express CAR antigen on the surface, but they have a shelf life. They will die because they can't perpetuate, they can't divide. So it is a short-term duration, and the proof of concept is there in myasthenia gravis. All the patients who were tried, they did not require chemotherapy, and myasthenia gravis got better. But antibodies did recover at 9 months, but clinically they remained in remission of more than a year. So these patients may require one more dose, like how we give rituximab once a year, once in 1.5 years, mRNA technology, which may be safer. Why it is safer? It is not a benign procedure. It's not a benign procedure. Infections are due to lymphodepleting therapy, neutropenia. So we need all this antibacterial, antifungal, antiviral prophylaxis, and antiviral prophylaxis for a longer time. Cytokine release syndrome is very common. We are familiar with cytokine release syndrome thanks to COVID. And grade 1, grade 2 have occurred with lupus, but grade 3, grade 4 occurred more with lymphomas and leukemias because of the higher tumor burden. They are reversible. They are eminently treatable with steroid and tocilizumab. And another toxicity is neurotoxicity. It is again due to cytokines breaking the blood-brain barrier. Tremors, cognitive dysfunction, seizures, vertigo, and many other features were noticed. And steroids were used and irreversible. And up to 90 days, many patients had a brain fog. Generally, it resolved, so they were advised not to drive. And late risk of infection, CD19 depletion can be there for a long time, so it can cause hypogammaglobulinemia. Some of the patients required IVIG infusions, and memory cell depletion can lead to sustained immunosuppression, and patients may require shingles and PCP prophylaxis on a long-term basis, and neutropenic patients may require GCSF. So this is the black box warning. A few cases of CAR-T lymphoma, the CAR-T cells persisted, and they started developing a second cancer after a year or 2 years down the line. It seemed to be a class effect. Only few cases of CAR-T lymphomas are identified in the literature of 30,000 patients. And so with this data, does autoimmune disease require CAR-T cell therapy? Majority of the patients do well with our conventional treatment. So we have to choose the right patient for this therapy. This is the mRNA technology I was alluding to. So the CAR-T concentration waxes and wanes, so you may require multiple infusions to sustain the remission. Another limitation is side effects, which we have discussed, but side effects in autoimmune diseases seem to be much less, probably due to the tumor, less the target load, like B cell load, compared to leukemias and lymphomas. And CNS lupus should be excluded. They were excluded in the trials because blood-brain barrier is already broken. The CNS lupus might worsen. So that is a concern. And we should not forget about the financial toxicity. It would cost anywhere close to 50 lakhs. And it is even the Indian-made version, the IIT, first Indian IIT along with some other institution in US have developed the first Indian-made CAR-T, which is approved in October 23 for some of the leukemias. So I'm sure some of the rheumatology institutions would take up and we start a clinical trial. So future of CAR-T cell therapy, we can try to fine-tune the system. There are now technologies to make our own CAR-T cells in our own body. So the time lag between apheresis, sending the sample to a pharmaceutical industry where they will multiply the T cells, infect the T cells with lentivirus, insert the CAR and give it back to us. We are going to immunosuppress and give the T cells. So this takes at least a month. So there can be a mechanism to produce our own CAR-T cells. CAR-T cells can be gene edited or gene engineered. This is my last slide. And to remove the unnecessary drivers of toxicity, like we can have a killer switch which will kill the cells after, say, 1 month. So none of the CAR-T cells are going to persist. And GCSF seemed to be the driver for many of the hematological toxicity, or CRS. So if a CAR-T cell is developed with a GCSF knockout along with the CAR-T, these patients don't develop CRS. And we have CAR NK cells, CAR monocytes, and CAR T regulatory cells, which may be much more milder, kinder way of attacking the autoimmunity. And what is going to come in the future is off-the-shelf allogenic CAR-T. So we can buy it from a shop and start giving. It's an allogenic CAR-T. Advantage of allogenic T cell is allogenic T cells are proven to probably got from patients who don't have autoimmune diseases. Patients' own SLE lupus patients' T cell may have an autoimmune phenotype because T cells do contribute to the pathogenesis. That is one way we can avoid the toxicity. And mRNA CAR-T, which I have already alluded to. So, ladies and gentlemen, Homo sapiens, two-legged apes, have started playing God. Thank you very much.
Thank you, sir. We will move on to the next talk. We will have the discussion at the end. Next, I invite Dr. Ramesh. I'm happy to introduce my colleague, Professor Ramesh. Presently, he is the Associate Professor of Rheumatology, Madras Medical College. He has got so many gold medals. The one person who has spent most of his life in reading textbooks is Dr. Ramesh. You can ask him anything about even the history and everything in whatever is available in the textbooks, which is not available. You don't ask him if it is not available in the textbooks. Over to you. Mind you, your time is 15 minutes. I can allow you 5 more minutes, but stick on to the time.
Thanks, chairpersons, my friends, ladies and gentlemen. Gene therapy in immune-mediated inflammatory diseases, is it a hope or a hype? Next 15 minutes or so, I'll take you through a dream which will be a hopeful dream or a hopeless dream for you to decide. Can you guess who this gentleman is? It's Gregor Johann Mendel. He was an Austrian polymath. He was a Czech born. Probably his genes were more selfish. The selfish gene, the gene machinery. Actually, this topic made me read wider. The more I read, I have come to a conclusion that I know nothing. With that disclaimer, with all humility, I would thank this man. If not for this man, the gene wouldn't have been recognized. Being a friar, he was a monk, Austrian monk, sailing in the ship. He would breed the pea pods, you all would know. Without that, modern genetics wouldn't have been possible. For, you know, the skeptics were always there, and for 34 years, it was just kept away. And then came These two people, can you guess who they are? One on the right is very obvious, Charles Darwin. As he said, the ape from the ape, Dharmanand from the big car, told about Darwin. His cousin was no less a person than Sir Francis Galton. Sir Francis Galton is not known to many of us. He was the one who brought the theory of eugenics. Eugenics was coined as somebody born with all the good traits. But unfortunately, it took a backbench after the World War or during the World War. The Nazis used for many nasty things, and it became a nasty word. But modern genetic engineering is nothing but eugenics in a very dignified form. I'll tell you why. Again, from history, we learned that the gene therapy for human genetic disorders started in 1970s when somebody said, you can manipulate the gene. Siddhartha Mukherjee later writes about the gene. The gene machinery got our own Venki Venkatraman Nobel Prize, and it all started with the concept of the old man, Sir Francis Galton. So I thought this particular meet, I'll make the soul of Francis Galton happy. Francis Galton was a polymath as well. He started his career as a medical student in Oxford, moved on to Cambridge, then moved to math, and like his cousin Charles Darwin, he started riding high seas and went into genetics. So going back and forth, 1972, Friedman and Roblin in their seminal paper got gene therapy for human genetic disease. As usual, the scientific community opposed, because when you manipulate the gene, the downstream events leads to cascade of biochemical reactions, so they did not allow that. But they were doing it in certain places without recognition, or probably they did not bring it to limelight. Technological advances in human genome product, biomedicine, later sequencing helped into effective application. Finally, it all boils to the gene, the environment, the seed is sown, soil is conducive, it comes as a herb, shrub, or a tree. We give it a name. Rose is a rose by any name you call it. An approval for the gene therapies in Europe and US was also manipulated, like how you manipulate the gene. For various reasons, it got an approval, though there were a lot of skeptics. This caused a paradigm shift in genetics. And especially in the dermatology community, the genodermatosis were addressed in a larger number. There were single gene polymorphisms which could be identified. But to look at the evolution of gene therapy, 1928, it was Griffith's transforming principle shook the world. Then Watson and Crick in 1953 deciphered the double-stranded helix. So we knew what the DNA was and what the function of DNA was. And that will be a separate topic. I'm not going into the nitty-gritty of it. In 1990, the first therapeutic gene transfer in ADA patients, adenosine deaminase deficiency patients, they gave a new lease of life. It was China who jumped the bandwagon and said, we will approve it. Then the EU followed suit. Gene therapy is nothing but use of genes as drugs to treat human diseases. Modifying the gene expression or correcting the mutant or the defective genes could be by various means, physical means, it could be by chemical means, introducing a viral vector. The basic principle is to get over the defect. What are the prerequisites for gene therapy? The genetic basis of the disease should be understood. The organs affected should be accessible. Treated tissue should have a reasonable lifespan. And above all, safety of the gene products from adverse effects, which is a big question mark. What are the target cell types? It could be a somatic cell type, or a germline. But the germline, the problem with germline therapy is ethical questions of whether this will lead on to the progeny with different types of problems. Because you look at one, but the gene magnifies into a different one. And as Dharmanand alluded, sometimes the viral vector can become genotoxic as well. The subsequent slides I'll tell you. If at all, 4 cardinal principles if you want to carry home. How do you use this gene therapy? You augment the gene by giving a functional gene, and it knocks off the non-functional gene so that a normal cell comes into. The other one is the gene editing. The malfunctioning gene is replaced by a corrected gene so that you get a near normal cell. Near normal cell, I'm not saying normal, I should have put it as near normal. A gene silencing is the cell with the defective gene, you put a blocking gene and try to take off the deleterious gene, because this goes and pushes that gene away, and this becomes functional, and this becomes a normal functioning cell. The suicide gene is like convincing somebody to commit suicide. You introduce a suicide gene into the cell, and it produces a suicide gene-induced cell death. What are the routes of administration? It could be in vivo or ex vivo. In vivo, you generate the therapeutic gene, deliver into a vector. It could be an adeno-associated virus or a lentivirus, and then it is introduced into the organ or into the bloodstream, depending upon the disease. Ex vivo, you take the patient's cells, you put in the therapeutic gene with the viral vector, grow them in ex vivo, and then introduce them. This could be done with 2 delivery systems, non-viral and viral vectors. As of now, viral vectors are very popular. Non-viral vectors in the form of physical methods, irradiation and other things, and chemical methods. I'll not dwell into the details. Now, switching gears to our rheumatic diseases, rheumatoid arthritis, the therapy for gene therapy started very early, but then it was a hopeless dream for almost 15, 20 years. Animal models were targeted. The targets were cellular targets or the cytokine targets. Since the synovium was hypertrophied, people wanted to try to manipulate the gene, so that they called it genetic synovectomy. But genetic synovectomy did not really take off. So they tried to look at apoptosis of cells. Certain targets were used. Certain cell activators were manipulated, and also they looked at the angiogenesis. The message came from the diabetologists were using VEGF antagonists in proliferative retinopathy. So this angiogenic concept also percolated, but then it really did not take off. And various cytokines were targeted, but then again in animal models it was quite effective. Like IL-4 was targeted, interferon beta gene therapy actually reduces inflammatory cytokines, but then it doesn't make the animal better. Then they started looking at the matrix metalloproteinases. So they targeted using a retroviral gene transfer of ribozymes. It did reduce the invasiveness of the synovium, but this from animal research has not moved into humans. The greatest thing in the animal models was the PUMA gene delivery system, where they found they decreased the joint inflammation damage through a human adenovirus V5 gene encoding a pro-apoptotic gene called PUMA. PUMA stands for P53 upregulator modifier of apoptosis. So with this background, people tried to look at the microRNAs, so that the microRNAs decrease the inflammatory cytokine, matrix metalloproteinase, and chemokine expression. So this was looking perfect. So with that, they moved on to humans. In ex vivo, they tried the IL-1 RA in rheumatoid arthritis synovium. It was successfully transferred. 3 other phase 1 and 2 trials with non-viral vectors like HSV thymidine kinase using TNF, a nuclear factor kappa B decoy, oligodeoxynucleotide. There's no major theory doesn't translate into practice. No major improvement in clinical endpoints. Then comes the Korean study. The phase 1 and phase 2, they had 127 patients. Intra-articular injection of AAV2-derived vector with TNF receptor, FC. The interim report showed phenomenal benefit, and a drug company brought it. It was called, I forget the name. However, the trial was paused because there's one patient death. The interim analysis of the death was due to histoplasmosis. And the NEJM brought out a beautiful report, investigation of the cause of death in the gene therapy trial. But then, you know, I don't know why the lid on the Pandora's box was not removed. Though the FDA said, no, okay, one death with histoplasmosis is because conventional therapy with anti-TNF alpha was there, so they blamed it on that and they allowed the trial to proceed. But however, the company did not. So till now, as of now, we don't have any experience. But looking at it, it seems to be a hope. Future targets are long non-coding RNAs, gap-linked, neat. I do not want to go into the finer details. And microRNAs, they act like sponges. The novel class of transcribed RNAs, probably my teacher Muthu Sethupathi will allude into it. He'll go into the finer details of how it becomes a circle, how it replaces. It is beyond my understanding. There are various targets. I'm sure people will try on that. And VEGF seems to be a little promising end, or that could be a combination of inhibiting these targets. Moving into SLE, as we are running short of time, I'll just say there were only animal models which brought about the decrease in the autoantibodies, decrease in the disease severity, involvement of the kidneys, and it prolonged life. Up to 70% was 40% in control groups. It has not been translated into human studies. In Sjogren, it's exciting time. The aquaporin gene therapy in mice corrected Sjogren syndrome, restored salivary and lacrimal gland flow, decreased the local and systemic inflammation, including the Tarpley score and the focal score. It's quite exciting, and I think this might hit into animals to take on to the next level into human beings. Myositis, yeah, I'll just be brief. Myositis, follistatin, this was borrowed from muscular dystrophy. Follistatin is the gene found to be useful in Becker's, and myostatin is an endogenous inhibitor of muscle growth. So they said, give follistatin, it will inhibit myostatin, and the muscle grows. So the same therapy they have tried in human beings. Yeah, the clinical experience. It's this trial with 6 patients. So it was an inclusion body, a sporadic inclusion body, myositis, given an IM injection of isoform of follistatin. Improvement in 6-minute walk time, distance, reduction in fibrosis, increase in regeneration were reported. The limitations were small group. There was a standard of care administration. There is no control group, poor methodology. Probably if we work on this, maybe we might get an answer. Osteoarthritis, yes, a lot of exciting news happening on growth factors, transcription factors, and cytokines. All are being tried. I'll only talk about the clinical experience. In 2017, Invosa was marketed in South Korea in 253 patients. Intra-articular delivery of retrovirus encoding TGF-beta. It did very well, the success, but then there was cell line error, and it was withdrawn from the market. Despite the error, the US trials were allowed to continue, and no severe adverse events were reported. And the therapy met with its endpoints. Whatever the endpoints were they, but I do not know why it is not brought into market. The future targets, the variety of molecules to be. This is one area of interest, inborn errors of immunity. It has done a dramatic change. As I told you, the hematopoietic stem cell has been the reference standards for variety of IAIs. I used to think that rheumatology will end in hematology, but they not be true, though this next speaker will allude to it. still burdened by the significant mortality. With all that, even with HSCT, the 5-year survival rate is only 74% despite spending so much of money. So they came up with HSC with gene therapy, administration of autologous gene-corrected hematopoietics. It eliminates for a matched donor. Wherever there is no donor, there is no risk of alloreactivity. This is what it says. When you have a matched donor, fully matched, or there's an alternate donor, you go into the HSCT pathway. If you don't have, you come into the gene therapy. So I'll not go into the details of how you do this. Clinical experience till now, the first time the feasibility was with ADA skid. Then proven efficiency in X-linked skid, Artemis skid, Viscott-Aldrich, X-linked CGD, and leukocyte adhesion deficiency 1. The ongoing trials looking at different arms, and it's quite exciting. But at the same time, I also should talk about the flip side. There's a case of T-cell acute lymphoblastic leukemia and a retroviral gene therapy. This was attributed to a gamma retroviral vector and not this, because the viral vector caused genotoxicity. This was overcome by the lentiviral vector, which is a self-inactivating one. And gene therapy strategies are now evolving from gene addition to gene editing. This is what probably Galton thought of in the eugenics, like breed the right. But again, there are a lot of ethical questions. I'll not go into the details of CRISPR. CRISPR is like a molecular scissor where you cut off the dirty genes and introduce the new genes. It started with 1997 in the E. coli, and the journey went up to 2020 to get a Nobel for Emmanuel Carpenter and Jennifer Doudna. You all must be aware of it. That's the mechanism where the molecular scissors act. And these are the disorders in which it has been tried successfully. And this is a famous statement from Jennifer Doudna. She says, the power to control our species' genetic future is awesome and terrifying. Deciding how to handle it may be the biggest challenge we have ever faced. I think it's perfect. I think all of us would agree with this because we are playing with the genes. And he said, are we playing God? At times, I am confused whether it's creation or evolution or a combination of both. And we use God as a insurance. It was Boson who said, it's a bloody goddamn particle, and we took the God particle from it. Ethical consideration. As he said, are we playing God? What constitutes adequate oversight of gene therapy trials? We don't know. Who decides which rights are normal, which constitute a disability or a disorder? I don't know. Will the cost of gene therapy make it available only for the wealthy? Could the widespread use of gene therapy make a society less accepting to people who are different? Should gene therapy be used to enhance basic human traits such as height, intelligence, and athletic ability? Should gene therapy be used to alter germline traits? Should religious beliefs be factored into choosing a gene therapy? I would like to conclude by saying autoimmune diseases, for some diseases, we have a promise. Many, the promise is not kept. But I always, without much skepticism or cynical way, we have to, science grows. We need to look at it in the correct perspective and move further. As far as the IEIs, I think it has become a gold standard at the moment. I would conclude with this famous quote from Walter Shelley, who worked on genodermatology. He's an American dermatologist. He said, never speak the language of despair, nor be the thief of hope. So I'll not rob you from the hope, and I think it's hope and not a hype. Thank you.
Thank you, Ramesh, for giving us some hope for gene therapy in our rheumatic diseases. Thank you. We'll move on to the next talk.
Moving on to the last talk of the session, I welcome Dr. Aruna Rajendran. She's lot experience in bone marrow transplantation and clinical hematology and oncology. On the next topic, that is stem cell transplantation in immune-mediated rheumatic diseases. Welcome, ma'am.
So she is from Madras Medical College. She has done more than 100 bone marrow transplants for the poor children. So I think she needs appreciation. So she is doing a real good service in the government setup. with all the available resources. She is doing a great service. Thank you,
sir.
Doctor.
So I thank the organizing team for giving an opportunity for me to address expert rheumatologist on stem cell transplant in rheumatic diseases. So a disclosure of interest where I have not done a transplant for a patient with rheumatological disease. So, but 2 years back or 1.5 years back, the first year DM rheumatology student from MMC, working under Arul sir, he approached whether we can do a transplant in rheumatological disease. I will tell you why we have not done till date. So for us, autoimmune diseases, we look at it as hematologists, the disease of chronic inflammation. They may come with a single organ and multiple organ involvement with damage or with organ dysfunction. We also understand that they have life-limiting or life-threatening diseases with the central issue of being loss of tolerance and chronic immunological self-reactivity. And now with lot of biological agents available, the disease-modifying drugs are still the standard of treatment. So how does stem cell transplant help in rheumatological diseases? It helps by resetting or rebooting the immune system. So when there is an issue with the hardware, we are very used to it. We switch it off and switch it on. Then it starts getting back to its original state. So it helps in eradicating the autoreactive T cells. We do it by, you give the immunosuppressants softer, we give the immunosuppressants harder. By giving conditioning chemotherapy, which has an immunosuppressive effect, it also eliminates the T cells, which is now proliferating in an autoimmune disease, and helps in thymopoiesis and thymic re-education and bringing back the naive T cells, which learns to be tolerant with the body. And it also, in case of allogenic transplants, which is not much used in rheumatological diseases, it also helps in giving a new immune system, which in time learns to tolerate both allo and autoantigens. So whom should it be offered to? As you would know, it is for the aggressive form of autoimmune diseases, which is not responding to standard therapy. So these are the major indications. So the autoimmune diseases, including rheumatological and non-rheumatological diseases. And then it is very much it's a standard of care in multiple sclerosis, relapse remitting disease, and in systemic sclerosis, Crohn's disease, and in monogenic defects associated with both autoimmunity and immune dysregulation. So to do transplant in autoimmune disease, it may not be possible only with a hematologist. It requires a close conversation between a rheumatologist, hematologist, and the individual patient, assessing the risk versus benefit and deciding based on an individual suitability. And it needs to be done in transplant centers which do high volume transplants, where there is also a feasibility of long-term follow-up. So these are the indications of stem cell transplant. The list is growing. So we do transplants for leukemia, we do transplants for lymphoma, we do for aplastic anemias, we do for relapsed refractory Hodgkin's, non-Hodgkin's lymphoma, germ cell tumors, we do for hemoglobinopathies, primary immunodeficiency disorders, and the monogenic disorders where there is autoimmunity and immunodeficiencies like familial HLH. So there are so many patients with known diseases waiting for a known treatment. When it comes to rheumatological disease, as hematologists, we feel those diseases are unknown, but though the treatment is similar between these two disease conditions. So these are according to the 2017 revised EBMT guidelines. So these are the indications. Usually the indications are divided into 4 categories: standard indication, and the next is a clinical option, the third is developmental, and fourth is generally not recommended. Whereas for systemic sclerosis, transplant is considered to be a standard indication, autologous transplant, and in SLE and vasculitis, polymyositis, dermatomyositis, and in rheumatoid arthritis and JAA, it can be kept as a clinical option for treatment in patients refractory to medical therapy. So when it comes to the diseases of autoimmune in nature, these are the major diseases for which transplants are done. And here, as a hematologist, we worry about their organ involvement. In systemic sclerosis, the skin, the heart, the lung are the major organs that we fear of. In multiple sclerosis, definitely it is a brain disease. We have to manage the disease along with the providing a very intensive therapy. And in Crohn's disease, it is the gut. Here, the primary disease is also in the gut, and the therapy that we give during transplant, we give chemotherapy that also causes severe mucositis. And there, in allogenic transplants, we have seen worsening of inflammatory bowel disease post-transplant. So this is the EBMT data for nearly last 25 years. Around 3,700 transplants have been done for autoimmune diseases, of which 93% of the transplants were autologous in nature. And the major indication, if we see, was multiple sclerosis followed by systemic sclerosis. So how to choose between a medical therapy and a stem cell transplant? So as I mentioned, medical therapy is softer, but it also has high risk of infections, and with longevity of the disease, there is more risk of organ damage. Whereas stem cell transplant, it has the risk of in a short period, we will put them into intensive therapy. Even the therapy can cause mortality, but and the results say there is a 60% chance that they can become disease-free at around 2 years or 5 years post-transplant. But definitely, they also have to be monitored for long-term complications of therapy. So these are the types of transplant. When the patient donates the cells for himself, it is called autologous transplant. When the donor is different from the patient, we call it allogenic. The allogenic can be matched related, where the family donates and they are HLA matched, or matched unrelated, where they are HLA matched, but they are in no way a blood relative of the patient. Or it can be a haplotransplant, where we break the HLA barriers and still transplant with parents or siblings or uncles and aunts who are half HLA matched with the patient. Syngenic transplants are rare because most of the time the identical twin will also have the genetic disease, but there are cases of syngenic transplants. Even in MMC, we have done 2 syngenic transplants for AML. So transplant, we have to sit with the patient, talk to them about the pros and cons of transplant. Autologous transplant has the least mortality of around 1 to 5%, whereas a matched sibling donor is around 5 to 10% mortality. This is only with the procedure. And with haplo or matched unrelated donor transplant, we can expect a procedural mortality of 10 to 20%. So autologous transplant, how is it done? Here, the patient is supposed to undergo high-dose chemotherapy with or without radiotherapy. So first thing is they donate the cells for themselves. So we give the patient G-CSF with or without plerixafor. So plerixafor is an antiretroviral therapy which later was found to have neutrophilic leukocytosis as a side effect and has now become a stem cell mobilizing agent. And when we give this on the 4th to 5th day, the patient, there is a rise in the CD34 stem cell in the blood, and the patient donates the stem cells for themselves by apheresis procedure. It is called peripheral blood stem cell harvest. And then the stem cells are cryopreserved with DMSO. Then the patient undergoes conditioning chemotherapy or radiotherapy. At 24 hours of chemotherapy washout, the stem cells are thawed and given back to the patient. And then he undergoes a period of neutropenia, mucositis, where they are prone for infections which last for around 2 to 3 weeks, and then they recover out of an autologous transplant. So the whole procedure takes around 25 to 28 days, and they remain inpatient in the hospital, taken care of in a transplant unit which will have HEPA-filtered air. So this is the apheresis mission. So this apheresis mission can do stem cell apheresis, platelet apheresis, plasma exchange. So this is for a child, we put a dialysis catheter. For young women also, patients who do not have proper venous access available, we may have to put a dialysis catheter. Whereas if their veins are prominent, elbow veins, they can even donate from their by inserting a needle, and the procedure usually lasts 2 to 3 hours, and the product exactly looks like a blood product based on the level of RBC in the bag. So if you see here, if the RBC is less, it appears orangish red in color. So this is the stem cells. So once the once the stem cells are mobilized, conditioning chemotherapy is given. This is a diagrammatic representation of the same, where then the patient undergoes, in the hospital he stays for 3 weeks, then he is still, we keep him under observation for 3 months close to the hospital and up to 1 to 2 years post-transplant. So the post-transplant complications in allogenic transplant can go even for 1 to 2 years post-transplant. So before we give the stem cells, we have to condition the recipient. Conditioning is also called preparatory regimens, where we create, the marrow space is created. This is very important in allogenic transplants. Autologous also, it is not our aim to empty the marrow, but it is a side effect of the chemotherapy that we give. But in rheumatic diseases, the conditioning purpose is to immunosuppress the patient here. So there is a myelosuppression component and there is a lymphodepletion component. So it helps in also controlling the disease. So at the end of conditioning, the recipient ends up with zero immunity and absent blood cells. So these are the drugs that are there, predominantly chemotherapy. We can also use radiation for conditioning the patient. So chemotherapy drugs are, the lymphodepleting chemotherapy drug classical is cyclophosphamide and fludarabine. As mentioned in CAR T cells, as mentioned as a part of gene therapy, they all use lymphodepleting chemotherapy with cyclophosphamide or fludarabine. The busulfan is a myelosuppressive drug, most of the time used in allogenic transplants, and it is a very toxic drug. Total body irradiation can also be used to lymphodeplete in small doses. When we give doses like 8, 10, 12 gray, then they end up having myelosuppression also. These drugs are toxic. We also use serotherapy, including ATG. ATG is anti-thymocyte globulin, which is usually rabbit or equine in source, and that also has high risk of infusion reactions. And DMSO is the cryopreservative. When we re-infuse back to the patient, they also end up having, we have to monitor for toxicities. So these are the different type of preparatory regimens, myeloablative, reduced intensity, or non-myeloablative regimens. For understanding in rheumatic diseases, we need not give them myeloablative conditioning, but most of the time we use reduced intensity conditioning or non-myeloablative regimens, because our purpose is not to eradicate the stem cells in the marrow, but to lymphodeplete the patient. So these are the phases of stem cell transplant, where the phase 1 is between day 0 is the day when we infuse the stem cells, and then it goes with plus as a prefix. So day plus till day plus 18 to 30, they remain in the hospital. Once they are engrafted for neutrophils and platelets, they get discharged to a nearby home, or they take a room and stay close to the hospital. And once they are okay till 100 days, we discharge them to their home, but they keep coming for follow-up up to at least 2 years post-transplant. So the risk of transplant is during the time of neutropenia, where in today's medical practice we see a lot of multi-drug resistant infections. So there is a risk of serious infection. So the transplant unit is usually available to take calls 24/7 and 7 days a week to address all the ambulatory issues that they have during the post-transplant period. There is a very less threshold to start antibiotics, because to avoid infections or treat them early, and we also give them post-transplant vaccination from 3 months post-transplant. There are long-term risks of transplant. One is infertility. Even if they have completed their family, they may have, women may become amenorrheic. So there is risk of secondary cancers. There is a risk of organ dysfunction because of transplant. Drugs like busulfan can affect the lungs. Cyclophosphamide can affect the heart. So we are going to transplant for an autoimmune disease, but the transplant process itself can lead to secondary autoimmune diseases. So there are 2 diseases where I'll present the transplant data. So if you see here, this is for systemic sclerosis. There are 3 trials, major trials, which have happened, and they have shown that these 3 trials have used different conditioning, whereas the last trial, the SCOT trial, where it was for systemic sclerosis comparing cyclophosphamide versus transplantation. They used total body irradiation, and they found the best response. So it was cyclophosphamide along with horse ATG and total body irradiation. So as mentioned by the previous presenters, when we use radiation, when we use CAR T cells, we reach the tissue autoreactive cells, whereas the drugs are not able to reach it. So when we use TBI as a conditioning regimen, around, the overall response rate was around, I think around 60%, and the mortality when compared to the previous two trials were reduced from 10% to 3%. So I think with time, it is not that we have improved the technique, maybe we are learning to do transplants in rheumatological diseases. So SLE again, when they were treated with cyclophosphamide, rabbit ATG and rituximab, the outcomes were very good. Even at 5 years post-transplant, 62% did not receive did not have a need for major steroid therapy. They were just maintained on HCQ. So these two diseases, I think when they are refractory to medical therapy, is evolving as a major indication for autologous transplant. So allogenic transplant are predominantly, so if you see the numbers, it is very less. So this is one study over a period of nearly 30 years, they have done 128. So we saw 3,000 transplants autologous. Here it is 128 allogenic transplants. And the predominant indications were GAA, SLE. So these were the indications. So in this, especially it is for children when they have monogenic disorders causing both autoimmunity and immune dysregulation. Here we have a risk of graft versus host disease, unlike autologous transplant, where the risk is predominantly infections, autoimmunity, and infertility. So the long-term follow-up is required. Disease flares, there can be incomplete eradication of autoimmune cells. So as we learned in the last study, total body irradiation maybe reduces the risk of disease flare. We can reinduce autoimmunity in the patient even following an allogenic transplant because of their genetic predisposition for the same. 10% of patients who undergo transplants for autoimmune diseases are developing secondary autoimmune disease involving predominantly the blood and the thyroid. So they come with autoimmune hemolytic anemia, ITP, and thyroiditis. There is one case of recorded of lymphoma in the long-term follow-up around 5 years post-transplant. So it is not uncommon for a patient with rheumatological disease to develop malignancies, especially of the hematological malignancies, but this has been noticed even in post-transplant period. So this is a summary. So stem cell transplant is useful for rapidly progressive refractory diseases. There is an experience over last 3 decades, predominantly used in systemic sclerosis, followed by SLE and maybe allogenic transplants for JAA. Autologous is the dominant mode of transplantation, and the type of conditioning chemotherapy that we are going to use, the organ status of the patient finally influences the outcome, and there is a need for long-term follow-up. So in a country like India, like rheumatologists and hematologists working together in starting clinical trials, first, and because the data that we see are predominantly from Western countries, our disease, our patients, the type of infections, our microbiome, and our genetics will be different. So we have to work together to learn more about the role of a well-established treatment or transplantation in the setting of immunological diseases. So a stem cell transplant unit in Madras Medical College was established in 2018 January. So till now, 84 transplants have been done in 2 years period. We do around 40 transplants per year. And from 9 months to 52 years of age, patient group have been transplanted, both for non-malignant and malignant hematological conditions. So all types of transplant, including matched related, allogenic, matched, unrelated, and haploidentical transplants are done with 93% survival. So it is a huge investment by the government in giving public an access to a treatment which otherwise causes a catastrophic healthcare expenditure. So this is our transplant unit, and we sincerely thank the patients and their families, and there is a huge manpower provided by the government to do transplants. There is a huge teamwork from the hospital, from including blood bank, laboratory, the clinical associates who work with us day in, day out to support this program. And with a lot of expenditure from the government, the CMCHIS funds and NGOs, so we are able to do this, provide this therapy. I sincerely thank the rheumatology department. They don't know that we steal their tocilizumab and keep it in our fridge. So we have always 4 vials of tocilizumab for cytokine release syndrome. We never end up using, close to expiry, we give it back to them. But it always gives us like a bank deposit feel having tocilizumab in our fridge. Thank you, sir. Thank you, everyone.
Thank you, Dr. Aruna, for your enlightening talk. Now we know why you are reluctant to do transplant in our systemic sclerosis patient. Actually, we had one severe systemic sclerosis with rapidly progressive skin involvement. Unfortunately, the patient lost to follow-up. Otherwise, we have been trying to do one, at least we start with one stem cell transplant for SSC patient.
Sure, sir.
Thank you, Dr. I think we are very late, running short of time. We will adjourn for the lunch. Any prize distribution? Organizers, yes.
Now we request the chairpersons to present a mementos to the speakers. So first I request Dr. Arulraja Murugan sir to present a memento to our speaker Dr. Ramesh sir.
Can you call the first speaker? Dr. Lakshmi, madam, come.
I request Dr. Srijita ma'am to present a memento to our speaker Dr. Lakshmi ma'am. So you can give a very good applause for other speakers. Also, I request Dr. Srijita ma'am to present a memento to our speaker Dr. Aruna ma'am. And now I request Dr. Arulraja Murugan sir to present a memento to our speaker, Dr. Ramesh sir. So now I request Dr. Ramesh sir to present a memento to our chairperson, Dr. Arulraja Murugan sir. So now I request Dr. Lakshmi ma'am to present a memento. So I request Lakshmi ma'am to present a memento to our chairperson, Dr. Srijita ma'am. We request all the delegates to assemble here after the lunch by 2:15 p.m. in the hall. And also, those who are vacating today, check out and vacating today, we request everyone to submit and give your tags in the SZIRACON stall to get your delegate kit. So once again, a kind attention, those who are check-outing today, so we request all the delegates to get your delegate kit by giving your tag in the SZIRACON stall. And head Department of Clinical Immunology and Rheumatology, and number of publications 60 and presentations 300, and areas of interest systematic lupus erythematosus and systematic sclerosis, And also I welcome the next chairperson, Dr. V. Krishnamurthy sir, Consultant Rheumatologist, Chennai Meenakshi Hospital and Apollo Specialty Hospital, Chennai, and CEO, Chennai Meenakshi Multi-Speciality Hospital. And academics, 20 years of teaching at Madras Medical and Stanley Medical College, published several papers and contributed to chapters in API textbook and manual of rheumatology. And awards, Maitland Memorial Medal for Clinical Medicine, 1979, MMC, Dhanvantri Award, 1995, and Best Doctor Award, Dr. MGR Medical University, 2013, Chennai, and the IRA Master Award, 2019, Indian Rheumatology Association. So we welcome both of you, sir.
Thank you. Good afternoon. I think post-lunch, I think people will start slipping in. And before people go to their, what do you say, siesta, we'll make it more interesting by the talks which we are going to have now. We have very important topics. 3 topics are there on large vessel vasculitis, and then one on the PET-CT, its role of PET-CT in day-to-day practice. And what is the third one? Avacopan. It's a novel drug, C5a receptor inhibitor. So I'll hand over the mic to John Matthew, a young dynamic person, who will introduce the speakers and set the ball rolling for this session.
I would like to welcome Rajeshri ma'am. Ma'am is a favorite for all of us, and she's the active brain behind this SZIRACON. And she has varied interests, particularly vasculitis, lupus, and she's a teacher for many of us, an examiner for many of us. And over to you, ma'am.
Good afternoon. As we are running late, I think I'll just start moving ahead. So I've been asked to talk about mimics of large vessel vasculitis. The large vessel vasculitis that we know of are basically Takayasu and giant cell arteritis, but there are many, many more which can involve the large vessels. Some of them we can bring under mimics, and the basic method of trying to comprehend or understand them is like how to approach is just like how we do in internal medicine, congenital versus acquired, infective versus non-infective, inflammatory versus non-inflammatory, and all the mimics. Here I will deal only with some of them which we really don't know. Some conditions mimicking large vessel vasculitis among the congenital are Erdheim-Chester's, infections, tuberculosis, syphilis, including HIV, systemic diseases like RA, SLE, Sjogren, etc., spondyloarthropathies, APLA, never to be forgotten, IgG4, and of course the traditional fibromuscular dysplasia and atherosclerosis given in the classification criteria itself, and something new, segmental arterial mediolysis, and we can include Cogan's and Bechet under the variable vessel disease because they involve the large vessels. Starting with some of the rare congenital disorders, it's Erdheim-Chester's. Here you get periarterial thickening of the whole aorta and its main branches. Sometimes ectasia can be seen and stenosis as well. Basically, it's a Langerhans type of histiocytosis with BRAF 5-600 mutation in MAPK as well. Here you get xanthomatous histiocytes. Drugs of choice are steroids, interferon alpha, mTOR inhibitors, and cytotoxic drugs. This is the Erdheim-Chester. You can see the arrows over there, well-marked arrows. And this surrounding the kidney, you can see the fat stranding. And this is called as a hairy kidney sign. And surrounding the aorta, you can see the thickening over there. This is called as a coated aorta, very classical. And here you see the iliac arteries being cut off. Wasting time. I don't have time. Okay, I'm very tall now. Okay. Next is about the common disorder we know of, the coactation of aorta, which we have to distinguish from pseudocoactation. We know commonly it's post-subclavian, and there you can see the E sign classically in the barium swallow, and that is this is a 3 sign in imaging. How do we distinguish pseudocoactation? It's basically because of a highly placed cervical aortic arch. It's due to the kinking and buckling with absence of stenosis of the aortic lumen, with no collaterals, absent LVH, and absence of ascending aorta dilatation, which are all seen in coactation. Next comes Marfan syndrome, and all of us know about Marfan's. There you see the ascending aorta dilatation and the arch of aorta dilatation, and descending aorta, which is type B, which occurs in pregnancy, very classical. Next is Ehlers-Danlos. It's an autosomal dominant. It's due to collagen 1A1 and collagen 3A1 mutations. It's a type 4 variety which produces the vascular complications, and there you can see all the areas that are involved. In Ehlers-Danlos type 4, from head to foot, all the vessels that are involved. Basically, it produces aneurysmal dilatation, aneurysms, and dissection of the aorta. There you can see it. Then comes this rarely known syndrome called as Loeys-Dietz syndrome. It's an autosomal dominant. It's due to TGF beta receptor 1 and 2 gene mutation. Here you see arterial tortuosity, aneurysms of the head and neck, and abdominal arteries. There you can see the tortuosity of the cervical vessels, and here you can see the aorta dilatation, especially the ascending one. Then comes neurofibromatosis type 1, which is an autosomal dominant. It's due to a mutation of neurofibromin 1 gene and tumor suppression gene mutation. Here you can see aneurysm, stenosis, and aortic coactation with AV malformations. There you can see the coactation, you can see the aneurysms over there. Next comes infections. Of course, all of us know commonest is tuberculosis, and there are various mechanisms by which it can affect the aorta. There you can see the stenosis over there. You can have aneurysms, and you can see the thickening also. This occurs in active tuberculosis. It can be due to hematogenous spread, vessel wall erosion by contiguous adenitis. Pseudoaneurysms are very common. Others are true aneurysms with aortic narrowing. This is a picture of a patient we had in MMC showing the aneurysm. It's like a saccular aneurysm which never occurs in large vessel vasculitis. They're all fusiform aneurysms with a thrombus over there. This is after treatment. This patient had tuberculosis. Next infection, all of us know syphilis. Syphilis classically spares the abdominal aorta, so you have the ascending aorta, arch of ascending aorta, arch and descending aorta, and the coronary arterial ostia are involved, so you have coronary ostial stenosis there, and then you can have the aneurysms occurring here, sparing the abdominal aorta. The mechanism is due to the pathology is obliterative endarteritis of the vasovasorum. Cell-mediated immunity also plays a role. Next comes HIV. You can see multiple aneurysms everywhere. And here also, it's due to inflammatory mediators, endothelial dysfunction, and smooth muscle proliferation. Adhesion molecules play a role, as well as cytokines and chemokines. Next is the connective tissue disorders. All of us know that RA can affect any vessel. When it affects a large vessel, it classically mimics Takayasu. You can see the thickening, circumferential thickening around the aorta. And then you can also see these type of involvement in Sjogren, SLE, and sarcoid. And sarcoid, it can be associated with adenitis, lymphadenopathy. Relapsing polychondritis, all of us know, due to inflammation of the cartilage. And there you can see around the blood vessel, you can see the thickening, mimicking giant cell arteritis. Here it's due to unidentified cartilage antigens producing immune reaction against type 2 collagen. Inflammation, fibrosis, aneurysms, and aortic regurgitation are the manifestations. In spondyloarthropathy, basically, it's due to a common type 1 collagen in the aorta and sacroiliac joint. That's how it involves the large vessels. It produces a proliferative endarteritis. It can produce cellular inflammation and fibrosis. So the end result is aortitis, annulus dilatation, and aortic regurgitation. Next are the variable vessel ones, Bechet and Cogan's. Bechet is very classical. We have to keep in mind, as I already told you, you don't get saccular aneurysms in the two commonly known varieties of large vessel vasculitis, TAC and GCA. There you can see, this was in one of our patients in MMC, producing the saccular bulges. And whenever you suspect or see a pulmonary artery dilatation with an aneurysm, always think of Bechet. No other manifestation can be there except that. So this is called as Hughes-Steuven syndrome. And there you can see the Cogan syndrome. Here, inner ear and ocular manifestations also can be there. Then we have the IgG4 related disease. All of us know a lot about it now. It's due to infiltration of lymphocytes and plasma cells, storiform fibrosis, and obliterating phlebitis. Previously, we thought it was due to retroperitoneal fibrosis, didn't know the etiology. There you see the thickening. Then we have a condition called as isolated iritis, which we do not know much about. Here, the predominantly affected age groups are male and younger patients. Here, the arch, thoracic, and abdominal aortas are involved, while the branches are spared. There you can see that. Then we have the apla. All of us know. You can see an abrupt cutoff over there of the vessels. And here you can see a thrombus inside the aorta. The white one is the blood. Collaterals may or may not form. Then we have the segmental arterial mediolysis. It was very new to me when I saw the mimics. Here, males and females are affected equally in the age group of 40 to 50 years. And you have visceral arthritis, especially the mesenteric arteries are involved. You can have a string of beads appearance, dissections, alternating stenosis and aneurysms. Thrombosis does occur as well. They are non-arteriosclerotic, non-inflammatory, with tunica media lysis producing vacuolation, and usually the precipitating factor is smoking and tobacco. This occurs due to repetitive vasoconstriction, and statins, antihypertensives, and antiplatelet agents are the drugs of choice. Here you can see whatever I have described. Then we have the middle aortic syndrome. Obviously, the name itself is descriptive. It's due to narrowing produced by segmental or diffuse narrowing of the abdominal and descending thoracic aorta alone. This may be genetic or acquired. Genetic is a developmental anomaly occurring due to lack of fusion or anomaly in fusion or maturation of the dorsal arteries, producing fibrosis in the suprarenal and extra-aortic area. Acquired may be due to Takayasu. Treatment is treat the hypertension with calcium channel blockers and antihypertensive statins. If nothing works out, plasty and bypass. Then we come to fibromuscular dysplasia. This is given in the classical original ACR classification of Takayasu arthritis. You have to exclude fibromuscular dysplasia and atherosclerosis. Why I put these slides last was because these are the common things we should rule out, and we should know more about these. Keeping, of course, in mind about the other conditions which I spoke about. So what is fibromuscular dysplasia? It occurs in age group between 20 to 30 years, females being affected more than males. Classical clinical manifestations are headache, claudication, dizziness. It's a non-inflammatory condition, a true mimic. Renal arteries, intracranial arteries, intracerebral, vertebral, mesenteric are all involved. Many varieties can occur, classical being the string of beads appearance, the focal concentric narrowing, and diffuse tubular stenosis. Aneurysms can occur as well. Dissection can occur as well. It can produce renovascular hypertension. Clinical manifestations may be due to TIA, CVA, myocardial infarction, renal infarcts, and mesenteric ischemia. So this is the classical variety producing the string of beads appearance. You can see it affecting the renal arteries and their intracerebral. I'll show you a diagrammatic representation of this. There you see the string of beads appearance, and you can see the focal stenosis. You can see the dissection over there, and then you can see the aneurysm here, and then, of course, you can see the tortuosity here. And this is the way it occurs, the symptoms it produces in this diagram. And these are the areas that are involved, as I told you, the cerebral, the coronaries, the renal, and of course, the iliofemoral arteries. Iliofemoral arteries are mostly not involved, especially in Takayasu. And remember, the aneurysms in Takayasu and GCA are always fusiform aneurysms. Atherosclerosis, the commonest condition. Here, the sites affected are abdominal aorta, infrarenal bifurcation, ostia, upper limb arteries are spared. Remember, upper limb arteries are spared. Aneurysms can occur with narrowing in branches. One thing which was new to me was this. Monoocular vision loss is very common in atherosclerosis. It's called ischemic optic neuropathy, but it's a non-arthritic, non-inflammatory. It is due to multifactorial causes. It can be due to disordered optic autoregulation, hypertension, and diabetes. It can produce CRAO, central retinal artery occlusion, branch retinal artery occlusion, atherosclerotic plaques, and emboli as well. It's the ocular counterpart of ischemic stroke. It predicts an impending stroke. How do the lesions occur? They can be punctate, linear, discrete plaques, localized hot spots, localized thickening of the intima media thickness. So this is how they occur. See at the branching points at the ostia, they are eccentric plaques. They can be linear, hot spot, or discrete. We should know how to differentiate by using the simplest method, the ultrasound Doppler method, in the easily accessible arteries, the carotids, the common carotids, by measuring the intima media thickness. That is the intima media, where the arrow points out, and it is uniform and circumscribed, circumferential in Takayasu. Same thing can occur in GCA, especially in the temporal arteries and in the axillary arteries, where it's called as halo sign. Here it's called as a macaroni sign. Well circumscribed, circumferential, uniform thickening. This produces a mild or slow slope sign. Whereas an abrupt slope sign, like a step sign with eccentricity, is seen. This is the asymmetric atherosclerotic plaque. So you see the difference between this and this, they are called a step sign. So I conclude by saying all large vessel involvement is not vasculitis. Takayasu and GCA by themselves have their own similarities and differences. Mimics are many, and they say, forget me not. Thank you very much for the opportunity. I hope I finished on time. Thank you so much.
Thank you, ma'am, for that great presentation. If there is a quick question, actually, people tend to... Is there a question from the crowd? Ma'am, shall I ask a question? Ma'am, you had a patient with tubercular saccular aneurysm. If he had no other organ system, how was the diagnosis established?
No, we initially thought it was Takayasu only, because those days, anything with large vessel involvement, anything with an aneurysm, we never even thought of Behçet, because we really didn't know how to differentiate Behçet and other conditions from this large vessel disease. And Sen Gupta in 1964, he was the one, and right from 1964, I was very much passionate about Takayasu. So I used to read a lot of articles, and then...
No, ma'am, how did you establish diagnosis in that patient which you showed? Saccular aneurysm?
No, he had adenitis. I forgot to show you the adenitis.
Okay.
Biopsy was done from that, and it was proved. And of course, the MANTU, QTB was not there those days.
Okay.
MANTU was highly positive, and it was histopathology proven. That is how Sen Gupta et al. Discovered it, because of the presence of contiguous adenitis near the
that was
vessels.
an excellent lecture. And do you see lutic aortitis? Because you were in GH. Yeah,
that was during our days, I think, last time.
Recently, and
we've
that's
seen
what
the
I'm
arch
asking.
of aorta aneurysm pulsating like that, and the sternum
Not
pulsating.
only tuberculosis infection, those days we used to get lutic aortitis, and that can mimic like a large vessel vasculitis.
Yes, yes. Nowadays, I think our youngsters would never get to see a syphilitic
Thank you.
tertiary
Thank you so much
syphilis.
for want of time.
Thank you, ma'am.
Thank you so
Thank
much.
you,
Excellent
thank you.
talk. Thank you.
I would like to invite Dr. Ruchika Goel. She's a lady with a brilliant brain. And if you have anything to ask about vasculitis, it's ask Ruchika. Anything, anywhere, I think, I can't think of anybody in the world who had so much knowledge about vasculitis than Ruchika. But over to you, Ruchika.
Thank you, sir, for the kind introduction. And I would like to thank the organizers of this conference and Arul, sir, for giving me such a topic. It is like fresh from the oven. All right. So I'm supposed to talk about avacopan in ANCA vasculitis. What is avacopan? Most of us know it, but it's nice to reiterate. So basically, it is a complement inhibitor. It inhibits complement 5A, C5A receptor. Now, that is the difference between avacopan and eculizumab. Eculizumab and vibobelimab, both of them are also target the C5 pathway. But eculizumab, actually, it inhibits C5, as a result of which it also inhibits C5b and thus inhibition of MAC complex, thus results in more infections. Whereas avacopan, it selectively inhibits the 5A receptor. The same is vilobelimab, which is out of the scope of this talk. However, belimumab also is coming up as a new molecule of the same pathway. Now, before we go to avacopan, it's nice to recapitulate what is the role of complement pathway in ANCA vasculitis. So these experiments, they are really elegant experiments, which dates back from Xiao and Schreiber's group from Professor Jennett's lab, wherein the researchers, the investigators found that in the ANCA-associated vasculitis mice models, wherein they induced ANCA vasculitis by anti-MPO IgG injection, what they found is that the wild type, this is the pointer? Yeah. The wild type mice had developed necrotized glomerulonephritis, but the mice which had a knockout of C5 actually had it had a protective effect, and they were protected from the necrotizing crescentic glomerulonephritis. The same set of investigators went on to do another set of experiments in which they showed the same results when you basically knocked out the mice for factor B. However, the mice which had a knockout of C4 did not have the amelioration of necrotizing glomerulonephritis, thus suggesting the role of alternate complement pathway in ANCA vasculitis. This was followed by the in vitro studies on human neutrophils, where they incubated the human neutrophils with ANCAs, and they found that there was increase in C3A levels, meaning to say that C3A has a role in pathogenesis of ANCA vasculitis. The same group of investigators further, as a proof of concept, treated the mice who had been injected with the anti-MPO IgG. And what they found is that the small molecule inhibitor of CD88 moiety of human C5A receptor had a decrease in the percentage of crescents, the percentage of decrease in hematuria, proteinuria, leukocyturia, and also they had an overall decrease in the renal scores as far as the necrotizing glomerulonephritis is concerned. So this was followed by the 2 phase 2 trials, which is CLEAR and CLASSIC by Professor Janeway's group, which I will not be discussing in detail because we have a phase 3 trial. And most of the talk henceforth will be basically dealing with ADVOCATE trial. So this was the trial, the landmark trial, which I think if avacopan comes to India, we'll be reading about it more and more. So basically this is it's a randomized controlled trial on 300 naive or relapsing ANCA vasculitis patients who were given either the standard of care or were given the interventional drug, which is avacopan, as an add-on to the standard of care. Now, it's very important to know in this trial what was the standard of care. So the standard of care was basically, it's an induction trial where you were talking about the induction of remission and not the maintenance. So in the rituximab, basically in the in the standard of care, the investigators treated the patient either with 4 weekly doses of rituximab in the dose of 375 per meter square, or they gave IV cyclophosphamide for 12 weeks, which was followed by azuran after 3 weeks of the last cyclo.
But the rituximab arm did not get any maintenance therapy after that. Along with that, the patients were started on 60 milligram of methylprednisolone along with 60 milligram of prednisolone. But this prednisolone was tapered to 0 at week 12. That is, we are talking about 3 months. And after that, the patients on rituximab did not receive anything, and the patients on cyclophosphamide received azathioprine. Whereas in the avacopan group, the standard of care remained the same, except for the patients, instead of prednisolone, received the placebo, and along with that, 30 milligram twice daily of avacopan, which was continued throughout the 26 and 52 weeks. Primary endpoint was at 26 weeks, and secondary endpoint was at 52 weeks. So what was the result? Obviously, it was a positive study. So what they found is that the remission in avacopan group was similar to the remission in the standard of care at 26 weeks, which was in the range of 70%. However, when we went to 52 weeks, as was expected, the graph started diverging, and avacopan group did better as compared to the standard of care group. Now, mind you, we should understand that the patients on standard of care did not receive any maintenance and steroids after 12 weeks of therapy. And even the patients who received cyclophosphamide got azathioprine only up to 24 weeks. So we are basically, it looked like the investigators had taken a very good choice of standard of care. But however, I don't think it's to be, the investigators are to be blamed, because this trial started in around 2017, when there was not much of rituximab hadn't found its place in the maintenance of the remission in ANCA vasculitis. Now, what was the side effect profile? I would like you to remember these figures. 33% higher in the standard of care. So overall, when you look at the relapse rate, it was to the tune of 8% and 10% in the avacopan group, as compared to 20% in patients who had received standard of care. Glucocorticoid toxicity, as is expected, it was definitely better in the avacopan group as compared to the steroid group. Now, I was told by investigators that, the organizers, you should put the whole thing in Indian context, avacopan in Indian context. So I would like to go, this is a very beautiful collated data by Benjamin Terrier's group, in which they had looked at all patients who had been recruited in Main-Ritz-San group of trials, Main-Ritz-San 1, 2, and 3. So when we look at the major and minor relapse together, at 28 months, we are basically talking about 5 and 11. That is around, let's say, less than 10%. While, if you remember in the avacopan study, the major and minor relapse together at 26 weeks was to the tune of less than 10%. So it was around 8 to 10%. So that means, as of now, where we stand with rituximab, we stand almost at par with avacopan. However, and when you look at the serious adverse events in this Main-Ritz-San trial overall, it was around 26%, which was a little higher as compared to avacopan group, but still it holds fairly well. So it is something like, Tesla versus Honda City. For us, avacopan is Tesla. It has not come to India. If it comes, we'll see. But we are okay with Honda City, because rituximab, as of now, is not equal to Alto. It is still Honda City. So keeping in mind, actually, avacopan it got the approval from FDA as well as from European Medical Agency. However, the Canadians were a little smart, so they have not given the approval for avacopan to be used as far as the insurance policies are concerned, because if you look at the health, the improvement in the quality of life, which I have not touched upon, and you look at the cost, they realized that the cost-benefit analysis, it doesn't hold in favor of avacopan. So it stands still there. So maybe our DGCA also may follow the same policy. Now we'll go to out-of-trial setup. So we talked about some of the unanswered questions. I'll go straight to that. So this is a real-life data, which is basically, there are two data. One is from the French Rapid Access Program, and the next one is from the Mayo Clinic. So in the French Rapid Access Program also, avacopan did successfully help in reducing the steroid dose to 0 at month 12, with an increase, with a definite, increased rate of remission in up to 80% of patients. And 4 patients even reached a complete remission without any concomitant use of glucocorticoids. This is the same, another study, basically this is 92 patients, a retrospective analysis from US group of investigators, wherein again they showed that the remission rate was to the tune of 80 to 90% with the improvement in GFR over time. 20% of the patients stopped Avocapan due to adverse events. What are the adverse events? So other than the infections, what we expect, the most important toxicity which people are concerned about is the liver toxicity. Even in the advocate trial, it was around 5% of the patients in Avocapan group did develop hepatocellular damage. And this is also supported by many letters. Actually, the case reports are coming from various parts of the basically Japan. It's predominantly from Japan, where they have shown severe prolonged liver abnormality, a case of vanishing bile duct syndrome, and even in the pediatric cases, the liver injury. So liver injury is definitely a concern, and that is why US FDA and EMA, both of them have introduced a caution in patients with a pre-existing liver abnormality. Next one is a thrombocytopenia. I could find one case report, again from Japanese group, so in which they showed thrombocytopenia. So probably if the drug comes to our country, then this is what we have to look for other than infections. Now, in the trial setting, advocate trial, the patients, the first recruitment criteria was that the patient should have a GFR of more than 24 mils per minute. So what about in severe AAV? So we have 2 studies, actually, in patients who have a renal involvement. One is a subgroup analysis from advocate trial, wherein some of the patients had less than 20 mils or equal to 20 mils per minute of GFR, and they found that Avocapan actually led to an improvement in GFR in these patients, which was like 27 in Avocapan group and 23 in prednisolone group. Then this is basically a real life data, which again has, like, it's a 4 patients data, wherein they have used Avocapan in patients who had a GFR of less than 50 mils per minute. And again, they found that as you go over time, the serum creatinine decreases or it stabilizes. It decreased in 3 patients and it stabilized in 1 patient with the stoppage of steroids at around 12 weeks after the use of Avocapan. So it does have a steroid sparing efficacy, especially in patients with a severe renal disease. What about diffuse alveolar hemorrhage? So again, you have 2 studies. One is from Mayo Clinic, which involved 15 patients, and they found that there was a complete remission in 7 patients who started Avocapan early, and in 88 persons who started Avocapan later in the course of the disease. And around 60 to 70% of the patients with DAH could stop steroids as soon as 3 months after the Avocapan. Serious infections were seen in 2 patients. Then this is another paper from Cambridge group, wherein you had again 8 patients, out of which 4 patients actually required mechanical ventilation. And what they found is that all 8 patients had a complete resolution of the DAH. They could come out of ICU. The survival and sustained remission was also in 8 patients. And at a median follow-up of 1 month, steroid was decreased to 5 milligram per day at 1 month, and 3 discontinued the steroids. Now, this is the only case report which I found in patients who had extra-renal and extra-pulmonary disease. This is a patient who had ocular complication in the form of refractory ocular orbital mass. And they found that this mass actually reverted back to normal over time. This was a patient who was refractory to multiple course of other therapy. So it looks like a very promising molecule in extrapulmonary disease as well. What about giving it as a first-line treatment? So this is the only study I got, 9 patients from France, wherein they had 5 patients were de novo, whereas 4 patients were relapsing, but they were not refractory. Like, they did respond to treatment. And what they found is that they could actually get a reduction of prednisolone as well as an increase in GFR over time, and it just mirrored the advocate trial result, meaning to say it definitely works in real-life setting as well. Because of this, in EULAR 2022 update, Avocapan found its place instead of steroids in patients with active GP and MPA, as far as the induction of remission is concerned. However, in maintenance, we do not know because we have no data as yet on how this drug is going to act as a maintenance agent. To summarize, avacopan is an effective steroid-sparing adjunctive induction treatment agent in ANCA vasculitis in the trial setting, as well as in the real life. It appears to be effective in severe renal disease too. The real life data suggests that its efficacy, it's useful in patients with diffuse alveolar hemorrhage. As of now, there's one study to support its upfront use as an alternative to steroid in some cases. However, cost efficacy analysis is required to find its place in Indian context, especially as a maintenance therapy. Thank you for patient hearing.
Thanks, Ruchika, for that brilliant presentation and the clarity of presentation. It was quite clear. Is there any questions from the audience, from the registrars? You should ask. No. Ruchika, it looks like, for the 8 patients with DH with avacopan was given, and it looked like, the survival was too good with avacopan.
Yes.
So would it mean like, then it should be like a standard of care. So it's like a question of survival benefit rather than giving rituximab or pulsing or cyclophosphamide.
Yeah, it looks like it is going to be a molecule like tofacitinib. The moment it comes out of patent period, I have a feeling it's definitely going to find its place as probably it is going to give rituximab.
Another question is like even in maintenance, probably instead of low dose steroids, it would be better than, can we continue it as for a maintenance therapy?
We don't know, sir.
Barring the cost.
There is absolutely no data on maintenance therapy as yet. The data is only in the induction. There is no data as far as maintenance is concerned. As far as I remember, even in the recent ANCA vasculitis workshop, they have not talked of it as a maintenance therapy as of now. But yes, why not?
That was an excellent talk. Apart from the hepatotoxicity, what about herpes zoster? Is it common with this molecule?
No, sir. No. It has not been, as of now, whatever data is available, it doesn't look like that is a major concern. There are some serious infections, but that is, in fact, lesser than the prednisolone. So when you look at in comparison with steroids, definitely it doesn't have that much of a risk.
Okay, because in one of the NEJM journal, particularly with infections, it was mentioned. That's what I just wanted to check with you, whether any recent reports, just like JAK inhibitors, whether this molecule also will have similar side effects in terms of infection.
I'm not aware of, sir. It may be one or two, but it's not a major concern as far as I could understand.
The 2021 paper didn't show that. But hepatotoxicity is well documented. Thank you.
You were comparing avacopan and rituximab, but avacopan, it was used as a steroid-sparing agent only. In the trial, only steroids and avacopan were compared, not because in both the arms people received rituximab, right? So is it appropriate to?
No, I am this is not, I'm comparing rituximab and avacopan. I am just telling about, if you look at the cost efficacy analysis, the survival, the relapse-free survival in patients who have received rituximab and steroids in all the main RITSAN studies was actually pretty, it was equal to the avacopan group. So what I meant to say is that the standard of care there had more of relapses, not because that the rituximab-based regime or the current regimes are not effective. It is just because they didn't get any maintenance. You expect a patient who has received induction with rituximab to relapse after 6 months anytime if you don't give them anything. So that's what I meant to say, that as of now, rituximab is a drug which is widely available. It is pretty cheap in India. So whether if you want to give avacopan, what is its place as compared to whatever we are giving at present? So the relapse rates were same, and the side effects also looks like to be the same.
Yeah. Anyway,
Thanks.
it's not going to replace,
because I think we may be running short of time. Maybe we can continue the discussion. I think it's very good discussion, but unfortunately, we'll continue it off stage.
Thank you.
Thanks so much. Next, I would like to invite Dr. Shanmuga Sundaram. He is somebody who has taken all the awards from the best of brains in US and started the nuclear medicine department in Amrita, and he's started the first training program in Amrita. And Thanks, Dr. Shanmugasundaram, for coming to our association for our meeting. Over to you, Dr. Shanmugasundaram.
Thank you, chairpersons. Good afternoon, everyone. At the outset, I like to thank the organizers, the scientific program chairman, Dr. Arul Raja Murugan, for giving me an opportunity to be part of this program. It's indeed my pleasure and honor to be part of this program and to discuss this interesting topic, positron emission tomography in rheumatology. Is it to be trusted or not? So in the next 15 minutes or so, we shall be discussing what exactly is the principle of positron emission tomography, how the images are acquired, how these images are to be interpreted with clinical sense, what are the common rheumatological conditions where in day-to-day practice it can be used, and I will try to illustrate those points with some clinical case examples. So positron emission tomography, otherwise called as positron emission tomography with a multi-slice CT, is a classical example of hybrid imaging. So this is a real hardware integration of positron emission tomography scanner with a CT, and the principle behind the positron emission tomography is use of positron emitting radioisotopes. These radioisotopes are unstable elements which have extra energy, and they release this energy in the form of a positron or positively charged electron. So these positively charged electrons, when they come into contact with the surrounding electron, it kills itself, and that is classically called as annihilation reaction. And when this annihilation reaction happens, there is release of two identical energy gamma rays which go against each other by 180 degree apart. So if you have a crystal which can be detecting this energy, gamma energy photons, you can create an image, and that is the principle of positron emission tomography. The commonest radiopharmaceutical that is used in day-to-day practice is fluorodeoxyglucose. As the name implies, it is a glucose molecule labeled with a positron emitter called 18-fluorine. This fluorine uptake is, or fluorodeoxyglucose uptake, is mediated by glucose uptake and transport receptors and proteins that are present excessively in malignant and inflammatory cells, and this is facilitated by the enhanced glycolytic rate in inflammatory cells. So what do you get out of a PET scan is a diagnostic quality contrast enhanced CT along with the information regarding the distribution of increased FDG uptake in the inflammatory cells. So this is easy to understand. There is a positron emitting radioisotope. It has excess energy. The excess energy is released in the form of a positron. It interacts with the electron. It produces two gamma rays which are going opposite to each other, which is going to be detected by the equipment that is positron emission tomography. So in the glycolytic pathway, the glucose is further modified to carbon and oxygen, but the fluorodeoxyglucose gets trapped as a fluorodeoxyglucose phosphate, and this hexokinase pathway helps us to retain the FDG in the inflammatory cells. And these glucose uptake receptors are 1 to 5, 1 and 3 are more specifically suited for the increased uptake of FDG in the inflammatory cells. So I'm lucky to work in two different equipments. One is a positron emission tomography attached to a CT, and also I have the lucky equipment that is the PET MR. So these two are relatively specifically used in rheumatological conditions, and PET MR is relatively preferred for adolescents and young people to avoid unnecessary radiation from the CT component. So purely from a clinical point of view, for the clinician, this is most important. You need a good glycemic control in these patients because what we inject is a glucose molecule, and patients are overnight fasting, and their fasting blood glucose level will be somewhere less than around 150 milligram. and the scan is performed after the injection of the fluorodeoxyglucose 1 hour later, and what you get is, as I told, a diagnostic quality CT along with the positron emission tomographic scans. So you always hear this word SUV, standard uptake value. It is basically a semi-quantitative measure of the glucose uptake in the inflammatory or malignant cells, and it is expressed as gram per ml. And it is really relevant in therapy response evaluation. The uptake, the SUV values come down when you treat the patients with specific drugs, and you can say patient is responding better. To a certain extent, in non-malignant conditions, it still can be used for prognosis. The higher the FDG uptake, higher the SUV, and that shows that there is active inflammatory process going on there. So specifically coming to the rheumatic conditions, the rheumatoid arthritis, polymyalgia rheumatica, the adult onset Still's disease, spondyloarthritis, the large vessel vasculitis, and sarcoidosis. Probably these are the commonest indications where the positron emission tomography with fluorodeoxyglucose is really relevant, and you can use it for the diagnosis, more importantly to the assessment of response to therapy, the detection of recurrence, and to a certain extent in prognosis also. So as a rheumatologist, you are also interested in the evaluation of pyrexia of unknown origin. So apart from the rheumatological conditions, the occult malignancies, lymphomas, the multisystem sarcoidosis, and infective endocarditis, these are again some of the real relevant indications where positron emission tomography can be used. So I like to show some specific patterns which can be relevant in the clinician's point of view to see what is the relevance of a PET CT. So in rheumatoid arthritis, what we image is the active synovitis. So the active synovitis is the increased site of the active FDG uptake, and the biggest advantage of whole body PET CT is its ability to image both small, medium, and large joints because it is a whole body image. And also you don't need any specific imaging features for the atlantoaxial and TM joints, which are more commonly involved. And the most relevant point is whether the disease is active or inactive, and also to assess the therapy response in specific disease modifying drugs and also anti-TNF therapies. And another relevant point from whole body PET CT is the extra-articular rheumatoid arthritis manifestations in skin, nodal, and vascular components can also be evaluated in one go. So here is a patient with active rheumatoid arthritis. The most important point is the increased uptake, significantly increased uptake in small, the large, and medium joints, and excluding the PIP joints, number one. Number two is the transaxial and sagittal images showing uptake only in the active pannus or the active synovitis, and extranodal sites also can be evaluated. And difficult sites like atlantoaxial joints or temporomandibular joints also can be easily evaluated. Here you can see that there is focal increased uptake of FDG. Coming to polymyalgia rheumatica, the most important point is the identification of the bursitis, and this bursitis in specific sites like ischial tuberosity, greater trochanter, iliopectineal bursa, and also the involvement of the spinous process. So all these things in one go can be done. You can see in this patient that apart from the large joints, especially the glenohumeral joint, and also the bursitis can easily be evaluated. You can see increased uptake in the spinous process of the lumbar vertebrae. And the other component of polymyalgia rheumatica, the large vessel vasculitis, also can be effectively evaluated. So the exact symptom site and the active disease site can be easily correlated. So you can evaluate these patients very easily. And also the main modality of therapy with steroid can also be evaluated whether patient is responding or not. So coming to the specific triad of findings in adult onset Still's disease, that is the hepatosplenomegaly, the lymphadenopathy, and arthritis. Involvement of the reticuloendothelial system, you can see nicely shown here the bone marrow is stimulated here, increased FDG uptake, the hepatosplenomegaly, increased uptake in the spleen, and apart from that, the lymphadenopathy, if any, here you can see the bilateral axillary lymphadenopathy, and also the involvement of the other joints. So all can be evaluated in one go with a simple FDG PET CT. Specifically, coming again to the spondyloarthritis, what we are looking is the peripheral and axial arthritis with enthesitis. Again, enthesitis can be easily evaluated because you are able to study the axial and also the appendicular skeleton. You can see in this particular patient the ankylosing spondylitis, the involvement of both the SI joints and also the spondyloarthritis in the lumbar spine. So this is what is the advantage of FDG PET apart from the therapy response and also for the recurrent evaluation or recurrent detection. So here is a patient with ankylosing spondylitis, and here is another patient with psoriatic arthritis. So the involvement can be seen as mainly dactylitis and also the PIP joints involvement. It can be a ray pattern or a row pattern. So it is easy to evaluate all the small joints in one go. You can see increased uptake in the toes, the PIP and also the metatarsophalangeal joints are easily involved, can be seen, and also the associated arthritis in IBD. You can see the involvement of IBD in the intestinal loops along with the plantar fasciitis and the distal PIP joints. So in one go you are able to evaluate both the arthritic component and also the systemic component of the disease of spondyloarthritis. So this is also another common clinical conditions, myositis. So this is a 19-year-old girl presenting with autoimmune encephalitis and myositis. So you can see significantly increased FDG uptake in the muscles, and the advantage is head to toe imaging also can be done in one go. So the evaluation of unsuspected clinical situations and clinical conditions can be easily done with this. Another common problem which we come across in our day-to-day practice is the sarcoidosis. So in sarcoidosis, what I like to highlight is the involvement of cardiac sarcoidosis and also the extracardiac disease like the sites like lymph nodes, pulmonary, liver, spleen, bone and skin. In one go, again, easy evaluation of the systemic sarcoidosis, and the sensitivity is too high, more than 90% in unsuspected active sarcoid sites. And it is important, I like to draw your attention this statement, as high as 35 to 50% of the time you have discordant findings when compared with anatomical conventional imaging. So the FDG PET CT should be the initial imaging of choice in the suspected sarcoidosis. So whenever we come across or whenever the clinical suspicion of sarcoidosis is there, these patients are specially prepared because we need to ensure that there is no physiological FDG uptake in the myocardium. So any myocardial uptake is going to be considered as abnormal. So we need to make the patient to fast from the no carbohydrate and only fat and protein diet for a minimum of 3 to 4 days. So it's the preparation is important, although it is a bit difficult, and prolonged overnight fasting that increases the availability of free fatty acid in the blood circulation. Again, using free fatty acid mobilization by unfractionated heparin, we inject the 50 international units per kilogram body weight 15 to 30 minutes before the FDG injection. So by following all these 3 instructions, it is possible to have a clean background in the myocardium, and any abnormal uptake in the myocardium is to be considered as an inflammatory myocarditis, and with the clinical background of sarcoidosis, we can brand that as sarcoidosis. So we have some specific patterns when you do a perfusion study with myocardial perfusion agents. When there is normal perfusion and increased FDG uptake, they are early cases and they respond excellently with the steroids. And even though there is a reduced perfusion, but there is still high FDG uptake, that is abnormal increased uptake pointing towards inflammation, still they will be benefited by steroid therapy. But these are the patients where there is scar formation with increased or no FDG uptake. Those are the patients who will have significant morbidity due to cardiac sarcoidosis. Some of the impressive images you can see, here is an abnormal uptake where you can see focal increased uptake in the myocardium and also diffuse abnormal uptake both in the apex and the interventricular septum. This particular patient treated with steroid showing reduced uptake in subsequent images, but before that there are other indications or other pointers towards the systemic sarcoidosis. Here the mediastinal nodes involvement and also the multi-system disease. You can see here almost all the systems including the skeletal system is involved. So this is one of the biggest advantage, that is identification of the disease burden in suspected cases of sarcoidosis. So this is the patient who responded very well, excellently with the normal perfusion with abnormal FDG increased uptake, and the post-steroid there is a significant reduction. So coming to the role of PET in large vessel vasculitis, here it is mainly the Takayama's arthritis and giant cell arthritis, and the aorta, its large and medium branches, all can be evaluated in one go, and possibly in my day-to-day practice I have seen its real use is in the management of these patients with drugs, and after that the therapy response. I will just take 3 more minutes, and the visual grading is relevant. What do I mean by visual grading? This is a normal image. You can see the normal distribution of FDG in the brain. There is distribution of the FDG in the urinary system, kidneys and urinary bladder, and this is the normal uptake in the blood pool, mediastinum and the liver. So when the uptake is lesser than the blood pool, it is a negative scan. If it is equal, it is grade 1. If it is equal to liver, it is grade 2. If it is more than liver, it is grade 3. So in this particular patient, it is a grade 2 aortic arthritis active inflammatory process. You can see there is increased uptake. And this particular patient, you can see significantly increased uptake, both the medium and large vessel. This is a grade 3 active inflammatory process. So this is a study to show that the intense uptake has significantly decreased after your therapy. So this is where we like to say the FDG PET is a relevant investigation to decide on when to stop the steroid or when to go for a maintenance therapy. So does it mean that the FDG PET is the ultimate in all these rheumatological conditions, and is it that every patient ought to be sent? There are difficult situations also. The first one is the glycemic control. In patients with uncontrolled diabetes, we have problems, but what we do is the patients will be injected with plain insulin on the time of our FDG injection. So this glycemic control, we need a lot of clinical interaction with you, number 1. Number 2, when to do this imaging. It is ideal to have drug-naive patients, but in day-to-day practice it doesn't happen. So why we specifically say we need drug-naive patients, that is because there is a significant negative impact of FDG uptake even with 24 hours to 48 hours of oral or intravenous steroids. So both the disease modifiers and steroid drugs have a significant negative impact on the sensitivity of FDG PET studies. So ideally, whenever you have drug-naive patients, it will be ideal, but even if patient is on steroids, when the patient is not taking steroids, or at least when we can withhold the steroid as much as possible, that's where the sensitivity can be improved. And we have seen multiple patterns in multiple studies or as of now, so multiple clinical situations. So is it a diagnostic study? Yes, it is a diagnostic study to show there is active inflammation, but are we going to arrive at a diagnosis? Possibly only with a clinical correlation. So the clinical correlation is a must for the right diagnosis. Obviously, we need to work together. Just I like to show this image. This is considered to be a carcinoma lung patient, and the imaging features point towards carcinoma lung, but it turns out to be tuberculosis. So FDG uptake is there in inflammatory, infective and malignant conditions, so it needs to be clinically correlated. So can FDG PET-CT be trusted? I feel emphatically I can say that it can be trusted in day-to-day practice of rheumatological conditions, but it needs to be used in the right situations. And possibly I feel it is a great tool to assess the therapy response, number one. And number two, as a clinician, you should be aware of the FDG uptake pattern, and that can happen with a consistent and continuous interaction of nuclear medicine physicians with the rheumatologist. I think I have tried my level best to show multiple patterns in the last 15 minutes with this talk. I hope we have had some discussion positively on that aspect. Thank you very much for your patient hearing.
Thank you, Dr. Shanmusundaram. Is there a compelling question from the audience? Yes, Dr. Murthy. Dr. Murthy.
Yes, sir.
Thank you. It's a very good presentation and very comprehensive. I just wanted to ask about how do you differentiate a bony metastatic disease in the axial spine with sarcoidosis? Because you can get sarcoidosis going into the spine.
So first of all, right now we are not depending on the three-phase bone scans or skeletal scintigraphy for the differentiation. Specifically with reference to the positron emission tomography with FDG, the uptake patterns. So here most of the time it is the articular and periarticular uptake, and spondyloarthritis means we know specifically the specific joints are involved. But in metastatic disease it is the axial skeleton, and also for example in vertebra means it is the posterior element, the pedicule and the body involvement. So there are specific patterns of FDG uptake in the metastatic sites, and it can easily be diagnosed and easily can be differentiated from a rheumatological condition.
Thank you. Dr. Murthy, shall we, in the interest of time, we are running about half an hour late. Thank you so much. There are so many questions. I hope you would be in
I am here, sir.
Yeah, here. So maybe we can you make use of his knowledge in the next half an hour's time. Thank you very much.
Thank you so much, chairpersons and the speakers. And now we are going to move forward for the session 4. And for the 4th session, it's very pleasure to invite and welcome our chairperson, Dr. Brigadier K. Narayanan sir. And he had his graduation and post-graduation from AFMC, Pune, Rheumatology training from Madras Medical College. And he is a former professor and consultant in medicine and rheumatology, armed forces, medical services. And currently he is senior consultant rheumatologist at Dr. Shenoy's Care, Kochi. So we welcome you, sir. We request you to take over the session, sir, please.
We have 3 topics for the next session. The first speaker is Dr. Ramesh Bassi. He'll be speaking something about artificial intelligence in immunology. That is modeling treatment sequences in immunology, a guide for better outcome. Dr. Ramesh Bassi is, I think, quite familiar with all of us. He's practicing in Calicut, so I won't waste much time reading this CV. So over to Dr. Bassi.
Good afternoon. It's an absolute privilege to be here addressing you. Thank you for giving me this opportunity. Right. I will start with some declaration. Conflicts of interest, none. But the mental conflicts were plenty. I was wondering why Dr. Arul gave me this topic. And then I would have been happy with the cost-effective treatment of RI. This is a cutting-edge, innovative method in medical research. I was wondering, am I the right person to discuss this topic? I'm not an authority on statistics, and I don't have any previous experience in modeling studies. But the only consolation was that nobody have any experience in modeling studies. So I thought I could survive. Right. I would like to introduce a clinical scenario. Mrs. MJ, 40-year-old lady with seropositive RA since 35 years of age. She is the wife of a CEO of a multinational company. That means that the cost is not an issue, treatment of RA. She can afford any treatment. However, she was treated with methotrexate and hydroxychloroquine. A few months, she was all right. But her DAS28 remained high. She was started on injection adalimumab. She was all right for a few months again. And then she continued to be symptomatic with high DAS score. So what to do next? The CEO is very demanding. I would like to have an answer. And he is ready to go anywhere. So what he did was, he went and met a rheumatologist at Delhi who advised him to add tafasitamab. Another rheumatologist at Mumbai said, no, add rituximab. Another one at Bangalore said, golimumab or tocilizumab would be better. He is so demanding, oh, come on, doc, give me an answer. What is this? You still can't make a decision on this? What is the next choice, the best choice? So, can we give an answer to the CEO? It's very difficult. To give an efficient answer, you need to have a double-blind controlled trial comparing the sequences of these drugs, which is practically impossible. So, what can we do about this? You know, there are about 1,500 volcanoes in the world, and some of them have not erupted for last 500 years. But still, the geologists predict correctly that this volcano is going to erupt. How is it possible? Because they make a model of the volcano, and you can do simulation. Look at the power of the wind. If it is 4 kilometer per hour, what is the damage by the volcano eruption? Everything can be predicted. So once you make a model and apply simulation, you can derive very strong, efficient data from these studies. So can this be extrapolated to medical research? That is what we are doing. Modeling involves creating a simplified representation of a system using mathematical, statistical, or computational tools to analyze complex relationships to predict outcomes. And simulation is the process of running a model over and over again to observe its behavior under different conditions. This is the key word, different conditions, allowing for dynamic testing and generating insights into the system behavior. And there are, just like statistical, TQ, students, t-test, chi-square, there are different modeling techniques. These are called decision trees, Markov models, individual sampling models, and discrete event simulation study. Now, this was actually one of the early models in rheumatoid arthritis. This was published in 2014. And in fact, all of these modeling studies were initially done to assess cost effectiveness in treatment. And this modeling, in this study actually, assessed the various efficacy of various modeling methods. And the various modeling methods were analyzed, and the cost effectiveness of various treatment modalities were assessed, and the decision was the discrete event simulation is considered as the best option, especially in rheumatoid arthritis, if you are doing a cost-effective study. This is highlighted for its ability to cover patient heterogeneity comprehensively, model complex treatment sequences, and account for competing risk in RA patients. However, it is crucial to have transparent data input to avoid biased results. One of the most important things in modeling studies, you need a crucial and you need reliable data so as to have a robust model. So at the moment, it's believed that DE is favored over other modeling techniques like Markov models when there is enough data available. Now let us see, how is a model prepared? You need a lot of data to make a model. So if you have more data, then the robustness of the model will be high. So conduct a literature review to identify relevant studies and modeling techniques. And then you have to choose an appropriate modeling techniques. It could be a decision tree, it could be a Markov model, or it could be an ISM or a DES. And then you need to gather data on treatment options, patient population, disease progression, cost and outcome. Believe me, this is all done by the software. You don't have to do anything. This is basically an armchair research. You do just give it to the computer and that will do the rest of the work. But you have to give guidance, the guidance to the computer, defining the input parameters, validating the model by comparing outputs with the real world data. This is again another important point. Your decision, the output should be compared with the real world data. And then, of course, you have to conduct the sensitivity analysis to test the model's robustness. And look at this, another study, a model-based study and analyzing sequence treatment of rheumatoid arthritis. And I will give you a summary of this study. Basically, this study evaluated the cost-effective sequential biologic disease-modifying anti-rheumatic drugs for patients with RA who have inadequate response to conventional DMARDs. It uses an individual patient simulation model to estimate outcomes and cost, considering factors like mortality, health assessment, and model input parameters. So it depends on what all inputs are you going to put in the model. Right. And various scenarios were explored, and let us see the result. Look at the wonderful sort of sequences you can do with the model. Can you think of doing a double-blind controlled trial with these sort of sequences? You can see that 7 series and in sequences were studied with this model. I'm not going into the details of, there's a busy slide, but look at that, the various models were used, and the final outcome, the model structure simulated individual patient outcomes based on a 6-month cycle length. For a modeling study, the cycle length is important, and that incorporate the HAC disability index scores and disease progression over time. Most cost-effective sequence was starting with abatacept, followed by tocilizumab, and then rituximab. You must remember that this modeling was done by the data from US studies. And there, the cost of treatment, the original innovator molecules were used, unlike in this scenario where we use more of biosimilars. But this cost effectiveness, the point at what are you trying to look out with a modeling study? Here the cost effectiveness was looked at, and they found that this sort of combination was cost effective. Now, this paper was published in March. I think Dr. Arul chose this topic based on this paper, Modeling Treatment Sequences in Immunology, Optimizing Patient Outcomes. Now, the study actually focuses on optimizing treatment sequences to improve the patient outcomes within fixed healthcare budget. Here, the modeling study is basically done to more of cost-effective treatment. For example, if the insurance company is paying or the government is paying for the healthcare, they need to make sure that healthcare is limited in the budget. At the same time, patients should get the best treatment. So this model used a state transition treatment sequence model, which means that just like a true patient, they go on to several phases of the disease. And this is our 3-year time zone starting in 2023. And the most important thing is they assessed treatment sequences for psoriasis, psoriatic arthritis, rheumatoid arthritis, ankylosing spondylitis, non-radiological angstmont, Crohn's, and ulcerative colitis in Italy. Okay. By analyzing treatment failure, cost, and biosimilar impacts, the study highlights the potential for significant patient improvements in patient outcomes by prioritizing more efficacious treatment early in therapy. This is why the Italy government wanted the most cost-effective treatment. They found that if you use the most efficient combination early in the therapy, it can be cost-effective. Again, the research emphasized the importance of evidence-based treatment sequencing to enhance patient health outcomes and support sustainable healthcare system. This is actually what is meant in that study. But look at that, how it was done. The model software is the most important thing here. The model was developed using the R programming. It's an important R programming is a very useful language in this, with an interactive user interface using the Shiny package. The R program incorporates direct statistical analysis of data, is less prone to functional error. And the Shiny provides a clear and interactive user interface that can be deployed online. So the meta-analysis and those sort of things are very easy with this program. This is the model type. It's a straight transition model. I told you the cycle length is, this is 2 weeks, which means that it's a very good study because all the transition within the 2 weeks were analyzed. Time horizon was over 3 years, and these are the characteristics of this model. And look at that, the treatment phase, how the model actually worked. There were 2 phases, an induction phase at the start of treatment and a maintenance regime until the treatment failure. You actually just put in the data into the computer model, and that decides how the outcome is. Right, this is a graphical representation of what I just said. This is how the method is done, 2 phases, and that is how it was conducted. And the next slide, this figure illustrates the average number of treatment failures per patient for various immune-mediated disorders, highlighting the potential for enhancing patient outcomes by selecting treatment sequences with higher efficacy. Now, I would like to look at that second part. In a rheumatoid arthritis, rheumatological condition, look at that combination, TNF, JAK, IL-6. Because they analyzed not the drugs, they looked at the mechanism of action. So, if you do a methotrexate, adalimumab, followed by TNF, JAK, IL-6, that would be the most cost-effective combination. So, the key takeaway from the study is the critical importance of optimizing treatment sequencing in immune-mediated disease to enhance patient outcomes with a constrained budget. So, basically, this is the point I have already discussed. Now, let us come back to Mrs. MJ. The CEO is pestering, come on, give me an answer. So, what you can give is still, now to my knowledge, the present treatment guideline does not address this issue. Because it is said that you can use another drug with a probably different mechanism of action. So if the patient had already had methotrexate and adalimumab, okay, you can try JAK inhibition, or you can try IL-6 inhibition, or B-cell depletion, that's all right. That is the present guideline. So with this information, I may be able to tell the CEO that, okay, what we will do is we will add JAK followed by an IL-6 inhibitor based on the present evidence. Now, just last week, another data was published, data-driven subclassification of ANCA-associated vasculitis. I'm sure some of you might have noticed, identifying 6 clusters of ANCA vasculitis, which has definite clinical importance. The document discusses study on subclassifying ANCA-associated vasculitis into distinct subgroups using a data-driven approach. Nearly 4,000 patients with ANCA-associated vasculitis from 6 European vasculitis registries. Clusters were identified, and I'm not going into the details due to the lack of time, but look at that, the 5 clusters have been identified. Right. Now, coming to the Indian scenario. So, is it possible for us to extrapolate this here as well? When you base your model based on a Western data, the socio-economic cultural diversity in our country, that is not reflected in the model. So there may be, I'm not sure whether that will give you a robust model for Indian studies. So what you need strong Indian data to make a model for our own rheumatological issues. And again, we don't have, most of our patients pay from their pocket. Some of them may have insurance, and the government-funded treatment is very, very low. So again, the Western scenario may not be applicable here. So you cannot base that data as well. and lack of original data. That is our problem. But we have excellent infrastructure. The artificial intelligence, computation and statistical skills are outstanding. So if we have a solid real data, we can make very good models. So that will be the future. I think now I'm going to end up with a take-home message. The modeling studies may be a game changer in medical research. I'm sure that is going to be the way forward. And the best option to study treatment sequence in oncology and immunology. This is the future. And what the message from the sequencing study tells us that early use of most efficient therapy provides the best outcome. Thank you. I hope I did justice to the topic.
Thank you, Dr. Bassi. Any questions? Just one comment. Immediate in our clinical practice, how this will help, especially like personalized medicine. More use, better feel. I feel the understanding the immune responses.
Yeah, this is more of a cost-effective study. So when you want to have a very cost-effective treatment, when the budget is limited, you can assess this modeling study and you can definitely give good advice. But whether you can replace that data along without any double-blind controlled trial, I am not sure at this point.
Actually, thank you, sir. Thanks for accepting and giving us a lot of information. So we have understood now what is modeling sequences, but practically we have problems in getting the drugs in the government hospitals. Sometimes some drugs are available, sometimes it may not be available. Some drugs are expensive. We cannot continue for a long time. So we have started studying AS patients who are on biologics. So etanercept to TOFA and TOFA to sulfasalazine or methotrexate. Like this, we have tried looking at these patients. Some of them, they maintained remission, even if we convert them from biologics to other drugs. So now we are doing that study, so comparing one sequence from other sequence. So if we develop a model, cost-effective model for our country, I think that will be a good one. For most of us, that will be an evidence. So especially for countries like us.
Right.
Thank you.
Okay, thank you.
Okay, thank you, Dr. Bassi. Now we will move on to the next topic. Next is the mRNA vaccines in rheumatology, current status. For this talk, I invite Dr. Nagaraj. Dr. Nagaraj is a rheumatologist working in Bangalore in Sagara Hospital, Jayanagar. Over to Dr. Nagaraj.
Yeah, thank you. Thank you, Dr. Nagaprabhu sir and Dr. Arul sir for this opportunity in South Zone, Kovai. So another difficult topic, mRNA vaccines, which have not much exposure as such and use in our scenario in India. Before we go into this complex topic, I just wanted to have an overview of RNA and the concept of the RNA therapeutics in general and the mRNA therapeutics in vaccines and the legal position of these vaccines and the pricing strategies which has been adopted in the markets of late. RNA was discovered in 1956 and over the evolution of times by 1978 we had a vaccine of use of antisense oligonucleotide in 1978 for RSV virus, and 1998 and 1990 onwards its use in RNA therapeutics has gained more usage as a therapeutic molecule. Why we should have mRNA therapeutics? One of the reasons before we go to this is that the protein molecules what we have right now are having, the small molecules what we have right now target only about 15% of the proteins. 85% are not targeted, just about 700 molecules we have. And there are the proteins have few selective clefts in them where these small molecules can go and bind. In such scenarios, these RNAs come in very handy because they actually are involved in the protein synthesis and translation process, and they can even modify the production and alteration or even block the synthesis of a particular protein. The mRNA therapeutics is much more important because this was a breakthrough in 1990 by Wolf's groups, wherein they said in vitro transcribed RNA mRNA can actually induce production of a skeletal muscle without actually entering into the nucleus. Therefore, it cannot modify the genome. There will be no chance of a insertional mutagenesis whatsoever as compared to the DNA DNA treatment, gene therapy. So RNAs are, we know, are the polymers of the purine and pyrimidine nucleotides, and these are the very basics of purines, that is the adenine, guanine, and the modified ones in the brown in the lower panel are important for us to understand that, these are the ones which can be used to stabilize a particular mRNA given their undue instability and difficulty in transfer to the cells. So this is a very brief introduction of the central dogma, wherein DNA leads to messenger RNA production, that's called transcription, and subsequently this mRNA inside the nucleus as a primary transcript is produced with a molecular weight approximately of 10 to the power of 7 Daltons, that's around 1 crore. As you can see, it gets sliced to, by the removal of introns, it becomes a mature RNA with a molecular weight of just about 10 lakhs. That means 90% of it is cut out by this RNases. So the differences between the RNA and DNA are, we know largely. The RNA is mainly in the cytoplasm, DNA is mostly in the nucleus. RNA is only 100 to 5,000 bases, whereas DNA has millions of such base pairs. RNA is single-stranded and DNA is usually double-stranded. So the mRNA is a type of single-stranded ribonucleic acid which is transcribed from the DNA and carries the coding information from the proteins. And it is important for us to understand this because it has potential to produce innumerable proteins, especially in conditions concerning neurology, cancer, and other degenerative conditions, wherein a particular identified target can actually be replaced or make it be made functional. These are the various types of the RNA therapeutics: the antisense oligonucleotide-based mediated gene regulation, RNA-mediated gene regulation, RNA interference, the second panel on the right side. The third one is the CRISPR-Cas-based genome editing. The fourth one is the aptamer production, and the final one is the mRNA vaccine, which is we are going to deal shortly. So the RNA interference is a process which targets the complementary mRNAs for destruction by leading to a blocked production of a particular concerned protein. It can be done by two methods. One is by introducing what are called as siRNAs, called short interfering RNAs, which are double-stranded and which cause a particular splicing of a specific mRNAs and lead to a double strand, and which will get destroyed automatically by the internal processes. The microRNAs are part of the natural occurring proteins, and they also cause the short double-strand RNAs, and they can lead to self-destruction of these RNAs and lead to RNA interference. The antisense therapy is it stops a particular gene from producing a specific protein by attaching to the particular mRNA consent. So here, one point highlighted in the blue lines over there are some confusions so far as the legal portion is concerned. This RNA therapy is considered as the biologic therapy in FDA. So it gives longer dynamics for investments itself for the multinational companies which are showing interest in RNA research. There are several universities across the globe, especially in Europe and the US. There are at least 6 to 7 dedicated RNA institutes, and they have attached MNC companies which are having a huge transactions of so many millions and billions of dollars invested in this, with this almost a decade back, even before we had the COVID vaccine. So that application has been extensive. It is either a ex vivo or in vivo transfer in the cancer research, allergy research, infections, and neurology, and multiple other aspects. So as we can see, these are some of the FDA-approved medicines for various conditions such as the CMV retinitis, spinal muscular atrophy, Duchenne's dystrophy, and amyloidosis, porphyrias, hypercholesterolemia, and ARMD, age-related macular degeneration. The real breakthrough which came as emergency approval was for the COVID-19 vaccine, which even won the Nobel Prize in last year. So 2018 was the first time when we had this first approval, and then subsequently up to 30% of the FDA applications and research is supposed to be on this biologics right now. So the antisense oligonucleotides are short nucleotides of 12 to 24 nucleotides, which can actually bind to specific RNA through base pairing, and they cause modification in protein expression. And as you can see, there are two drugs involved here, which we mentioned there. We'll skip all this. RNA interference is an endogenous process, which, as I told you, can be through siRNAs and miRNAs. And this can be one of the medicine which is used in this is for CMV. And this is a common pathway which can lead to the transcription, interference, heterochromatin productions, translation changes, etc. This is a method that's called clustered regularly interspersed short palindromic repeat sequence, which is actually used in a prokaryotic protein called Cas systems. And they actually can insert and make a gene silent or can activate a gene is supposed to be the process in this involved. And it can be, it's actually a gene therapy which comes closer, and there is no, there's one approved molecule which is under research for CMV retinitis in this group of drugs. Aptamers are single-stranded oligonucleotides with a three-dimensional structure, and they can have either an antagonistic way of approach or a cell-specific approach. The antagonist approach is the one which is common in the clinical research right now, and we have the one molecule for the ARMD, age-related macular degeneration, which is under research for this group of drugs, which can attack the VEGF, that's called the pegatinib. Coming back to the mRNAs, mRNA is actually a negatively charged macromolecule, and which is usually, once it's inserted, there are quite a few RNases which can instantly destroy this. Therefore, that needs to be protected from getting destructed. The idea is to have a protected environment so it gets delivered to the intended particles. So one of these ways of doing it is to engulf it in lipid nanoparticle, shown in the left side of the panel. It enhances the stability of this mRNA. And it can be either injected as intravenous as for the ARMD, intramuscular as for the COVID vaccines, subcutaneous routes for various others, RNA molecules, and intravenous routes, and as well as intrathecal for spinal muscular atrophy. The vaccines actually are acting in such a way that, the particular one mRNA vaccine, once it's introduced into a cell, it uses the cell's machinery to produce the antigenic protein. Normally, the concept of vaccine is that we identify a particular portion of the virus or the bacteria concerned, we weaken that particular protein and introduce it in a weak manner inside the system. Here, we are actually sending an mRNA to produce that particular antigen inside the cell's machinery, and then that antigen is exposed to the immune cells, which starts producing the antibodies. There are a lot of variations on this, and mRNA as a property, mRNA vaccine is supposed to be more beneficial because of the simple structure and because of the rapid design. The designs can be taking place within a very short weeks of time, such as weeks to months. And they can actually have a combination vaccines. We can, their scientists have shown that they can introduce multiple mRNA sequences in a particular single delivery, and antibodies can be produced to various different pathogens. And the inbuilt adjuvant, as I mentioned, and there is no, rather than no minimal vaccine infection and rapid manufacturing process. These questions which all the rheumatologists have, what about the safety? That remains to be seen, because we have just had about 5 years since the COVID vaccines were introduced, the mRNA, and the long-term safety is still unknown, and more studies are being done. When we use in cancer, these cancers, the vaccines are more therapeutic rather than preventive, and they are supposed to activate the cytotoxic C lymphocytes, causing a reduction in the tumor burden load. There are several cancers which are being tried, such as the melanoma, breast cancer, prostate cancer, ovarian cancer, all the lymphomas, leukemias, and brain gliomas, etc. They're also being used in HIV, various infections, the rabies virus, Zika virus as well. The one important concern so far as rheumatoids have, 4 vaccines have been tried in patients with rheumatic diseases. One is the RSV vaccine, the respiratory syncytial virus vaccine, which has taken a rejuvenation. Considering there was a failure of this vaccine in 1970s and 1980s, where the subunit did not function after the introduction into the system. Then it comes the herpes zoster. Right now we have Shingrix vaccine, which is subunit-based vaccine. But there are some controversy about this vaccine for mRNA because varicella is a stable virus, and there is no change in the conformation of this virus as compared to influenza, which changes annually due to the hemagglutination mutagenesis. So the RSV and combination influenza, so many trials are going on. This is hopefully being one of the real breakthrough if it happens, because right now we have a situation wherein we have to use annual vaccines, annual weightage, and this has to be grown on the avian cell cultures, which takes about 6 months to identify the particular strain for that particular year, and then it takes its own production time, etc. So considering the mRNA's fast production and fast design, this is one area where it is really going to possibly have a breakthrough. Then there are challenges. What are the challenges so far as mRNA engineering is concerned, RNA screening as such? There are the challenges in the precision RNA screening, the RNA being a huge molecule, only 20% of it is in the coding sequence, 80% of it is not in the coding sequence, and that remains an enigma to the scientists. So the integration of the RNA sequence into clinical laboratories and into particularly the cell samples is always a non-uniform process, which so many laboratories operating their own method. There is no consensus, and there is no there are no definite guidelines from any governing bodies such as FDA or European Medicine European Agency. And a plethora of available software options to interpret them, that becomes the data comparison quite difficult. And also the delivery is also a major problem. Different drug delivery methods are used, and therefore the different outcomes happen. Formulation changes, chemical modifications. Though these changes is intended to have a less barrier and intended uptake, but the uniformity, lack of uniformity makes them non-comparable. So RNA molecules do exhibit a remarkable versatility, holding immense, largely unexplored potential for clinical applications, and the lower production cost is supposed to be quite hyped. But as you can see, the dark green bar in this diagram is actually showing the applications for the new drug replication as a small molecule, whereas the lighter shade actually shows biological applications. As you can see, there is increased number of trials, studies in various phases of studies. And this kind of a differentiation and lack of uniformity for the application of a particular drug has left a lot of room for confusion in play here. As we all saw during the COVID time, Pfizer vaccine, even during the COVID time, a country like developing countries like India couldn't afford a vaccine from Pfizer, and we had to go for alternative vaccines. So post-COVID first or second wave, as you can see in the Reuters report here, there was a very intense hike in the price, which also was adopted by other rivals such as the Moderna and BioNTech. Therefore, when we speak about the cost cutting, how much it actually translates into reality is something which needs to be seen in due course of time. So this 2020 marked a kind of watershed year for the mRNA vaccines by the introduction of COVID vaccines. And these two people were even awarded the last year's Nobel Prize for their discovery in mRNA vaccines, Katalin Kariko and Drew Weissman from University of Pennsylvania in USA. So this is, I'll end my presentation with the statement of Kariko. She says, under the shadow of disappointments and failures in the neighboring fields of gene therapy and short interfering RNA and the mRNA, etc., the mRNA field has really been advanced, and we have to exercise due caution. And cardinal faults such as the premature adoption of the new technology and right usage of the clinical trials and adopting appropriate safety measures, etc., should be there. Ongoing clinical testing programs have to be initiated based on the thorough preclinical exploration of the targets, etc. So it is important for us to apply prudence and use this technology. It's really a breakthrough, but we should use it in the right sense for us to get the maximum benefit. And rheumatological disorders do await these kind of breakthroughs. Right now, we don't have a particular disorder wherein we can have a specific target, which there is mRNA. Right now, we are only looking at vaccines, which can interfere with the disorders, which can actually trigger or alter a disease course in a rheumatological scenario. Thank you. Thank you for the kind attention.
Thank you, Dr. Nagraj. Is there any trials going in rheumatology conditions? Like,
no, sir.
Against IL-12, 23, TNF?
No, sir. No, sir. No, not on mRNA scene. Only on the vaccines is right now.
There are some phase 1 animal experiments.
Yes, sir. Not in the clinical center.
Yeah, not in the clinical.
Yeah.
But rheumatoid arthritis, SLE, and psoriatic arthritis, these are the ones that are trying, especially against cytokines IL-12, 23, TNF-alpha, and anti-CCB. But these are all early.
There are no targeted. There are no specific targets, and their outcomes
so
are.
There are multiple targets are possible. So that's a difficulty. But hopefully it may come through. Thank you. Any questions? Thank you, Dr. Nagraj. We'll move on to the next topic. I invite Dr. Binoy J. Paul for his talk on reframing the gout management. Dr. Binoy doesn't need any introduction in this audience. Over to Dr. Binoy.
Can I have the slides? At the outset, I thank the organizers, especially Dr. Arul, for giving me the opportunity to talk about reframing the gout management in Indian scenario. As you all know, uric acid is an end product of urine metabolism, but gout is a disease of the hominoids, the man and the apes, not lower animals. They contain the uricase enzyme, and there was inactivation of the uricase enzyme by mutation in human being. It's because in the phase of transition to upright walking, hominoids have experienced a hypertensive crisis. The human diet during that time was mainly vegetarian and extremely low in salt. Can you make it larger? Can you make it larger? Full screen, I come back to this. The elevation of the serum uric acid was a protective mechanism for restoring normal BP, primarily through urate-induced renovascular changes. Today, human diet is rich in salt and proteins, hence the homeostatic adaptation is now contributing to obesity and gout. The prevalence of gout is difficult to estimate, but the global prevalence is around 0.6% based on the meta-analysis of 71 studies from 1962 to 2002, and the data from developed nations are much higher. What about the prevalence in COPCOT nations, in Asian nations? In India, Big One trial says it's 0.12%. Our study, along with the COPCOT survey, in Kerala it was around 0.19%. There are few Indian studies on gout, very few. AIMS Delhi study in 1990. The overall profile of the disease appears similar to that seen in the West. And in the Chennai study, only 0.5% of patients attend the rheumatology OPD of the tertiary care hospital. Majority are treated outside. This is our own study where we found that the ankle joint was the commonest joint involved initially. But during the course of the disease, 90% of people in our country develop first metatarsophalangeal joint involvement. And gout in female is another problem, 3 to 5%, mainly postmenopausal. Polyarticular onset is common. What about young onset gout? This is the Vellore study of 117 patients. 18% had an age less than 30 years. And tophi is also not uncommon in our patients. I think I can skip all these things. But looking for tophi is very important to make a diagnosis. This patient had recurrent ankle arthritis, a 60-year-old male, and uric acid was always normal. So once AC level has been done, which was marginally elevated, and was treated as sarcoidosis. But when we look, what we found is this callus-like swelling. Aspiration showed uric acid crystals. As William Osler said, one swallow doesn't make a summer, but one tophus makes gout, and one crescent malaria. So making a diagnosis, it is very, very useful. And in our clinical study, the renal calculi was about 15.9%, but the renal dysfunction was only 0.12%. And there are a lot of comorbidities. I am not going to the details. So we have 3 types of people in gout in India. One is the young onset gout. Second is the garden variety, the older males and the females. And you can see that the second group is having the maximum 80%, around 18 to 20% young onset, around 3 to 5% females. And metabolic syndrome is commonly associated with the older males, but uncommon in the young onset gout. Now, diagnosis of gout, the classical teaching and gold standard is demonstration of the monosodium urate crystals. But in a busy office practice, it may not be possible. But when you see a patient with recurrent mono or oligoarthritis, especially affecting the first metatarsophalangeal joint, ankle or midfoot joint, associated with hyperuricemia and a very rapid response to colchicine, your diagnosis of gout is almost 95% correct. Nowadays, classical imaging techniques have come, ultrasound and ECT. This is the polarized microscopy, which all of you are familiar. And the double contour sign and the snowstorm appearance are well known to the rheumatologist and definitely clinches the diagnosis. Recently, dual energy CT has come in selected centers in all over the country, including Kerala. And you can see the difference, the double contour sign and the red deposits of uric crystals compared to our conventional X-ray. Now coming to the management, last 8 years around 7 or 8 guidelines have come for managing gout. The last one and the most applicable one is the APLAR guideline, came out in 2021. Around 22 doctors from 18 countries were sit together to make this guideline. I was fortunate to be part of it, and I will be discussing mainly those things in the next slides. So if you look at the optimal pharmacological gout management, which include two things, one is controlling the pain and inflammation, second is reducing the urate burden. For acute flare, we have NSAIDs, colchicine and steroids. For anti-inflammatory prophylaxis, we give either low-dose NSAIDs, colchicine or steroids. And for reducing the urate burden, we have the allopurinol, febuxostat, and the uricosurics and uricases. Is it made automatic? The slide is changing. Without my knowledge, the slide is changing. The next one is coming. So, coming to the pharmacotherapy, assess the clinical setting. If there is mild to moderate pain or a single joint involvement, you can give monotherapy with NSAIDs, systemic corticosteroids or colchicine. Any one you can use. If there is polyarticular involvement and large joint involvement with very severe pain, you can give a combination therapy, colchicine with NSAIDs, oral corticosteroids or colchicine, or intraarticular steroid with any other modalities. They also found that topical ice is a very useful adjuvant to relieve the pain. Now, abroad, anti-IL-1 agents are available. Anakinra, rilonacept, and canakinumab has been tried in refractory gout, and canakinumab has been already approved by the European Medical Agency, but we don't have it. But we have ACTH with us, which stimulate the glucocorticoid secretion by the adrenals and stimulate the melanocortin 3 receptors. So this is the non-adrenal mechanism of ACTH in gout. So it has got a rapid onset action and more effective than corticosteroid. A single injection of 60 international units per intramuscularly is often needed. You can repeat it after 48 hours if needed. So this is very useful in post-operative patients, patients with GI and renal contraindication for colchicine or NSAIDs, or patients already on steroid like a post-transplant patient. NSAIDs and colchicine are contraindicated. Patient is already on fairly high dose of steroids. In that patient, you can try ACTH. So it will be a very good alternative to the IL-1 agents which is available abroad. The prophylactic treatment, there is not much change compared to the standard of care. Urate lowering therapy, the APLAR and ACR guidelines are same. The indications of urate lowering therapy are, one is 2 or more attacks per day, per year, TOFI or TOFUS on clinical examination or imaging, or radiographic damage attributable to gout. And there are some conditional recommendations, that is infrequent flares, less than 2 flares per year. Patient with chronic kidney disease, urolithiasis, or a persistently high serum uric acid levels of more than 9 milligram in spite of non-pharmacological measures. Now the target uric acid level is below 6 milligram per deciliter for patient without TOFI and below 5 milligram in patients with TOFI, chronic arthropathy or frequent flares. The urate lowering therapy classically starts 4 to 6 weeks after the last attacks, but can we start urate lowering therapy during the attack? The SCR 2020 guideline conditionally recommends starting urate lowering therapy during the acute flare along with anti-inflammatory therapy. They found that patients are better motivated and ensures follow-up as many patients are not returning for urate lowering therapy. So that was their concern, and starting urate lowering therapy during acute flare is not significantly extending the flare duration or severity according to certain trials. But still, I wait if possible. In a very selected patient, you can start. Urate lowering drugs, we have uricostatics, uricosurics, and uricolytics. And probenecid is the classical uricosuric agent. And the secondary uricosurics are the losartan, amlodipine, and fenofibrate. The other drugs are not available in our country. The probenecid is the most commonly used uric acid agent, uricosuric agent, prevent the renal tubular absorption. The half-life is 3 to 12 hours. You can start with 500 milligram and stepped up to 2000. Adequate hydration and alkalinization are highly important. But the major problem is it has got a limited production and availability in India. Only one brand is available and it's very difficult to get it when it is required. So that is the problem with probenecid. Uricolytic agents, we have only RAS uricase, which is a recombinant uricase used for tumor lysis syndrome by our oncology colleague. It is not approved for treatment of gout because of the chance of anaphylaxis on repeated use. The dose is 0.15 to 0.2 milligram per kilogram. Abroad, pegloticase is available, which is a pegylated uricase, which is less antigenic with longer half-life and can be given as a weekly injection intravenously. So in refractory gout, there are reports that it has been tried as an off-label use, especially when the patient has got progressive of chronic kidney disease or post-renal transplant people. It is administered as an IV infusion every 2 to 4 weeks. It is contraindicated in individuals who are deficient in G6PD. Uricostatics, xanthine oxidase inhibitors are available. We have allopurinol, febuxostat, and the new addition is topiroxostat. Allopurinol, we have to start with a very minimum dose, 50 to 100 milligram per day, and gradually increase the dose. The major problem is the side effects. The skin rashes occurring about 4 to 5%. Some develop severe Stevens-Johnson syndrome or allopurinol hypersensitivity syndrome. And abnormal liver function, cytopenias are also not uncommon. The allopurinol hypersensitivity is more common in people with CKD who are positive for HLA B5801, sulfonamides, those who are having allergy to sulfonamides and Asian ancestry. And this is one of my patients who developed severe Stevens-Johnson syndrome. The global frequency of HLA B5801 has been done, including our country, and our prevalence is around 3.3%, not as high as the Koreans, Chinese, or Japanese population, but at least 3% of our people are likely to develop severe skin reaction. So in that setting, febuxostat is much more suitable in Indian context because it is structurally unrelated to allopurinol. Now coming to the newer drugs, there are many newer agents available, the uricostatics, the xanthine oxidase inhibitors are the best example. Then we have the PNB inhibitors, we have the uricolytics, and many uricosurics are available abroad. The only drug that's available in our country is topiroxostat. So if you look at the evolution of the history of gout therapy, the colchicine was introduced in 1800 and followed by the other drugs. After allopurinol, there was a long gap, and now there are newer drugs coming out. So the only new drug is topiroxostat, which is a newer non-purine selective xanthine oxidase inhibitor, which was available in Japan since 2013 became available in our place only last year, which has got a good bioavailability and a biological half-life of about 4.5 to 7.5 hours, metabolized by the liver, very safe in renal dysfunction, no cardiac side effects reported. The dose is 40 to 120 milligram per day. It decreases the albuminuria in hyperuricemic patient with CKD. The major adverse effects are gout flares, nasopharyngitis, elevated transaminase, and interaction with azathioprine. The advantage of topiroxostat is it has got a dual mechanism action. It's a hybrid inhibitor, safe in cardiac patients, good renal protection, and it has claimed to have pleomorphic actions like lipid lowering effects, reducing the brain natriuretic peptide in heart failure, anti-atherogenic effects, etc. The other group of drugs which has got uricosuric action are the SGLT2 inhibitors like anagliflozin, dapagliflozin, and others developed for treating diabetes mellitus, and it's available in our country. There has been several trials on canagliflozin, its uricosuric effect producing around a 13% reduction in the level of uric acid. Dapagliflozin has also been tried to reduce uric acid level even in patients with advanced CKD. So coming to reframing the management of gout in India, this is the standard of care, and in Western countries they have canakinumab, anakinra, and rilonacept, but we can try ACTH instead of that. Now for reducing the urate burden, they have pegloticase, tigulixostat, lesinurad, and dotinurad. Probably we will be happy with rasburicase in selected cases, topiroxostat instead of tigulixostat, and SGLT2 inhibitors instead of lesinurad or dotinurad. Thank you very much.
Thank you, Dr. Binoy. One question I want to ask. The role of colchicine, chronic gout, or management of chronic gout as such.
Pardon? Colchicine?
Management of chronic gout, like it's a chronic disorder. Now the
Yeah.
stress is on the management as a chronic disease, and the role of colchicine.
Yeah, colchicine can be used in two ways. One is for the acute pain, to relieve the pain. After that, you have to give a 0.5 milligram BD maintenance dose. If there are no side effects, you can continue for indefinite period. Many patients with tophi and all, they used to get recurrent attacks. So in that setting, colchicine 0.5 milligram BD will be useful to prevent further attacks. The other one is for the acute phase, where you are giving 2 tablets stat followed by 1 tablet, 0.5 milligram after 6 hours. And nowadays we are not giving the high dose colchicine. We are giving 1 tablet 3 times daily till the pain is over.
Should we give long term for in chronic cases? Those who keep getting recurrent gout attacks, should we give it in a long term basis, colchicine?
Yeah, for the prevention of acute flare, when you start uricosuric therapy in these patients, you have to give it for a minimum period of 3 months. But 3 to 6 months is the usual period allowed. After that, there may not be much requirement. So I used to give up to 6 months in chronic tophaceous gout.
Yes, sir. Just 2 things. So you have very long experience in managing complex gout. Have you ever come across a scenario where you chose febuxostat, but the patient was better off with allopurinol? And then second question is, what is the highest dose of allopurinol you could prescribe in your practice?
I will take
Thank
the
you, sir.
second question first. 800 to 900 milligram, that is the highest dose of allopurinol that is approved. Between US and Europe, 100 milligram difference. Coming to your first question, that is on patient with liver disease, it is better to use allopurinol rather than febuxostat, because febuxostat is mainly metabolized by the liver. So in that setting, allopurinol is useful. Many patients who are not responding to febuxostat also, we may change over to allopurinol. So allopurinol still having a role. Only problem is that in Asian population, the chance of Stevens-Johnson syndrome is relatively high compared to Caucasians. That is why we are using febuxostat more. In India, it is not very costly. So otherwise, effect is almost same.
Sir, I wanted to ask regarding the dose of colchicine in end-stage renal disease. There are some where they say that you use 0.25 milligram daily.
Yeah.
There are some places which say you use it once a week. Is there any clarity on this?
I think 0.5 milligram once in on alternate day.
Yeah, there are some papers which say that
there
you
are
use
not
it
much
once.
consensus, but most of the only thing you have to reduce the dose. There is no doubt. How much we should reduce? There should be control trials. That's not available, but many people used to give 0.5 milligram tablets are only available in our country. Half tablet once in 3 days or 2 days they used to give, depending on the serum creatinine level.
Thank you, sir.
Okay, thank you, Biro.
Due to lack of time, we'll not be having a stretch break right now. So anybody who wants to have a tea or coffee, you can bring the cup inside. And we'll start with the next session. To chair the session, we'll be having Dr. Ramakrishnan Nadu, who did his DM Rheumatology from Nizam's Institute, Hyderabad. He was former Associate Professor of Medicine and Emergency Medicine at various government medical colleges in Andhra Pradesh. He's currently working as Senior Consultant in the Department of Rheumatology and Clinical Immunology at ESIC Medical College, Hyderabad. Along with him, we'll have Dr. K.V. Kishore Babu, who is Consultant Rheumatologist at Shine Specialty Hospital, Nellore, Andhra Pradesh. We welcome you, sir. We request the chairpersons to introduce the first speaker.
Welcome to this session. This session covers very important topics in clinical practice. First session is topical infections and MSK diseases. I would like to invite Professor Vinod Ravindran sir for this talk. So Dr. Vinod Ravindran sir doesn't need any introduction. He has many accolades to his academic career. Over to you, sir. Please continue.
Thank you. Thank you, the organizers and the scientific chair for this opportunity. So I'll be discussing topical infections in the context of rheumatology. Now, this area is pretty wide. You can see that all the agents, whether it is bacteria, fungi, parasites, viruses, can cause various type of musculoskeletal manifestations and autoimmune rheumatic syndromes mimicking conditions such as vasculitis and other things. And then there are some distinct entities mainly brought on by the bacterial infections such as tropical pyomyositis. Now, because of the paucity of the time, I would be mainly restricting myself to the virus and that to alpha virus. But you can see that this topic is hugely important. So if you are happy to wait till mid of next year, this volume of best practice clinical research in rheumatology, I am guest editing, and this has all the infections I just showed in the previous slide. Now, some of these infections are they present as rarer arthropathies also, which we had to consider if we are thinking about an alternative diagnosis to our patients who have musculoskeletal problems, or we are thinking of mimicus. So for example, you can see that tropical diseases such as leprosy, chikungunya, brucella, and here tuberculosis, they do come under rarer arthropathies. And by the European Parliament, a condition is called rarer if it has a prevalence of less than 5 per 10,000 population. Okay. And if you want to know more about how to investigate infections in arthritis, then this is what I would ask you to read. And just mail me, and I'll be very happy to share that with you. So coming to the arboviral diseases, these are vector-borne diseases. Three main candidates here: chikungunya, you know very well, which I'll cover in detail, dengue, and Zika. Now, as opposed to chikungunya, dengue can be potentially fatal, okay, because you know that the dengue hemorrhagic syndrome and multi-organ failure is well recognized. Zika virus will have prominent conjunctival injection, but only mild myalgia, hard level arthritis, and both dengue and Zika will not translate into chronic inflammatory arthritis, which we see in our clinical practice in chikungunya-related infection. So, chikungunya is alpha virus, and it's an arthropod-borne virus. These are the two vectors. One is the Aedes aegypti, which is also a vector for Zika and dengue. But as it is true for both dengue and Zika, the Aedes albopicus is very common nowadays. It is much more common than Aedes aegypti across the globe. So, though predominantly chikungunya infection is a self-limiting disease, extremely painful, febrile, with all the features of any acute viral illnesses such as malaise, extreme fatigue, but most of the patients who have been infected with chikungunya may remain largely asymptomatic. So question comes, when do you want to investigate and how you are going to choose this test? Well, in the very acute phase, within first 7 to 10 days, you would be wanting to do the PCR to pick up the virus. And then in the phase from 10 days to, let's say, about 4 to 6 weeks time, you'll be mainly doing the IgM chikungunya antibodies. And in the later phase, of course, it will be IgM. Okay, so this is basically IgM and IgG. Sorry, I got it the other way around. And depending on sort of, where you see the patients, they can have a variety of manifestations. And mostly in rheumatology, we are interested either in a very acute phase where it will be difficult to differentiate it from other viral infections such as dengue, unless we are dealing with an epidemic of chikungunya arthritis happening at the same time in community. Okay. So three main questions related to chikungunya arthritis: that how to manage acute arthritis, and does it trigger rheumatoid arthritis, and if so, how best to manage chronic chikungunya arthritis. So first thing first, well, in the acute phase, the main focus is to relieve the symptoms. And these symptoms, as I said, these are fever and acute arthralgia. And then, of course, be on the lookout for any complications such as organ dysfunction, which is rare but do happen. And to start thinking about chronic complications of this disease. So supportive measures are at the very top: anti-inflammatory agents, paracetamol, weak opioids can be used, anti-inflammatory agents. If you have a particular joint which is inflamed and causing a lot of trouble, you can inject that joint as you do in your rheumatology practice otherwise. And also a short course of oral steroids, but only for a very brief period of time under careful surveillance can be given. And then, of course, for the pain and all that, tricyclic antidepressants and anticonvulsants are sometimes rarely used. Now, in a proportion of patients who have acute chikungunya arthritis, it translates into chronic chikungunya arthritis. And it's in about 10 to 15% of the patients, and even in some sort of, series, it's up to 25% of the patients. And this phase, the chronic phase, can affect almost all the joints. So you can see that the small joints and the large joints, in any combination, it might affect. Excuse me? Okay. Then comes the question is what happens to these populations who develop chronic chikungunya arthritis? Do they develop rheumatoid arthritis? So this was a nice study which Ashish did from Trivandrum, and you can see that 15 months down the line, some of the patients did develop syndromes which are commonly seen in rheumatology practice, such as rheumatoid arthritis, psoriatic arthritis-like disease, undifferentiated spondyloarthritis, and just sanomitis or bursitis. And this is another study we did near Perintalmanna. And here this particular geographical location was not affected by chikungunya. And you can see, as opposed to that population which Ashish studied, here you had soft tissue rheumatism and low back pain and osteoarthritis as the major rheumatological diagnosis, rather than a proportion of patients having inflammatory type of presentation. So this is what we see in rheumatology practice, or we may see. So it can be symmetrical polyarthritis resembling rheumatoid arthritis, oligoperipheral monoarthritis resembling undifferentiated spondyloarthritis, inflammatory low back pain, and inflammatory myositis-like presentation, and of course, fibromyalgia. And this is what you see in chikungunya arthritis, very similar to rheumatoid arthritis. This was a French study, and you can see that after 307 patients were diagnosed to have chikungunya, they were followed up at 17 months and at the 32nd month, and a proportion of patients developed rheumatoid arthritis like clinical syndrome. Very small numbers in this particular study, but nevertheless 13. So this systematic review tells us that 25% of the patients who have acute chikungunya infection would develop chikungunya chronic inflammatory rheumatism, that is chronic arthropathy, in later stages of their life. Okay? And if you include all the studies, then the number goes up to as high as 34%. So then the next question comes, is there any radiological evidence for that? Okay, so this was a study done in Dakshin Kannada, and out of 203 patients with chikungunya fever followed up, you can see 94 had arthritic symptoms persisting, and 20 of this 94 had X-ray and MRI. You can see that 5 of them on X-ray had developed erosions, and if you look at their MRI findings, it is very similar to what is seen in rheumatoid arthritis. So then the next question comes is there any immunological basis for this? Yes, there is, and if you look at the literature recently as it is coming, there is a new candidate every day. So now if you look at this slide, it might also help you understand that why the agents which are used to treat rheumatoid arthritis or many of our rheumatological conditions are also effective in chikungunya arthritis, because the candidate targets are the same. So the next question comes is, who are going to develop chikungunya arthritis, the chronic phase? So older age, of course, and then symmetrical distribution, very high inflammatory burden at the onset, and it is persisting beyond 4 months. And of course, if they have high level of interleukin-6 or increased level of ferritin in the experimental setting, the last 2. Then the final question would be how best to manage chronic chikungunya arthritis. Well, the objective here is very similar to what we target for in the management of rheumatoid arthritis, that is reduce the pain and the inflammation, prevent the stiffness, loss of muscle tone, and actually prevent the joint damage, which might be a consequence of the inflammatory process. So this is one study we did at Calicut. This was an open-label, randomized 24-week study where in 2010 we randomized 2 groups of patients. One continued to be treated with hydroxychloroquine alone as a monotherapy, and the second group was treated with triple therapy as we use in the treatment of rheumatoid arthritis. And they were given, both groups were given steroids right at the beginning, which was tapered off and discontinued by 7 weeks. And if this was an intention to treat analysis, and you can see that the red line on the top denotes DAS28 scores in patients who received hydroxychloroquine monotherapy was higher compared to the one who received triple therapy similar to rheumatoid arthritis. And if you look at their health assessment questionnaire, which denotes disability, you can see that there was significant improvement in patients who received triple therapy similar to rheumatoid arthritis. And this is a bit more detail about that. The EULAR good response, low disease activity, which is very close or as close to remission we can get. It was higher proportion seen in group who received triple therapy. And this is what happens when you give methotrexate to a patient who has chronic chikungunya arthritis. You can see almost the same type of resolution you expect clinically in patient you treat rheumatoid arthritis with methotrexate. So this is again a summary slide. Anti-inflammatory, paracetamol, weak opioids for the pain, but here steroids and of course all the drugs, including biologics in the selected few. So the overall recommendation, if you consider the Brazilian and the French recommendation, is to treat these patients as chronic rheumatoid arthritis. And if the patients are not achieving the target, that is disease activity score based on 28 joint counts, though that is actually surrogate and not particularly tested for chikungunya chronic arthritis, but you would still use that because you need to have a target. If these patients are not responding up to the expectation, then you will change the therapy, introduce the biologics in a similar way you do for the management of rheumatoid arthritis, because the studies have shown that untreated chronic chikungunya arthritis going to lead to similar type of damage to the joints. Then, as in rheumatology, of course, there are a lot of other things being tried. Abatacept and etanercept have been tried, and small case series, particularly from the French population, and they are effective in selected group of patients. So I would like to conclude by saying that there are many infections which can lead to musculoskeletal syndromes, if not inflammatory arthritis. Mostly might be arthralgia, particularly viruses, but then there are other sort of agents you need to be aware of. Tuberculosis, leprosy, they have their unique manifestations. HIV is also one of the important agent to be aware of. But when it comes to chikungunya, symptom management is the key for the acute phase, and then because the data, the knowledge is still evolving, and not that many countries has chikungunya per se, we had to rely on our existing knowledge, and we had to extrapolate our knowledge about treatment of rheumatoid arthritis to this particular condition also. Having said that, the actual structural benefit we need to assess, which is mandatory for any trial beyond 2 years in rheumatoid arthritis with either MRI or X-ray, has not happened in chikungunya arthritis. So I would like to conclude, and thank you very much.
Thank you, sir. It's an excellent talk. Sir has beautifully covered the entire chikungunya arthritis. Is there any questions? Sir, is there any vaccine for chikungunya, sir?
Offhand, I can't remember, but last I read there was some in development. Okay. Yeah.
So what is the treatment option in acute viremic phase of chikungunya?
Sorry?
Acute viremic phase of chikungunya. You cannot give steroids. NSAIDs also, dengue also mimic like chikungunya. So initially if we give NSAIDs, it may worsen dengue.
Yeah, so that is okay. So that is one of the critical, I think, component of our assessment to say this is chikungunya arthritis. See, mostly you can see that the chikungunya has happened in the endemic phase. Okay, And then there have been epidemics of chikungunya. So in that context, it is easy to make a diagnosis or assumptive diagnosis of chikungunya. But in all the other phases, like in this season in Calicut, if I have any patient with acute febrile illness with arthralgia, I will think about dengue first. Okay, because the caution is the very much what you said, to avoid anti-inflammatory agents and to minimize the risk of hemorrhagic syndromes.
Thank you, sir. Thank you very much.
Thank you.
Moving on to next topic.
It is I'm privileged to invite Dr. Professor Vinita Shobha Madam, and who is a professor and head of the Department of Clinical Immunology and Rheumatology at St. John's, and she is a researcher and teacher. Doesn't require any introduction. And now, so like Madam is enlightening about the macrophage activation syndrome in lupus, whereas macrophage activation syndrome itself is a difficult condition to make a diagnosis and manage. And let Madam enlighten us how to manage macrophage activation syndrome in lupus. Over to you, Madam. Thank you.
Thank you very much. Good afternoon, everyone. Thank you, chairpersons and organizers, for this opportunity. Macrophage activation syndrome is a very exciting topic, actually. It resembles the cytokine release syndrome, which we see in context of viral infections, etc. But in the context of autoimmune diseases, we sometimes fail to recognize it. And even if we recognize it, there is not much of evidence-based therapies which are available for treatment of MAS. So I will show you that in next 15 minutes or so. So I've been asked to talk about the therapeutic challenges, but I thought that I should start first with even the diagnostic challenges which we see in the context of macrophage activation syndrome. So the diagnosis in itself is rather gray, and the therapeutic challenge and the evidence for the choice of therapy is very, very lean, as I will show you in next couple of slides. So what exactly is this macrophage activation syndrome? It is a term used to describe HLH, which is hemophagocytic lymphohistiocytosis, and this is called MAS when it is occurring in the context of rheumatological diseases. And previously it was largely described in pediatric population, but now we are seeing it more frequently even in adult population. So it is characterized by inappropriate and sustained activation of cytotoxic T cells, NK cells, as well as myeloid cells, macrophages and dendritic cells. And that leads to cytokine storm, which is systemic. So the cytokines which are released are multiple: interferon gamma, IL-18, TNF-alpha, IL-6, IL-1, to name a few. And it can occur in several of the autoimmune diseases, not only in lupus, but also it of course happens in systemic onset GIA, in adult onset Still's disease. Kawasaki is one good example of where we can get this kind of macrophage activation syndrome, also in JDM, RA and Sjogren's. So HLH has traditionally been classified as primary and secondary categories. As we have understood more about the pathogenesis of MAS or HLH, now we are having more granularity in terms of understanding why MAS happens. So it could happen in context of some genetic abnormalities in the inflammasome pathway, in the perforin pathway, in the lysosomal trafficking pathway. But today what we are interested in is in the secondary HLH or the MAS, which happens in the context of autoimmune rheumatic diseases, and predominantly we'll be focusing only on lupus here on. So let me start with a case. This is a girl who was admitted just recently in our wards. She's a 22-year-old lady who had been diagnosed in December 2023 as lupus based on inflammatory polyarthritis, presence of fever, alopecia, and positive ANA and low complements. She was treated elsewhere with low dose with 0.5 milligram per kilogram body weight of steroids and hydroxychloroquine, and she was doing pretty good till 3 days prior to admission in St. John's, when she came with fever, headache and neck pain. And on examination there was no meningeal signs, and she did not have any features of active lupus as well. So we kept a differential diagnosis of neuropsychiatric lupus versus a CNS infection in view of fever, and she was started on IV hydrocort and ceftriaxone, and supportive measures were started. Her initial investigations only showed mild anemia, low albumin, and an elevated AST, which was a little surprising. 6 hours later, she developed a GTC and she became irritable. She had altered sensorium. Fundus examination showed early bilateral papilledema. Her initial viral screens were negative. Her CRP was elevated. And as part of anemia workup, we found that her ferritin was significantly elevated, which was 40,000. So what are we dealing with here? So we have a patient of lupus with a very high ferritin, and obviously our antennae go high, thinking that this patient might be heading towards macrophage activation syndrome. Her complements were low, the rest of the viral screens were negative, HIV, HBs, AG, HCV, and her CSF analysis showed lymphocytic pleocytosis. Her MRI brain showed diffuse leptomeningeal enhancement in bilateral frontal, parietal, and occipital region, and tiny foci of microhemorrhages and pons. So now we are dealing with this dilemma of neuropsychiatric lupus versus a viral meningoencephalitis. So her treatment with hydrocort was later on switched to dexamethasone because of the cerebral edema. And ceftriaxone was made into anti-meningitic doses, 2 gram IVBD, acyclovir was given, and she was treated with anti-epileptics and dexamethasone. Subsequently, a consultation was sent to us, and then we decided to give her IVIG, considering that she could be SLE flare in mass, which is impending. Subsequent to this treatment, her seizures episodes stabilized. She did not have any more seizure episodes. Her fever spikes came down, but her irritability continued to progress. So this brings us to the point of first challenge, which is how to diagnose MAS in an adult patient with autoimmune rheumatic diseases. As all of us are very well aware of the non-specificity of MAS manifestations, which can be quite variable. There can be a rapid development of multi-organ failure. There can be unremitting fever. There can be generalized rash, reticuloendothelial cell hyperplasia, cytopenias, worsening LFT, and also neurological involvement. Of course, one should not miss out on the features of underlying autoimmune rheumatic disease. So in our patient, while we were treating her, we found that her infective workups are all negative. Her CSF analysis grew nothing, and her meningoencephalitis panel was also negative. Her blood and urine cultures came sterile, and the MAS workup was strongly suggestive of macrophage activation syndrome with high triglycerides, low fibrinogen levels, and very high LDH levels. So this kind of confirmed our suspicion of macrophage activation syndrome in this patient. So this brings us again to discuss the lack of clarity on the diagnosis of AIRD-associated MAS. And we usually tend to rely on the criteria which has been developed for pediatric patients, especially in the context of systemic onset GIA. We use H-score for diagnosis in adults, which is basically applicable to HLH or MAS in adult patients with primary malignancy or infection. And when we get a value we have to get a score. If it is greater than 169, it has a high sensitivity and specificity. M-score is another one which is basically applicable to systemic onset GIA. It has a diagnostic cutoff value at -2.1. Recently, a new indicator has been developed for systemic onset GIA MAS, which is fairly easy to use, which is ferritin ESR ratio. If it is greater than 21.5, it is said to suggest systemic onset GIA MAS. So recently, last year, ACR-ULAR has also come out with points to consider in early stages of diagnosis and management of suspected HLH MAS with 6 overarching principles and 24 specific points. I'm not going to go into that, but we will just briefly go over how to establish the diagnosis of MAS a little better. So these are the various criteria which are available for diagnosis of MAS in adults, and this is what we tend to use. And let us try to apply this score to our patient. And we found that as an academic exercise, if we try to calculate her H-score with prior known immunosuppression, a febrile illness, high ferritin levels, high triglycerides, high AST, and low fibrinogen levels, we get a score of 214, which is giving us a 80 to 88% possibility of this being a macrophage activation syndrome. So now that we have made our diagnosis clear, one needs to think, why has this happened to this patient? So there are several inciting factors which are known. For example, infections, that's the one which is considered most relevant. So in our patient, the CMV titers came negative. And there are several other infections, but it is believed that most of these patients who go on to develop MAS actually have one or the other kind of genetic predisposition. So moving on to therapy, that challenge, So treatment of MAS is not, there is no standard of care. There is no guidelines which is based on evidence. The first line treatment is usually high dose corticosteroids, which is efficient in about 2/3 of patients. Sometimes we tend to add IVIG. In our patient, it was chosen because we were at a dilemma point between an infection and SLE flare, not specifically for MAS at that point in time. There is no comparative data for several of the second line agents which are available, and there is definitely insufficient evidence for refractory or relapsing MAS. So this table is just to tell us that both methylprednisolone and dexamethasone can be used, though there is no RCTs or systematic review looking at the evidence of glucocorticoids in MAS, especially which one is better, whether it should be DEXA or it should be methylpred pulse, and in what dose. And of course, IVIG is the second good option. But what is the evidence for IVIG in MAS? So basically, again, it's driven from pediatric population. The data is very sparse, largely from case reports or case series in context of autoimmune rheumatic diseases, and I could not find any RCT or systematic review looking at the use of IVIG in MAS. So if you look at this study which came out from France, 103 episodes of MAS in about 89 patients, and very important to note here that in 41 patients, almost half of the patients, MAS was inaugural. That means it was the first manifestation of SLE. And when they gave these patients glucocorticoids, the success rate was about 60%. And when they gave corticosteroids plus IVIG, even then the success rate was almost same. The relapsed patients, they have used IVIG, cyclophosphamide, etoposide, rituximab, and despite whatever treatment they gave, 13 patients had relapsed, 33 episodes had required ICU hospitalization, and 5 patients had died. So that means this is a disease which can be difficult to treat despite all the measures which we have at our deliverance. So coming back to our patient, so with our treatment, she started improving, and as she was improving, she was administered cyclophosphamide to take care of her neuropsychiatric lupus, which was one of the manifestations for her. Her ferritin started falling, LDH came down, CRP came down, AST started falling, but then while we were waiting for her to get discharged, her irritability continued to be present. She again developed cytopenias, and we were wondering if it was cyclophosphamide induced, or was it a CMV reactivation, or was there a recurrence of MAS. And at this point, again, we found that the ferritin levels had again rocketed to 22,000, and the white cell count was dropping rapidly. So we again looked for infections, and we found that those were negative. So in this patient, then again we were forced to give methylprednisolone for 3 days. This time we wanted to be 100% sure that we are not dealing with an infection, so a whole body PET CT was done, and which did not show any evidence of infection. So then, because she continued to worsen, we gave her IV anakinra, 100 milligram, 5 doses, and with that she is improved, and she has actually gone home just a couple of days back. So what is the evidence for anakinra in context of MAS? Anakinra, as we all know, is a recombinant humanized IL-1 receptor antagonist, and it is licensed for use for rheumatoid arthritis, SOGIA, AOST, and CAPS. And it has been used even in sepsis-associated cytokine storm syndromes. In one of the systematic review published last year, it was found to have a good success rate, especially in patients who were having rheumatology-triggered MAS, and the survival rate was as good as 83%. But what is the evidence for cyclosporin? Again, the data is very sparse, based largely on the case reports or small case series which were published in the context of pediatric HLH more than 25 years back. And it was published that it exerts a switch-off effect on the disease process, leading to quick disappearance of fever and improvement in the laboratory and abnormalities within 12 to 24 hours. And that is how we continue to use cyclosporin as one of the therapeutic agent in the context of MAS in adult autoimmune rheumatic diseases. But what if this patient hadn't responded to anakinra? What would we do? So plasma exchange is another option. In one study from China involving 62 patients with MAS, they gave glucocorticoids and plasma exchange, and they found that these patients who received plasma exchange actually had a better outcome as compared to those who did not receive plasma exchange. And after plasma exchange, they reported that multiple inflammatory parameters actually were rapidly reduced, accompanied by improvement in clinical symptoms as well as the laboratory indices. What about JAK-inhibs? Do they play a role? Do they stand a chance in the treatment of MAS? Yes, ruxolitinib, which is a non-specific JAK inhibitor, JAK1 and JAK2. We all know that JAKs use the JAK-STAT pathway, inhibit the JAK-STAT pathway, which is using multiple cytokines. Multiple cytokines are using that track. So ruxolitinib has been used in primary HLH in several patients, but it's again the data is in few patients or in few small case series. And in context of lupus, I could find just one case report wherein there was a successful treatment of HLH in a patient with SLE who was treated with ruxolitinib. Emapalumab is a new kit on the block, which is anti-TNF targeted therapy, and there is a recent trial published last year in 14 patients with resistant MAS with good results, and there was an achievement of remission in 13 out of 14 patients. And this graph over here is showing the rapid decline in the ferritin levels, in the AST, in the platelets, as well as in the LDH. So this is another option which might be a good molecule to look forward to in the context of MAS. So coming lastly to the outcome, the mortality rates in SLE MAS are quite high, 5 to 39%. In a retrospective study from China, 90-day all-cause mortality was about 22.9%. And it was found that ferritin, a high ferritin of more than 6,000, that has a highest, is the strongest independent predictor of poor outcome in autoimmune rheumatic disease associated macrophage activation syndrome. So we were lucky to discharge our patient and send her home safely. Thanks to my team, and Dr. Ramya is the one who is largely seeing this patient in the wards. And thank you, Keetna, for making this case summary for me. Happy to take any questions. Thank you.
That was a lucid presentation, excellent. Open for a discussion. We can take a few questions.
Ma'am, we've been seeing probably, as you said, many times it's the first manifestation. So we routinely include ferritin upfront to prevent a delay. In one patient, what happened was ferritin was going above 1 lakh. We were measuring. It was going up to 2 lakh also. We had that nephelometer to measure it. So I didn't know what to do. I was giving sequentially methylprednisolone, IVIG. I had to give, I was just wondering what to give. Then what I did is, I just started cyclosporin and just switched to dexamethasone and kept it on hold for a longish while, for 2 weeks, then it abated. So as a consequence, he has had avian, but we could save him. It's a male SLE, very aggressive, and all he had was only SIRS. No organ involvement, no skin involvement, just came with SIRS, MAS with SIRS features, and the ferritin was just shooting up. So sometimes we may not get trials, we have to go beyond trials, and as you said, ma'am.
So one thing we could look at is for infections like CMV and EBV virus, but then there are several others which we may not be able to pick up.
Okay.
But even if we pick up CMV, does CMV treatment change the course? There are some studies which are saying that even if the CMV is coexisting, giving them antivirals did not actually change the course of the treatment. So I think the steroids and cyclosporin is the best way forwards.
In EBV, there are many tests. If at all we have to check new infection, apart from EBV, IgM, do you have to do a DNA?
Yes.
Both?
Yeah, nuclear antigen, EBNA has to be done.
Acha, EBNA, okay. Thank you, ma'am.
Ma'am, I have one question. Ma'am, there is this scenario where there are some patients who are refractory to IVIG, refractory to pulse corticosteroids, refractory to cyclosporin inhibitors. So we had one patient who had EBV positivity, lupus patient, and the patient had CNS dysfunction and coagulopathy and severe hepatitis. Eventually we lost the patient, ma'am. So in such a patient, there are some reports which say that you can give rituximab. Do you have any experience successfully treating EBV associated MAS with rituximab? Because like the ICU physicians were too scared to give rituximab.
So rituximab takes some time to act. So it is not a preferred second line or a refractory drug to choose because it takes time and you might lose in the meantime. So I think what other things could have been tried was plasma exchange, as you're saying that this patient was in ICU and had a lot of other complications. So I think plasma exchange is something you can try. And our patient too, we felt there was a time when we felt that we might lose this girl. And that is when Ramya was very smart. She talked to some children hospitals and they had a ready-made stock, ready stock of anakinra. And we were able to get it and send her home, So that's another option which you could consider. And because it's only anti-IL-1 and it doesn't really has a lot of side effects, anakinra. So I think that's something which you can look at.
Thank you.
Thank you, ma'am, for the excellent talk. Between the second line options between IVIG and the 2004 HLH protocol, which has cyclosporin and etoposide, which one do you practice? Like, which is your preferred one? I agree in this patient because she has CNS toxicity also. Cyclosporin may have been, that is maybe one concern. Plus infection. Infection, mostly it is viral that we are scared of.
Yeah.
So what is your current practice between IVIG and the cyclosporin?
Between IVIG and cyclosporin. So IVIG is the easiest choice to make because we can use it. It will work for both SLE as well as for the infection. It will not definitely harm, and it is a good choice even for MAS. So that is why I think Ramya chose IVIG up front, and she did not choose cyclosporin. Actually, I said that we should have given her cyclosporin. Then maybe she won't have worsened later. But it was not chosen because of the fear of the CNS toxicity. Etoposide, I have not personally used. I remember hemat people using it in one patient, etoposide, and that patient died. So I have that negative thought about etoposide.
Thank you.
In this setting, which steroid you can prefer, ma'am? IV methylprednisolone or dexamethasone, because dexamethasone have a long action. So could we use the dexamethasone in the place of methylprednisolone?
So there is no hardcore evidence for either in the context of MAS, dexamethasone as well as methylprednisolone. And traditionally, we have been taught to use dexamethasone because of its longer duration of action. And so I prefer to use dexamethasone, 10 milligram per meter square. If patient doesn't respond to dexa, then we tend to juggle around with methylpred as well. But I prefer to use dexa, but that's what I have been taught, not what I have learned from literature.
Ma'am, you said about cyclosporin. Is there any data of tacrolimus? And another question, how long to continue CNIs after the resolution of MAS?
So I did not look up the data on tacrolimus, so I can't say that offhand. The next question was about?
How long to continue CNIs?
So 2 to 6 weeks is what is written in the textbooks, and most of the times what I do is I send the patient home on cyclosporin, and when they come back for follow-up 2 weeks down the line or 1 week down the line, if their counts and all are stable, then I usually switch cyclosporin to what would be their best second-line immunosuppressant, and I withdraw taper cyclosporin. I don't abruptly stop it. That's what I do. But the duration is 2 to 6 weeks.
Thank you, ma'am. One last comment, like etoposide should be one of the cheapest alternative to anakinra. That's what we have experienced in one patient in NIMS, madam. That much, like I don't have an experience in SLE patient, but we have treated one HLH patient with etoposide. With that comment, I conclude this session. Conclude this topic.
Thank you, ma'am.
Thank you, ma'am. Thank you very much.
Thank you.
Moving on to next topic, that is dose tapering and discontinuation of biologic therapy in spondyloarthritis. I would like to invite my senior, Dr. P. Damodaram, is a senior consultant rheumatologist from Tirupati. He has many international and national publications, and he has got IRA Young Investigator Award, Best Paper Award, and first prize in state chest conference quiz. Over to you, sir.
Thank you, sir, for giving this opportunity. So my talk was on dose tapering and discontinuation of biologics in axial spondyloarthritis. And this topic is very relevant, especially in Indian settings, where the cost is very important, because most of our Indian patients, they don't bear the cost of using the biologics for a longer time. But in spondyloarthritis, we don't have any other choice especially in those patients who have very severe risk factors, and especially with hip involvement. So we need to give a very long duration of biologics therapy. So first we need to know what will happen if there is an abrupt withdrawal after remission. So in this observational study, you can see in initial cohort of 107 patients, the clinical persistent remission was noted in 36 patients. You can see the response rate is roughly around 40%. And then when you stop at this stage, so what will happen? So nearly 10% of patients will remain drug-free, that is 12 patients out of 107 patients, and then relapse was noted in rest of the patients. And then if you reintroduce again the infliximab in this group of patients, the remission was resumed in only 11 patients, but the remission was not achieved in 10 patients. So this is the subgroup we need to analyze. What are the factors why they responded initially and then later they become refractory. So, and the similar study with adalimumab. So out of 48 patients on adalimumab, 24 patients had a defined SS40 response. And then if you stop abruptly adalimumab and you follow up later, in the mean relapse time was 14 weeks, nearly 10% of patients able to maintain the SS40 response, and rest of the patient relapsed after 14 weeks. So, and after 2 years of treatment, 15 of 19 patients achieved SS40 response again, but 9 of 19 patients could not able to achieve a complete remission. So we need to identify what is the reason of failure to maintain remission after reintroduction after a good remission. So this subgroup analysis is very important so that we can have more knowledge about what is the factors that leading to the failure of remission the second time. So this is another RCT where they taken a large group of patients, 673 patients. Among them, only 45% of patients achieved sustained remission. And when we stop adalimumab abruptly, so 152 patients, they randomized patients, 152 patients, they continue to take adalimumab, and 153 patients, they use a placebo. And you can see in the group of patients where they restarted adalimumab, again only 70% of patients achieved remission, 30% could not able to achieve a remission. Earlier they achieved remission. So whereas 47% of 72 of 153 patients, that means out of 673, 72, then again roughly it comes around 10.6% of patients can able to maintain a drug-free remission after achieving a very good clinical remission. So we need to identify what are the factors that leads to drug-free remission and why patients who achieved remission at first time could not able to achieve later. So we can broadly classify in 4 subgroups those patients who achieved drug-free complete remission after effective treatment, no relapses even after stopping the drug for 1 or 2 years, and those who had remission only with the medications, and the third subgroup who lost drug-free remission after reintroduction and difficult to achieve remission. So we need to identify what is the factors that lead to this type of subgroups, so that we can modulate which subgroup of patient we can able to taper the biological demods. So this subgroup is very important. This can be explained by the development of anti-chimeric antibodies, or the disease might have become more severe after the cessation of the biological demods. So this is another study, interesting study, treatment retention rate of infliximab. This is also one of the important factor. So if you see after 1 year, only 50 to 60% of patients could able to retain the treatment with infliximab, whereas with etanercept, the treatment retention rate is much higher, maybe because of the ease of administration and no need for hospitalization. So in this study, if you see both the etanercept and its biosimilar and infliximab biosimilar achieved equal remission after 6 months. So this is another study, systematic review analysis, where you can see the flare rate after abrupt withdrawal of the drug. So you can see the timing of attaining remission is varied in each study, and these studies was conducted from the different parts of the world. It ranges from 3 months to 3 years. And you can see the adalimumab could able to, the less flare rate was noted in adalimumab, but this was not reciprocated in other RCTs. So if you see the only RCT data that was there in this analysis, we can see from the China, the use of etanercept, the flare rate was observed in 79% of patients. In the ABILITY-3 trial, the flare rate was noted after 40 weeks in 52.9% of patients, whereas in co-optimized trial and cost-Y study, so they flared that with ixekizumab, the flare rate is much less, 45.3%, whereas with satrozumab, it is 79.8%. And the go-back and re-embark study, where where they analyzed the golimumab, the flare rate was 66.1% after 52 weeks. So this, you can see the data is not uniform, and the flare rate was observed in, with different biologics at different timings. So based on these observations, the EULAR introduced one more recommendation that we need to consider tapering biological DMARDs in patients who achieved sustained remission for a minimum of 6 months. And the treatment aim is to induce clinical remission or low disease activity utilizing combinational therapeutic agents. But most of the studies that has analyzed the tapering of those tapering of biologics are single studies, so that we cannot give a perfect conclusion whether the addition of DMARDs or addition of the intense exercise regimen or dietary modulation or risk factor modulation can play an impact role. So this study, you can see the etanercept once in 2 weeks was a standard dose, and when they followed up 22 months, the remission was maintained equally in both the groups. And there is another study in China where they used Enbrel for induction followed by Enbrel 25 mg weekly once was a standard dose. And they found that the mean VASDI was maintained equally in both the standard groups and also the tapering group. So this is another study where they looked up the satrozumab, and they found that the monthly satrozumab versus once in 2 weeks satrozumab, and they found that the flare-free survival is also similar between the standard group and the tapered group. So there is another RCT where they tried dose spacing, like once they have gone 3 months, they spaced it for once in 6 months, or if it is adalimumab, once in a month means they, once in 15, they change it to once in month, something like that. So in this study, they found that the dose spacing by 50%, so they found that the mean flare rate was mean remission was equally in both the standard groups and also the tapered group. So in another study where there is an intense treatment followed by maintenance with 25 mg weekly once etanercept versus standard care. So they also found that the efficacy of both the standard drug and also the tapered regime both are showing same percentage of remission. So this is another study where they studied first dose reduction by 50% and then by spacing by more than 50%. So they both dose reduction and also spacing. So they found out that in this RCT done from Netherlands, so they found that the mean disease activity is more or less similar in both the standard group was therapeutic group. So there is another study in Denmark. They also done the TNF spacing and also dose reduction was a standard practice. They found that the mean DAS was similar with the both standard group and therapeutic group. So this leads this number of studies, perfectly done randomized control trials from different parts of the world. So they found that the maintenance of remission in both the groups was similar when you use etanercept 50 mg weekly once in 2 weeks, or etanercept 25 mg weekly once, or stepwise induction with standard dose, then followed by 25 mg weekly once, or TNF inhibitor dose spacing by doubling the time, and with or without 50% dose reduction was also found to be equally effective in maintaining the remission when compared to the standard care. And also satrozumab monthly once is also almost equally effective when compared to the once in 2 weeks in maintaining the remission. And also golimumab once in 2 months is not inferior in maintaining remission when compared to the monthly one. So based on these observations, so as guidelines came up that yes, we can do dose tapering and maintenance in patients who are using biologicals after an effective induction of clinical remission. So these are the various dose reduction strategies. Dose reduction, 50% reduction in dose or increased spacing with standard dose with or without 50% reduction in the dose. And other one is stepwise reduction. So this is more compatible in our setting. So where you progressively taper the dose first by spacing and then by decreasing dose, and then if possible stop the medication, and if patients noted any flare, then you can do a re-intensification. So in this DRESS PS trial, it was shown that the cumulative incidence of flare was 85% in the tapering group and 78% in the no tapering group. So whenever you consider dose tapering, we need to discuss with the patient about the risk of flare and about the possibility of making a drug-free remission that can be noticed in approximately 10 to 12% of patients. So when we see the structural progression, so this is another study which showed that whenever the patient has a baseline syndesmophytes, when you use tapering TNF inhibitors, there is a progression of syndesmophytes. New syndesmophyte was noted and the SAS score was increased. Even though the BASDA CRP levels was both normal, could able to achieve equally in both standard and tapered group, the structural progression was noted those who has got a baseline syndesmophytes. So to conclude, TNF inhibitor is the only option for AS patients who remain active after the first line NSAID treatment until the introduction of anti-interleukin 17A blocking agents. There are many studies showed that spinal inflammatory agents and MRI rapidly improved by TNF inhibitors, but the continuous treatment for 2 years failed to inhibit the newborn formation. But in this study, we can see that if the patient doesn't have a baseline syndesmophyte, the continuous use of standard care found to be effective in preventing the structural progression. And many cohort studies showed that early use and long-term use of TNF inhibitor can diminish the radiographic progression. So another important thing is the infections, the viral infections, bacterial infections, skin and soft tissue infections. So these infections are also one of the indications to reduce the dosage of anti-TNF, and also the hypersensitive reactions, demyelinating lesions, and induction of DNA and non-melanoma skin cancers. So if, in anti-TNF agents was particularly effective in the group for younger, for male gender who has got peripheral arthritis, for non-smokers, and those who has got high patient assessment of disease activity and elevated inflammatory markers like CRP and serum amyloid A. So in this subgroup of patients, anti-TNF agents are found to be more efficacious. So to conclude, anti-TNF agents tapering is feasible in those who attained sustained remission. Patient-tailored dose reduction of anti-TNF can be effective, and in patient with already having underlying symptoms, right, the tapering group progresses more than the standard group, even though the BASD and CRP responsiveness. And anti-TNF agents are more effective in certain group of patients who are younger male and those who has got higher CRP, because many of the studies was carried out with a purely one drug into picture. They don't look into the combinational DMARDs along with the usage of biologics, and also the intensive exercise therapy and risk factor modification like stopping smoking, and dietary modifications, infection prevention. So probably we need to have a more robust data so that we can take in all into the account for even further reduction of the biological DMARDs. And thank you. So such a memorable experience. Thank you, whole ZIRACON team.
Nice talk, sir. Nice talk on dose tapering and biologic therapy in SPA. Sir, I have a question. Is there any role of tofacitinib in maintaining the remission? After achieving the remission with anti-TNF, can we continue with tofacitinib?
That's what I mentioned. That theoretically, the studies was in those who has got anti-TNF non-responders, we can use tofa. But those patients who already responded to biologics, then switching out to tofa, there are no much studies in that context. That was the lacunae. So we need to have a more robust data, so that where you can use the combinational DMARDs along with tapering biologics. So that will give a more better answer.
Any other questions? Thank you, sir. Moving on to next topic, that is golimumab Indian experience. I would like to invite Dr. Balaji. Dr. Balaji, he is a professor of rheumatology at SRMC, Chennai, and senior consultant rheumatologist at Parvati Hospital, Chennai. He has the best outgoing students and MD internal medicine, and he has many publications and poster presentations. Thank you, sir.
Thank you.
Over to you, sir.
Today my topic is on golimumab Indian experience. So I'll keep it very short. So golimumab indications, this is the overview of the global trials. So for AS, rheumatoid arthritis, and psoriatic arthritis, we have all the GO suffix trials. So these trials are already well established, the safety and efficacy of golimumab. With regards to the Indian data, I would want to talk about one trial, which is the GO MORE trial. So the first trial that I'm going to discuss is the GO MORE subgroup analysis. So golimumab in Indian RA patients, this is the global trial in which the Indian data I'm going to discuss. So the subgroup data is from a multi-center. You can see the authors, Dr. Sarvajit Paul, Dr. Sharat Chandra Moli, Siddharth Kumar Das, Vinita Shobha. So we have got a good number of representation across the country. So this GO MORE study, the study design is an open-label, multi-center prospective trial of add-on golimumab in biologic-naive RA patients who are on background methotrexate therapy. The sample size was 106 patients. When we compared with the global data, the Indian patients had a higher disease activity at baseline. DAS28 ESR was higher in 91% patients in Indian population versus 78% in the global population. So the efficacy outcome in the GO MORE trial is the number and percentage of patients who achieved DAS28 ESR and CRP. EULAR response at the end of month 6 was comparable both in the Indian population and the population outside India. So from the GO MORE study, at 6 months, the disease activity was good, with the ESR, CRP, SDI, and the Eurocold questionnaire scores were comparable in both the groups. Incidence of all adverse events were much lower in the Indian patients. There were no deaths, cases of tuberculosis or malignancy. So this study concludes that as an add-on therapy to methotrexate, golimumab in India has no new safety signals. Only difference between the Indian population and the global population being that the baseline disease activity was higher in Indian patients. Next trial is, this was published in IJR and was also presented at 24th APLAR. So this was safety and efficacy of golimumab in RA. This is a prospective, multi-center, real-world study. So this is a phase 4 study. You can see the authors, Dr. Bimlesh, VK sir, Uma Kumar ma'am, and Sandeep Kumar sir. So this is again good representation from both north and south. So this was a phase 4 prospective open label study with 120 patients and 6 sites over a period of 24 weeks. The study population was moderate to severe RA initiated on golimumab as per the treating physician's clinical judgment. So golimumab was given here along with methotrexate like in the previous study. So this was basically a safety study. So the primary objective was assessing the safety and the exploratory ones were the patient reported outcomes. So let's talk about the safety data. The safety data here is 51% of the patients experienced more than one treatment emergent adverse effects, which were mild to moderate in severity, like pyrexia, arthralgia, UTI, cough, and URI. No cases of TB malignancy or death. Serious adverse events, 4 were reported in this study. They were abdominal wall abscess, atypical pneumonia, liver abscess, and cholelithiasis, which were all well treatable. So this was the safety data from this study. Coming to the efficacy data, there was good improvement in the disability index, fatigue scores, and also improvement in the DAS28 ESR and CRP. So next thing that they also assessed was satisfaction and user friendliness of the auto-injector pen, which was 64%. The patients have given a satisfaction rate for the auto-injector. So this study, conclusion is golimumab plus methotrexate was safe and well tolerated in Indian RA. Subjects with a high disease activity have good improvement, physical function improvement, and fatigue improvement from baseline. Scores of health assessment questionnaire and fatigue score showed clear benefits. patients were very satisfied with the auto-injector, and majority did not experience any injection site reactions. Moving on to the third study, golimumab in AS and psoriatic arthritis. Again, this was a multi-center, non-comparative, open-label, real-world study. The authors were very similar to the previous study. This study, again, sample size 100 patients and 9 centers, followed up for 6 months. Golimumab given monthly once with the, I'll tell you about the drugs that they had used. So this study design had a screening phase, treatment phase, and a follow-up phase. So in the screening phase, they had identified patients for golimumab, and in the treatment phase, patients were given 7 doses of golimumab. And in the follow-up phase lasted from 24 weeks to 32 weeks, where they followed up for side effects after completion of the study. Now, if you look at the data for ankylosing spondylitis and psoriatic arthritis, as expected, this patient characteristics, men were 90% in AS and 66% in psoriatic arthritis group. And concomitant medication in ankylosing spondylitis was predominantly sulfasalazine, and in psoriatic arthritis group, it was methotrexate. So these were the baseline characteristic differences. Both, coming to the efficacy outcome, both ankylosing spondylitis and psoriatic arthritis, ASAS20 was seen for AS and ACR20 responder rate for psoriatic arthritis. By week 4, there was good response with both the groups. And by week 14 and 24, there was very good response. And 66% achieved ASAS20 response in AS group. And in psoriatic, 93% achieved the ACR20 responder rate. The efficacy endpoint, the patient global assessment, total back pain, BAS-P and BAS-TI, the inflammatory component of BAS-TI, there was good mean change in the AS group. In psoriatic arthritis group, the tender joint, swollen joint count, patient's assessment of pain, patient global assessment, physician global assessment, health assessment questionnaire, there was very good change in the baseline values from week 0 to week 24. Coming to the safety data, again, mild to moderate treatment emergent adverse effects were documented, like nasopharyngitis, URI, pyrexia, cough, diarrhea, and gastritis. 4 patients reported serious adverse events, no deaths, no malignancy, or no TB reactivation. Next, moving on to some case reports, there were good number of case reports on usage of golimumab in ocular disorders like ocular hypotony, B27 associated, and 1 case of idiopathic necrotizing scleritis with secondary glaucoma. And there was also a case series of golimumab usage in uveitis and scleritis from South India. So several ophthalmological, that is uveitis, predominantly treated with golimumab, and 1 case of scleritis also. Now we talked about the safety. So can anybody guess what is this? So this was a case report from JIPMER on golimumab-induced toxoplasmosis. So this was a sarcoid patient who was refractory to methotrexate, and they had tried golimumab in this patient. After the 2nd dose of golimumab, a patient developed ring-enhancing lesions and neurological deterioration. And the brain biopsy confirmed trophozoites in the parenchyma and the histiocytes, confirming toxoplasma gondii. So this was neurotoxoplasmosis following golimumab therapy after 2 months. So we need to watch out for atypical infections after golimumab. So basically summarizing, we had 3 trials of golimumab. 1 was an RCT, which is we have the GOMOR, where we have an Indian subgroup there, and 2 real-world data from across the country. So we had this RCT, we had 106 patients, which was published in IJRD, and IJR and JAPI, we had 120 and 100 cases for RA and AS psoriatic arthritis. So from these trials, the limitations being most of them were open label, very small sample size, and another drawback is they were followed up only for 6 to 7 months. So we do not have data for long-term safety of golimumab with regards to India. So that data we need to see. We don't have it actually. So recently conducted RC, summarizing the trials, for the approved indications like rheumatoid, AS, and psoriatic arthritis, golimumab is safe and efficacious in Indian population. Important take-home message will be, in the first 7 months of treatment, no risk of TB reactivation, malignancy, or deaths, and there was meaningful improvement and sustained improvement in the patients with regards to both disease activity and functional scores. Also, golimumab being an auto-injector pen, there's a convenient option for effective intensification of therapy in all the approved indications. Thank you all.
Thank you, Dr. Balaji, leaving more than 6 minutes time. Thanks for saving time. And session is open for a discussion. Any comments from the audience? Yeah. What is one comment? What is the maximum duration of the golimumab we can try, according to you?
Sir, if we look at the long-term data, there have been trials where they've given anti-TNF continuously for 4 years. Golimumab 4-year data and all is there. So we can try, but in Indian scenario, I'm not sure if we can continue giving that long. Personally, I have given for patients up to 2 years, but say after 1.5 years, I have tapered it to once in 2 months or once in 3 months. So I have personally experience in patients being on golimumab for 2 to 3 years, but of course, the frequency does change. We don't give monthly ones forever. But as such data, we have up to 4 years. But Indian data, we don't have. Sir.
Okay, if no further questions, we
Thank you.
like to conclude the session. Thank you, one and all. Thank you, Dr. Balaji.
Thank you, sir. So the quiz in this hall will start in about 10 minutes time. So we'll just make the arrangements and then we'll announce the winners in about 10 minutes time.
A kind attention. So quiz grand finale shall be conducted at 6 p.m. today in Hall A. So I invite the chairpersons of the last session, Dr. Kishore Babu sir, to present the memento to the speaker, Dr. Vinod Ravindran sir. So now I invite Dr. Kishore Babu sir to present a memento to our speaker, Dr. Vinita Shobha ma'am. அடுத்தது இந்த ஸ்பீக்கர் இவங்க யாருக்கு யாரு தாமோதரன்கா So next I invite Dr. Ramakrishnam Naidu sir to present a memento to our speaker, Dr. Damodaran sir. I invite Dr. Ramakrishnam Naidu sir to present a memento to our speaker, Dr. Balaji sir. I invite the chairperson, Dr. Ramakrishnam Naidu, sir, to present a memento to another chairperson, Dr. Kishore Babu, sir.
J, J, J. J, J.
Bonish, Bonish. இதை ஒரு செகண்ட் டைப் பண்ணேன் இந்த சைடு ஃபுல்லாக நேம்லாம் போட சரி ஓகே ஓகே ஆ மைக் அங்கே டீம்ஸ் இருக்கு இல்லையா அங்கே ஈச் டீம் ஒன் சிக்ஸ் மைக்ஸ்
Hello, hello.
J, J, J,
எங்க
J, J, J,
Hello, check, check. Check, check, check. Check, check.
இல்லை இல்லை வேண்டாம் ஒரு டைப் நம்ம ஓரளவு சொல்லிக்கலாம் பென் வச்சிடுங்க வைங்க இங்கே ஸ்கோரிங் டீமுக்கு ஒரு டேபிள் வித் சேர் உங்களுக்கு இங்கே I can see some of the participants are only here. Can you call the others?
One chair, one chair. இது போறாடே.
How long is it going to take? Because I'm not sure about the distance. See, there's one small confusion here that there's a team from CMC, only one member is there. The other person is on the way. Since it's a team quiz, in case before the quiz starts, the other person is not able to make it, then the second team which is qualified from CMC will be participating. So you have few more minutes to wait for your partner. If they don't come, then the other team who have qualified from CMC will come. Okay? Have the lots been taken? Yeah, you can announce.
So, Team A will be the team from MMC. Please, you can take your seats. Team B will be from CMC Vellore. I think we'll wait. Team C is from CARE Cochin. Please take your seats. Team D is from Amrita Kochi. Team E is from SRMC Chennai. And Team F is from St. John's Bangalore. Good luck to all the participants.
So before we begin, so I am Dr. Balaji, I am the quiz masters, one of the quiz masters. So Dr. Bhuvanesh, so I am from Tamilnadu, and Dr. Bhuvanesh from Kerala, he is representing the Kerala. We have Dr. Abhishek from Karnataka, he is from Bangalore. We have Dr. Aparna from Tirupati, she is representing Andhra Pradesh. And we have Dr. Vignesh from Warangal, he is representing Telangana. And we have Dr. Sundaram from the local host, Coimbatore team. So we have selected the quiz masters in such a way that all the parts of South India are represented well. So big round of applause to the entire quiz team, because from the prelims to the every round, trying to make it innovative and make it exciting for the participants and for the audience, all have really contributed a lot. So big round of applause to all the quiz masters. So we'll start with the general quiz rules. I think we'll have to, anyone who's tracking the other member from CMC, will they be able to make it? Outside? Okay. Then the other participant you can come at least see the rules. So these are basic rules. The first answer given by the team after they are asked to give their answer will be considered as the final answer. Only one member of the team is allowed to answer into the mic. Please answer into the mic. Decision of the quiz master is final. We expect the audience to encourage the participants and not whisper the answers. I'm sure many of the students here will know the answers, even the faculty. Please do not whisper the answers. Our audience have their own set of questions. I think you can try them. Okay. So this is the blueprint of the quiz. We have round 1 and round 2. So in round 1 and round 2, we are going to have all the 6 teams participate. At the end of round 2, we will have one elimination. So 5 teams will make it to round 3. In round 3, we have 5 teams, and at the end of round 3, we'll have 2 more eliminations, and the rapid fire, we will have a total of only 3 teams. So the finale will be played by 3 teams. So round 1 is called pounds, round 2 is called mystery box, round 3 is shots, and round 4 is rapid fire. So all the best. So have fun. The basic motto of this quiz is it's learning, it's fun, just to encourage good bonding between all of you and good teamwork. Okay, so let's move to round 1. So round 1 is called pounds. So this is the format of the pounds. Question 1 will be directed to team A. So team A is MMC, so you will be getting 1 question. When the question is flashed on screen, a pounds window of 30 seconds will open. So from team B to F, all teams can give the answer. You have a pad with a paper given to you. All the 6 teams can give the answer in that 30 seconds, but you will have to write down the answer except MMC. Okay, all other teams can write down the answer, but only if you wish to. If you do not wish to, don't give the answer. Because the pouncing teams, if you give the right answer, you will get +20. If you give the wrong answer, you get -20. But the question to which MMC, we are directing the question to MMC. If they give the wrong answer, they only get 0. If they give the right answer, they get 20. So the other teams who are going to pounce, you have to raise your hands and you have to commit your pounce. Okay? So if you give the wrong answer, it's minus 20. So basically, this round gives opportunity for all the 6 teams to answer all the 6 questions. If you're very good and confident about your answer, you can score for every other question. If you're underconfident, you will get minus 20. So you have to take that risk. Okay? So are the rules clear? So once you write the answer, you will hand over to Dr. Sundaram, and he will let us know about the pounds. Then after that, when I ask, team A can give their answer, and it will move on like that. Next question will be to team B. So is it all clear? So shall we begin the round 1? So you all have pen and paper ready?
Yeah, so the team to which it's a direct question, you don't shout out the answer until we say the pounds window is closed, right?
Okay. When I say team A, then you can answer, okay? So we'll start. The scorers are ready? Yeah. So we'll start the quiz with the first question. Identify X and Y. They describe the same entity. X was a dermatologist who published his observations from a series of 3 cases in the journal Dermatologist Uschenschrift in 1937, and the same year he presented it at the meeting of Dermatology Association of Paris. One of these patients went fully blind. Eventually, ophthalmologists had begun to accept the disease, but dermatologists kept denying the new disease, insisting they could be symptoms of known diseases. Y was an ophthalmologist who presented a unique case with 3 major signs during the annual meeting of Medical Society of Athens on November 15, 1930. In 1946, thrombophlebitis was identified as the 4th major sign. Identify X and Y clearly. You should write what is X and what is Y. If you mix up both, you don't get any answers. X you should write clearly, Y you should write clearly. Please raise your hands who are pouncing. No. It's only either full 20 or 0 or minus 20. See, you have to say who all are pouncing. No one is pouncing? Okay. MMC, now you can answer the question.
Is Y Hulisi Beshed?
What about X? Okay. Anyone from the audience? The answer is wrong. Okay. So none of the teams who have no one has pounced. So MMC gets 0 and other teams also don't score anything. Anybody from the audience? Okay. The answer is X is Beshe. Beshe was a Turkish dermatologist. Y is Adamantiadis, who's an ophthalmologist. So it is Adamantiadis Beshe. So this is the answer. Now team B, CMC, this is your question. Are you ready? Identify X and Y. In the early part of 20th century, autoimmune rheumatic diseases were considered to be caused by unknown infectious agents. Based on this idea, molecule X, pioneered by Koch and Kitasato for the treatment of tuberculosis, were widely studied in rheumatic diseases. These molecules were widely popular and used many decades before their regulatory approval. McPherson Brown, on the basis of his observation of mycoplasma-like structures in RA synovial fluid, proposed treating patients with Y. Identify X and Y. How many teams are, don't answer CMC, how many teams are pouncing? Any team that is willing to pounce? You have another 15 seconds to decide. Time up. Anyone pouncing? Okay, now no one is pouncing. So CMC, you can give the answer. You have no negative marking. You can try. But you have to give the answer now. 30 seconds are done. No more time to think. You know the answer, you don't know? Don't know. Okay. Anyone from the audience? Sir? No, sir. Anyone else? Right, Y is minocycline, X. Very good, X is gold and Y is minocycline. Audience got it right. So we'll move on to the next question. Team C from Care Kochi, this is your question. The average American daily diet in the 1980s contained 1 gram of X, which was more than necessary for the nutritional needs of most. But based on its precursor role in the synthesis of an important neurotransmitter, it was used to treat diverse conditions like insomnia, premenstrual syndrome, obesity, drug withdrawal at doses as much as 15 grams daily. Soon after its widespread use, a peculiar syndrome Y characterized by debilitating widespread pains was reported in thousands of patients, and in more than 98% it was linked to consumption of supplements containing X. Identify X and Y. 30 seconds of pounds window opens now, and Team C, wait for the answer. Don't answer now. Time over. So Care Cochin, you can give your answer.
X is L-tryptophan.
Okay, what about Y?
Eosinophilic myalgia.
Yes, give the correct answer properly.
Eosinophilic myalgia syndrome.
Right answer. X is L-tryptophan and Y is eosinophilia myalgia syndrome. Yeah, Team E has also pounced correctly, so both Care Cochin and SRMC Chennai get 20 marks each. Next is Amrita Cochin. This is your question. Identify X and Y. The first clinical description of this disease was done by Jonathan Hutchinson at the Blackfriars Hospital for Diseases of Skin of London. This patient complained of purple symmetrical skin plaques on the legs, hands, that gradually developed over 2 years. He named it Mortimer's malady after one of his patients. A Norwegian dermatologist, Caesar Boyd, thought his patient's skin lesions resembled Mortimer's malady and decided to call it X because they resembled a soft tissue tumor. Another dermatologist, Besnier, named it YZ, 2 words. However, neither Y nor Z is related to X in any way. Y is exacerbated by sunlight, while Z by extreme cold. Identify X, Y, Z. Yeah. Team A has pounced. Anybody else wanting to pounce? I think time is enough. Okay, the pouncing window closes. Only Team A has pounced. Now you can answer, Amrita Kochi.
YZ is lupus pernio.
Right, what is X? But you'll only get the full mark if you tell the X.
Condylomolacta. Condylomolacta.
No. So Amrita Kochi does not get any score. So X is sarcoidosis. So it resembles a soft tissue sarcoma. So that's why soft tissue tumor, they named it as sarcoid. And Y is lupus and Z is pernio. Okay. But when you know lupus pernio, X you should automatically say it is sarcoid, no? So now the question goes to SRMC. This is your question. This is about events that happened in 1980s as narrated by Mark Feldman. This strategy was not widely accepted initially to an extent that a UK company that had developed and tested X for sepsis without success could not be persuaded to redirect their efforts towards testing it in rheumatic diseases. But fortunately, ex-colleague Jim Moody, when he became chief scientist at Centocor, now part of J&J, worked with us and supplied the, at that time, rare and precious X. The rest, as they say, is history. The first trial of X in rheumatic diseases was done by Y at Charing Cross Hospital, London. Identify X and Y. SRMC, wait for the answer, 30 seconds. Anyone willing to pounce? Time up. No, anyone willing to pounce? No. SRMC, your answer.
This is TNF inhibitor.
Okay, what TNF inhibitor?
Infliximab.
That's right. What about Y?
Y is Ramnath Mani.
Okay, I think we'll give the mark because infliximab was right, Maini was also right. So Y is Ravinder Maini, not Ramnath Maini. So we'll give because most of the answer is anyway right. You got Maini right. So we'll move on to the last question for the team from Bangalore. How is XY immortal today? She was born as a Loretta Pleasant in 1920. Her family does not know when her name changed to XY, but she was given the nickname Henny. She had 3 children. Her last child, Zachariah, believes his birth to be a miracle as he was fighting off the cancer cells growing all around him. She died soon after the birth of the child in 1951, aged 31. Who is XY? Anyone willing to pounce? One team has pounced. The answer is in the question. Bangalore, do you want to answer? Okay, one team has pounced. Yes.
Henrietta Lacks and HeLa cells.
Perfect, perfect. Henrietta Lacks, HeLa cell line. Team A, MMC has also got it right. So now, by the time the scores are compiled, we'll go to the audience questions for round 1. X is one of the earliest diseases to be described as a clinical entity by Greek physician Hippocrates. Galen linked it to debauchery and intemperance. X is derived from the Latin word Y. Y is referred to the prevailing medieval belief that an excess of one of the 4 humors would, under certain circumstances, drop or flow from blood to tissue. Identify X and Y. Audience, anyone? Yes. X is gout. What is Y? Y is gutta. Gutta is a Latin term for gout, which means to flow, drop. Okay, so next audience question. X was first identified in Tanzania by Marion Robinson and Lumsdenan. They named X after Kimakonde word meaning to become contorted. Subsequent authors apparently overlooked the references to the Makonde language and assumed the term to have been derived from Swahili, the lingua franca of the region. Some of the best studies about the natural cause of X come from the islands of the Reunion in the Indian Ocean and the Guadeloupe and Martinique in the Caribbean Sea. Identify X. Right, chikungunya. Chikungunya means that which bends up. So right answers from the audience. The last audience question, identify what is he talking about. J.C. Jennett wrote after a landmark meeting in a town in North Carolina in 2011. So I think you can read this. It's quite lengthy about Shakespeare's Romeo and Juliet. Basically, this passage is about What's in a name? The name Romeo and Juliet, the entire tragedy that befell Romeo and Juliet were precipitated by perceptions and prejudices resulting from their names and classes. So what is J.C. Jennett talking about in this? Anyone? Any of the teams? Yes, you can tell in the mic if you know. Audience, and no one is answering, so you can.
Classification of vasculitis.
Yes, what vasculitis were they talking? It's about naming, no? So this was about renaming Wegener's granulomatosis as granulomatosis with polyangiitis. Okay, so this brings us to the end of round 1.
Score.
So the scores at the end of round 1.
Okay. So Team A from Madras Medical College and Team E from SRMC both are leading with 40 points. Team C from CARE Kochi and Team F from St. John's are in second position with 20 points each. Team B from CMC and Team D from Amrita are yet to open their scores.
Okay, so we'll move on to the next round. A big round of applause to Sundaram for preparing round 1 for very unique questions about trivia. So moving on to round 2. Round 2 is called mystery box. So all the 6 teams, you can see 6 mystery boxes in front of you. So you can select the mystery box that you want to. You don't have to blame that you got a tough question. Somebody else got an easier question. So you choose your fate. And each question is 20 marks. You only get either full 20 or 0. No negative marking, but the question will only pass to the audience. Okay, this is a really tough round. Let us see how many of you are able to crack it. Okay, so we'll start, since we started from Team A, now we will start from Team F. So from Bangalore, you can choose any of the mystery boxes that you would want to.
4.
So you want to choose mystery box number 4. So once I open the mystery box, you have 30 seconds and you have to answer after 30 seconds. Audience, please remain silent even if you know the answer, please. Your 30 seconds starts now. Identify the classical condition based on the flow cytometry in a male patient with generalized lymphadenopathy. Time up, you have to give your answer. No negative marking, you can try.
Pass.
Okay. Anyone from the audience? Who said Alps? Fantastic, that's the right answer. This is autoimmune lymphoproliferative syndrome. The peripheral blood of this patient shows an expanded population of CD3 T cells, and which are negative for CD4 and CD8, double negative. The population of the double negative T cells should be positive for alpha beta T cell receptor. So this is autoimmune lymphoproliferative syndrome. Okay, so mystery box 4 is gone. Now SRMC, you can choose.
Sir, 6.
6. Okay. So mystery box 6 is open. Identify the cell cycle in which the given cell is in. The red arrow marked cell, what cell cycle is it in?
Telophase. It's
What is the answer?
It's telophase.
A wrong answer. Anyone from the audience? Anaphase. Who said anaphase? Ma'am, fantastic, ma'am. That is anaphase. So you can see the chromosomes. Now the sister chromatids are pulled by the spindle fibers and they are at the 2 opposite poles. So this is an anaphase cell. What pattern is this? This is Numa pattern. Okay. So no marks for SRMC. We'll go to
5.
5. Okay. So your mystery box is open. Identify the optical technique given below. Time up.
Nephrometry.
Wrong answer. Definitely it's not going to be nephrometer. Anybody else from the audience? No wrong answers. Anyone from the teams? Okay, this is surface plasmon resonance. This is an optical technique for proteomics, where they measure the plane polarized light when it hits a metal film under internal reflective conditions. Due to the strong antigen-antibody reaction, you get a propagating plasmon wave, which is measured to quantify the antigen-antibody reaction affinity. So this is a newer technique which is used generally for proteomics. So if somebody has done a study on it, I think you will know. Most of the papers now discuss about this technique, surface plasmon resonance. Okay, so we'll move on to the next. Care, Cochin, which box do you want to select? 1, 2, 3 are remaining. 3? Okay. Identify the marked structure on musculoskeletal ultrasound. Posterior thigh, short axis. You have the clues. You'll have to identify the exact structure. And you have the clues. Time up. Answer, please. If you do not know, don't know. At least can you dissect what are the structures there which are shown? Anybody else also? Anyone else who knows MSK ultrasound? It's all written, no? What is all there? Semitendinosus, semimembranosus, adductor magnus, conjoint tendon, biceps femoris. So what is left? Sciatic nerve. That is the right answer. So that is the Mercedes-Benz sign. Okay. Okay, now the question. CMC, 1 and 2. 1. 30-year-old male, progressive weakness of the left upper limb, left shoulder joint, decreased range of motion, swelling, no tenderness. See the X-ray, MRI, make a diagnosis. I want a diagnosis. Inside the mic, into the mic.
Charcot-Satrapathy.
That's the right answer, Charcot-Satrapathy. What is the second image? We give full marks to CMC Velour. What is the second image?
MRI spine is showing myelitic.
What does it show?
Myelomyelitic changes
It's a
there.
compressive myelopathy which is causing the weakness of the...
That's a syringomelia. You can see the syrinx there. Right? So Charcot-Satrapathy with the syrinx. So full marks to CMC. Okay, MMC, you have only one box left. We are opening the box for you. Identify this immunological test. All of you know the test, but I am not sure how many of you have seen the image. Time up. MMC, your answer. MMC, you have to answer. No. Anyone from the audience, because the question passes to the audience. Not immunoprecipitation. Yes. It is double immunodiffusion. So this is an immunological technique to detect and quantify antibodies and not and antigens. So mainly we do this for ENS. So MMC has not answered. So now, before they compile the scores for round 1 and round 2 and tell us the top 5 teams which are progressing to round 3, we'll have some audience questions. Identify the critical part of immunofluorescent microscope which is marked red. Yes? Yes, I heard the answer. Dichroic mirror, that's the right answer, dichroic mirror. Last audience question, what is your diagnosis? Very easy. Answer from the audience? That is calcific periarthritis. You can see the deposits in the SASD bursa. This is calcific periarthritis. Observe closely. It's a straightforward one. Okay, so now, before we move on to the next round, so can we have the scores and the top 5 teams?
Team A from MMC and Team E from SRMC are topping with 40 marks each. Team B from CMC Vellore, Team C from CARE, and Team F from St. John's. All of them have 20 points each. Team D from Amrita have not scored, and hence they are eliminated from this round.
Well done, team from Amrita, for participating. You don't have to go. You can stay for the entire quiz here. No one needs to leave. Okay. So, big round of applause for Amrita team for participating. Okay, so now we move on to round 3. And for round 2, a big round of applause to Dr. Abhishek for giving the toughest round. It's a very tough one actually, but really well done. So now we move on to round 3. These are my questions. This round is called shots. In this round, the basic concept of this round is you miss 100% of the shots you don't take. So now you know which team is leading and which team is trailing. So example, now if the question is directed to team A, say now MMC is a question is directed to them, MMC can choose any one team whom you want to target. So you can take your shot on any one of the teams that you want to. You can choose the team. You also get to choose the topic. So I'm going to show you a set of topics and you will select the topic also for them. And if the team that you choose gives the right answer, they get plus 20, you get minus 10. Okay. But if they don't give the right answer, then you give the right answer, you get 20. But if you don't give the right answer, you don't get any negative marking. Okay. So you have to play here smartly, whether you're going to choose a weaker team or a stronger team. Because you can go into negative if you choose a strong team, and you can get more marks if you choose a weaker team. It's up to you. So MMC, we begin with you this round. Yeah, a team can be targeted only twice. So each of you will get 2 opportunities to target someone, and you will get targeted only twice. So that we'll make a note of. So MMC, this is your turn to target. So the topics are immunology 1 and 2, rare rheumatology 1 and 2, pediatric rheumatology, pharmacology 1 and 2, outcome measures 1 and 2, ANA pattern. So you can decide which topic and the team whom you want to target. MMC team?
Rare rheumatology 1.
Okay, rare rheumatology 1. But let me warn all of you, what looks difficult may be easy and what looks easy may also be difficult. Okay. Now, which team do you want to target?
Team F.
Team F, okay. So, Bangalore, your question is rare rheumatology 1. You have 30 seconds. You have to connect the images shown and make a diagnosis. Connect all the 3 images and make a diagnosis. Your clue is rare rheumatology. Time up. You do not know the answer, so you get minus 20. MMC, if you answer, you get plus 20.
Is it MRH?
Fantastic, that's the right answer. So multicentric reticulohistiocytosis, can you describe what you see quickly?
Nodules in the ear.
Yes.
Erosive arthritis of small joints of the hands.
Right.
And this one, I guess.
Yes, you have histiocytes with eosinophilic and ground glass cytoplasm and arthritis mutilans. So this is MRH. So MMC gets the score and minus marking for Team F. CMC, this is your question. You can choose. What topic do you want to choose? Quickly, please make it fast. Team and the topic.
Immunology 1.
Immunology 1, and who's the team you're targeting?
E.
E. Okay. So the question is to SRMC now. Immunology 1. So these three put together come under dash. You see 3 immunological cells here, they all come under dash.
Antigen presenting cells.
Right answer. They are the antigen presenting cells. So you have the dendritic cells,
Dendritic
B
cell,
cells and the
macrophage and
macrophages.
B cells.
Fantastic. That's the right answer. So you get minus 10 and SRMC gets plus 20. Now the question goes to Team C. Choose the opponent and the topic. Team B. So you are selecting Team B topic. Speak into the mic. Pediatric rheumatology. So CMC, this is your question for pediatric rheumatology. Connect the images and make a diagnosis. Time up. CMC.
Juvenile recurrent parotitis.
Please speak. All of you, please speak into the mic. Everyone needs to hear.
Juvenile recurrent parotitis.
No, that is the wrong answer. No, there is no pass. No one gets any score. Anybody from the audience? Yeah, sorry. I'm so sorry. You get to answer. Yes. Yeah.
Angelman syndrome.
No, that's a wrong answer. Now the audience can answer. The right answer is from here. Yes, this is cherubism. So what you see, cherubism, you can see the characteristic fullness here. This is a destructive fibro-osseous lesions where there is expansile growth in the maxillary and mandible region. It's called cherub because the kids resemble innocent paintings, the cherubs who are obese from the Renaissance. So that's why it's called cherubism. This is a self-limited disorder, comes under autoinflammatory syndromes. So it is there in the textbooks from your standard textbooks. Okay. So SRMC, topic and the team whom you want to target.
Outcome measure 2 MMC.
Okay. MMC. What is this outcome measure? Clinical is hyperlipidemia, arterial hypertension. Lab, ACL, anti-beta 2 GPI, APS, PT, and LA. Total score is 20.
No.
Time up MMC,
Pass.
you don't know the answer. So MMC gets minus 20. SRMC, do you know the answer?
I can try.
You can try, but whether you try, if you get it right or wrong, you can try. Anyway, you don't get negative marks.
International thrombosis score.
What score?
Thrombosis score.
Obvious it is thrombosis score. What score is it? What is the name of the score? Anyone
GAPS.
from the audience?
GAP score. GAP score.
GAPS, yes. So GAPS is Global Antiphospholipid Antibody Syndrome Score, which is combination of the APLA test along with clinical conventional cardiovascular risk factors, hyperlipidemia, especially they are using it in SLE. So many trials are coming out with the GAPS score. Okay, now Bangalore, you get to choose the team and the topic. I think you should be ready fast.
Rare Rheumatology 2, Team C.
Okay. Team C, this is your question, Rare Rheumatology 2. Connect the images and make a diagnosis. If you know the answer, you don't have to wait for the time to finish. If you know the answer, you can say. Okay, time up.
Brucellosis.
Exactly, right answer, brucellosis. So can you describe the images or was it a guess?
Osteo.
Louder into the mic. So that is the Pedro Pons sign where you see L4 destructive lesion with a parrot beak appearance. And this is the city of Malta and this is the undulant fever pattern. So this is brucellosis. So they've answered it right. So they get plus 20 and Bangalore get minus 10. Is it clear? Yeah. Okay, now again MMC, this is your turn.
Which one? Pharmacology. Pharmacology 1.
Pharmacology 1, whom do you want to target?
Team E.
Team?
E.
E, okay. Now all have been targeted once, fine. No, yeah, right. So Team E, this is your question. Connect the images and tell the name of the drug used in rheumatology. You have clues to make, to identify this drug. Time up. SRMC, you need to give the answer. So SRMC doesn't answer, so they get minus 20. MMC, do you want to answer?
Is it Selexipag?
Right answer. Selexipag is the right answer. So just describe the images quickly.
IP receptor
Yes,
agonist. And
Selexipag selectively targets the IP receptor.
Triton study was triple therapy versus double
Triton
therapy,
study.
including
And what is this 200, 400? That is the dosage. So it comes as 200, 400. You have increments of 200 micrograms. So this is Selexipag, right answer MMC. So MMC gets SRMC is minus. CMC,
ANA pattern.
Okay.
Team C.
Team C, okay. Team C, are you ready? Identify this ANA pattern.
Topo 1 pattern.
Wrong answer. CMC, you can answer.
SCL 70 pattern.
Wrong answer. Anybody else? Anyone from the audience? Okay. Okay, PCNA pattern. This is proliferating cell nuclear antigen. So what you see here is some cells are stained, some cells are not stained, and you can also see some discrete speckled pattern here and there. So this sort of a pleomorphic staining is very characteristic of PCNA pattern because the antigen is not expressed throughout consistently in the cell cycle. Only 30 to 50% of the cells react. So this is PCNA pattern. Team C? Okay, Team F, topic?
Pharmacology 1.
Pharmacology 1 is over.
Sorry, pharmacology 2.
Team F, identify the drug. Team F?
Not.
You not answer?
Pass. We're not sure, sir.
Okay. You can still answer if you're not sure because anyway you're going to get minus if you don't answer.
Win Christians?
No, wrong answer. No, you can answer. Team C.
Colchicine?
Colchicine is the right answer. So what that is meadow saffron or Colchisium autumnale. That is the plant from which colchicine is derived, and this is the microtubule that colchicine targets. So interestingly, there was a criminal, Catherine, who used these plants to kill many. So she was a serial killer. She used this plant to kill many. So it has got very high dose of a colchicine alkaloid in it. SRMC?
Immunology 2, MMC.
MMC, Immunology 2 question for you. So identify this structure in immunology. I want you to give a specific answer. The whole structure, what it is. Time up, MMC, you have to answer.
MHA class 1 molecule.
Wrong answer, MMC.
MSc class 2.
Right answer, SRMC. So this is MHC class 2. You can see the peptide binding domain. I've given you the clue there. See, in class 1, peptide binding domain, the structure is different. Okay, it is open here, it is closed. Okay, so you can see this is alpha 1 and beta 1 in class 2. In class 1, it is alpha 1 and alpha 2. Okay, so this is MHC class 2. So SRMC gets plus 20, MMC gets minus 20. Okay. Okay. So you have the topic is only one topic is left.
Team E, outcome measures 1.
No, team E has already been
sorry.
targeted. Yeah, only B is left.
Team B, outcome measures 1.
This is your outcome measure. Identify this outcome measure based on the clues. I think read through, don't give up. Read through the outcome measure, you will know the answer. Yes. And you should be definitely telling this. Time up?
Chris
Yes, right answer. Chris is the right answer. Chris is composite response index in systemic sclerosis. So this is a step 2 of Chris, and step 1 you have the organ involvement. So So before the scores are being compiled for this round, we have some audience questions. Audience, what is this drug? Yes, who said that? Iguratimod. So the trials are from Asia. Structure is very similar to an NSAID. Mechanism of action, you can see cytokines, NF-kappa, beta, immunoglobulin, COX-2, NSAID-like and anabolic bone metabolism. So this is Iguratimod. So next audience question, identify this pattern.
Yeah, you're right.
Yeah, right. Multiple nuclear dots pattern. So you can see discretely countable nuclear speckles, 6 to 20. The associations are NXP2 and SP100 for primary biliary cirrhosis. Okay, we move on to rapid fire. Before that, we'll have the scores and the top 3 teams who are entering the rapid fire.
So this round has caused a lot of changes in the scoring, in the standings, sorry. So Team E, SRMC, is in first place with 60 points. So they made a total of plus 20 in this round. Team A, MMC, is still with 40 points. So they made no gains in this round. They had 0. And they are in second place with 40 points. Team C, CARE, is again with 20 points. They made no gains in this round at all. Team B, which is CMC Vellore, they lost 10 points in this round, and now they are at 10 points. And Team F, St. John's, they unfortunately lost 60 points in this round, and they are at minus 40. So the top 3 teams which will be progressing to the next round are Team E, SRMC, Team A, MMC, and Team C, CARE.
Well done to the top 3 teams. And the other 2 teams also, big round of applause for participating. Lots. Now we'll have the lots for rapid fire. So the 3 qualifying teams for the rapid fire round, please take the lots because your questions will be based on the set that you take. So we have 3 sets. 1 representative from each team can take your set. Okay, let me explain the round. The time starts after reading the first question. Question can be passed, can go back if time permits. Abbreviations will be considered only if complete and accurate, and the decision of quizmaster is final. So irrespective of your scores, you can win or lose just by your excellent performance in rapid fire. Because every question carries 10 positive mark. If you give wrong answer, you'll get -10. But if you choose to not answer, you will get 0. If you say pass, you will get 0 for it. But in your time, if you still have time, you can go back to the question that you have passed and you can answer it finally if time permits. Okay? But since the questions are different, but still there's similar pattern, who has got set 1? Care will stay. Set 2 and set 3, they will leave the hall. Just so that you don't strategize according to what they have done. Yeah, 2 and 3, please leave the hall. You will be called back again. You just escort them back, please. Set 1 is Care. So Care, are you ready? Only one person should give the answer, and if the first answer that comes out is wrong, then it is wrong. Okay? So you trust your partner, and whoever wants to say the answer, please speak into the mic. So Care, are you ready? So we'll let you know your time, okay? So we're going to start. Question number 1, expand the abbreviation Asia.
Pass.
Be louder.
Pass.
Second question, name the drug used in Aurora trial.
Oclosporin.
Right answer. Which test is used for lunate dislocation?
Pass.
Wrong, name the positive regulator which stabilizes alternate pathway C3 and C5 convertases.
Pass.
Tocilizumab belongs to which pregnancy category medication?
Next. Pass.
Name the radiographic view used for impingement conditions.
Pass.
Familial granulomatous synovitis is also known as?
Blau syndrome.
Right answer. Purpura, weakness, arthralgia. What is this triad?
Melzer triad.
Right answer. Knuckle, knuckle, dimple, dimple sign is seen in?
Pass.
Autoantibody protective for severe radiographic erosions in rheumatoid arthritis.
Pass.
You have 30 more seconds. Expand the abbreviation Asia.
So 10th question, RA 133.
Right answer. 10th question is right answer. Anything else you want to take up which you have left? Test for lunate dislocation, abbreviation for Asia, tocilizumab, radiographic view. Time up. Okay, we can call the set 2, we can call it. Set 2, right? Yeah, set 2 is SRC. SRMC, only one person will speak into the mic. These are not your questions, okay? So your questions will come now. So one person speaks into the mic clearly. You can go back to the answers if you have left, okay? And if you give a wrong answer, you get -10 straight away. So this is your rapid fire set 2 for SRMC. Expand the abbreviation DITRA.
Deficiency of 36 receptor antagonist.
Right answer. Name the drug used in B-mobile and 1 and B-mobile 2 studies.
Pass.
Which test evaluates iliotibial band for contracture?
Pass.
Name the negative regulator in complement pathway which inhibits C1RS and MBL-associated serine protease.
C1 esterase inhibitor.
Right answer. Apart from duloxetine, which other SNRI is approved by FDA in the treatment of fibromyalgia?
Milansepram.
Right answer. Name the radiographic view which evaluates the glenoid for evidence of a bony Bankart lesion.
Pass, sir.
Devick's disease is also known as?
Neuromyelitis optica.
Right answer. Encephalopathy, branch retinal artery occlusion, sensorineural hearing loss syndrome. Diagnosis?
Sir, pass.
Pass. Characteristic.
Suzak syndrome.
Right answer. Characteristic Meescher's radial granuloma is seen in?
Pass.
Autoantibody in JDM associated with lipodystrophy.
NXP2.
Wrong answer. They've given one wrong answer. You can go back to the questions you have not answered. Which test evaluates iliotibial band for contracture? Radiographic view for glenoid? Time up.
Bimekizumab is B mobile 1.
Time up. You've answered after the time is over. Okay, so we can call the next set 3. So going back to the questions that they've left, Asia is autoimmune inflammatory syndrome induced by adjuvants. Aurora trial was right. Which test is used for lunate dislocation? Anyone? Murphy's test. Tocilizumab is category C. Radiographic view for impingement condition is Rockwood view. Knuckle, dimple is pseudo hypoparathyroidism, and the other question was right. So set 2, the answers that were given wrong are bimekizumab that he told last. Iliotibial band for contracture is Ober's test. Radiographic view is West Point view. Meescher's radial granuloma seen in erythema nodosum. The autoantibody is anti-TIF1 gamma. Okay. So set 3. MMC, only one person has to give the answer. And if you give the wrong answer first, then you will lose the mark. So answer properly. You can go back to the answers which you pass later. Okay? So this is not your set. Your set will be shown now. So you're ready, MMC?
Yes, sir.
Yeah. Your time starts now. Expand the abbreviation of DIRA.
Deficiency of IL-1 receptor antagonist.
Right answer. Name the drug used in MIRA trial.
No, pass.
Test useful in differentiating synovitis of PIP joints from intrinsic muscle tightening.
Pass.
Name the TNF family cytokine which acts as soluble decoy receptor for rank ligand.
Pass.
Fresolimumab targets which cytokine?
Pass.
Name the radiographic view which assesses the humeral head for a Hill-Sachs lesion.
Pass.
Appetite-associated destructive arthropathy is also known as?
Milwaukee shoulder.
Right answer. Non-syphilitic interstitial keratitis, vestibulo-auditory dysfunction. What syndrome?
Cogan syndrome.
Right answer. Sleeve sign is characteristically seen in?
Pass. We'll come back.
Autoantibody associated with lupus hepatitis.
Ribosomal P antibody.
Right answer. Go back to the questions which you have not answered. Name
9.
the drug used in MERA trial.
Can we go to 9?
Yes, you can. You can choose to answer anything. You have 20 more seconds. MIRA trial, synovitis, fresolimumab. Time up. So the answers that you missed. The drug used in MIRA trial is mepolizumab. Test useful in differentiating synovitis of PIP from intrinsic muscle is Bunnell test. TNF family cytokine, this was an easy one, osteoprotogerin. Fresolimumab also was easy, TGF beta. Radiographic view is Stryker notch view. Sleeve sign is anti-MDFI dermatomyositis. So these were the questions that you didn't answer. Now, before the final scores are being compiled, we'll go to the audience rapid fire round now. Anyone wants to answer from the audience? Drug used in pilot study in a multi-drug resistant rheumatoid. It's being discussed all 3 days now.
Peresolimab.
Bite engager, Linat to Mumoba. Expand buses, Belgrade ultrasound enthesitis score. Femster's triad is seen in?
Tuberculosis.
Right answer. Most common monogenic autoinflammatory syndrome?
FMF.
Yes, FMF. Characteristic Woody hands is seen in? Palmar fasciitis with polyarthritis. The trials Begin, Beam, Beacon were done for which drug? Baricitinib. VJET study using etnacept was done in which condition? GPA. Name the spirochete which can cause large vessel vasculitis. Treponema pallidum. Name the anti-neoplastic drug causing scleroderma-like disease. Bleomycin. The Clayton-Hoffman procedure is a salvage procedure for advanced forefoot rheumatoid deformity. That completes the quiz. Thank you all. Before we announce the winners, so we have the top 3 ready now. So with 60 marks, Care Cochin comes 3rd place. With the score of 80, MMC gets the 2nd place. The score of 100, SRMC gets the 1st place. Very well done to all the teams for participating. I hope the audience liked the quiz. Thank you all. Thank you for participating. Thank you. Can we have a group snap? You can just. I would like to call all the quiz masters onto the dais so that we can have a group snap with the participants. Yeah, whoever is there. Abhishek.
As part of the organizing team, I would like to appreciate the efforts of all the quiz masters, Balaji sir, Bhunesh sir, Abhishek sir, Aparna ma'am, and Vignesh sir, who is not here, for their efforts in making all the questions, taking the trouble to attend all our Zoom calls. Thanks a lot.